arterial cannula are tip, body and connector. This is the three standard parts of a cannula. Look at the tip. If the tip has a single hole, you have a cannula with a single hole. See, this cannula has a single hole. So the single hole cannulae are arterial cannulae. Exceptions like this one. This is a peripheral cannula. Voice gaya. They want to disperse the blood. See that cannula which this gentleman is holding. What's your name, dear? Nihal. So hold it up. See that single hole. So this you say in your mind. You don't say, sir, it's a single hole. That's why it's a, don't say like that. So single hole arterial cannula. This is the only exception. There is another aortic cannula which disperses the blood volume rather than blood coming out in a jet, and what is called sand blasting effect. Amma, okkarma, you can sit down. What do you say in Kannada? Sit.
Yes, sir.
If a girl standing next to me, I become very hot. Very hot. No AC. Okay? So, see this cannula, what this gentleman is holding. What's your name, dear? Abhishek. Abhishek is holding a cannula with multiple holes. So, that's a venous cannula. Okay? Got it so much? Now, all cannulae are recognized by the tip. Correct? So, the tip could be plastic, tip could be metal, tip could be metal, tip could be straight, tip could be curved or angled. Whatever word, don't worry, these are the words which we have created. So, immediately don't try to correct yourself. Okay, what you have said is perfect. So, what is the full name of this cannula? Pacifico, you tell afterwards. Allow examiner. This is a KM, typical KM student. They have got so much of knowledge, they want to come out with the knowledge. So before examiner thinks these questions are very tough and difficult and intelligent, and if you answer them quickly, you are in trouble. Okay? So what is this cannula? From that classification? Curved, metal tip, venous cannula. Understood? Which he has revealed. This was invented by Al Pacifico, which now he has told the name Al Pacifico. I will ask him why it was called Al Pacifico, why he invented. What is this cannula? Full name, Anil Gangadhar Sadashiv Tendulkar. If you say Anil, Anil Kumble also will come. If you say Tendulkar, Sachin will come. Anil Ambani also can come. So best tell the full name. Curved, plastic tip, venous cannula. Very good. Your cannula? Straight plastic tip, arterial or aortic cannula. Now he called it arterial cannula. See that hub. See that hub? Because of that hub, you can't pass it into an artery. In fact, the idea of that hub is to stop from going too much inside. So it is classic aortic cannula. Okay? Have you understood the names of cannulae? Now let us come to body. Body could be wired, body could be unwired. See this, unwired. Okay? So what is the advantage of wiring? This is called built-in wiring. What is this wiring? Built-in wiring. Obviously there was a type of wiring in the olden days which was outside the cannula, which you could remove and throw away. So exactly like your books which are wire bound books. So exactly like that, correct. So this cannula had that type of wiring. This is built-in wiring. Okay? You cannot remove it. What is the advantage of that? Prevent kinking. And usually the aortic cannula is fixed in position. Moment you do the aortic cannulation, you immediately take artery forceps or towel clips or ties and arrange the entire system in a curved, smooth, curved manner, right? So arterial cannula doesn't require wiring, but still we have got arterial cannulae which are wired. Okay? What is the disadvantage of wiring? Since yesterday somebody was constantly telling you that something is told, it has a negative problem also. So how this wiring is done? They dip it into plastic and take it out. Again dip into the plastic and take it out. So there are layers of plastic around. So wiring increases the thickness, wall thickness. So one word you must always know and keep on throwing again and again. Yesterday Dr. Sitaram Bhatt told you 4 anatomical facts of tetralogy fellow. You keep on talking again and again. Is this ID-OD ratio. ID-OD ratio. So what is ID? Internal diameter. What is OD? Outer diameter. So what goes inside is OD. And what blood flows is ID. So we are more interested in ID. We are not interested in OD. What's your name? Varun. What is the relation between diameter and flow? Now these are the questions which you are able to hit for a 6 even at the midnight. Varun to me looks he has not taken bath. Huh? How I diagnosed? Huh? You are taken. Okay, then you are not put. What is the relation between diameter and flow?
Directly proportional.
That is the correct answer. He gets full marks. So this formula you must know for your lifetime.
What is this law?
So flow is proportional to 4th power of diameter. So what is the 4th power of 2? Everyone is searching for calculator. 16. What is 4th power of 3? 81. So 2 millimeter becoming 3 millimeter, the flow increases 500%. 16 to 81. 1685. 500%. That is the reason, right from anesthetist, tube, neckline, surgeons, valve. Many times we think, why is he fighting for 19 versus 17 valve? Huh? Some first year resident may be thinking, my boss is mad here. 17 was going very easily. He wanted 19. So it is 4th power of 17 and 4th power of 19. I am not mathematician, but must be a great difference. Understand? So remember your lifetime. And another formula which Prasanna was asking you, fluid conversion of Ohm's law. So that is Ohm's law is voltage is equal to current multiplied by resistance. So voltage is replaced by P, I is replaced by flow, and resistance remains resistance. So Paul Wood was a clinical cardiologist who invented this new formula for resistance by simply putting millimeters of mercury into pressure, that is 100, flow 5 liters, and resistance comes as how much? This resistance will be 20, and this is called Wood units. Very easy to calculate on table, very easy to calculate in ICU. On pump, very easy to calculate because pump flow is known that particular moment. Pressure is known that particular moment. So immediately you can calculate the resistance and decide whether to start a vasodilator or a vasoconstrictor or increase the flow to maintain the pressures. Understand? So just remember this, ID-OD ratio. And the third part of the cannula,
This wiring which is there, this wiring in the tube is circular, this wire is circular. If you go in for the other cannulas now, they have made the wire flat.
yeah, that is next gen cannula.
To increase the ID.
To optimize the ID-OD ratio. When we discuss next gen, we'll talk about that. What is this part of the cannula called? No, this part of the cannula, whole length. Clamping site. Okay? Medtronic knows that you are going to into raise to n cannula. So They have given you a port for clamping. And last is connector. Now, I think that cannula has a connector. So, what's your name you said? Nihal. So, Nihal, use your fingers. No. Hold the cannula in one hand and use your fingers, give me. Use your fingers as tube and you pass like this and try to pull it out like this. And tell the gathering what you feel. Correct. Now, correct. That's a tube. You are inserting the, friction. Inserting the tube. Insert. Now try to remove out. It won't. You know this or don't know? So these serrations are arranged in such a manner that you can insert the tube, but you can't pull out the tube. You require slitting of the tube to disconnect the cannula. And this connector is called built-in connector. Built-in connector. You can take the name of your head of the department. If you're married, take the name of your mother-in-law and pull all your force, but this connector cannot be removed. Okay? As against that, this will require a connector. Correct? And nowadays you can get all sorts of connectors in permutation combination. Straight, Y, 1/4, 3/8, half, any combination. 1/8, any combination you can get it. So what is the importance of connector? Connector means what? From perfusion point of view, from surgeon's point of view. Connector means what complications can happen. Always think about complications. Then you don't face them. If you don't think about the complication, you will face them. My boss was so good, every stitch I used to take, you say, AV node gone, circumflex gone. Every step he will tell me. Nothing happened anytime. But he will remind me, circumflex gone. He will declare. So I said, shall I remove? No, okay. AV, oh my God, this was AV node. This is aortic leaflet, you have taken. Gone, this case is gone. Like that he will keep on reminding me of every step. So you must know all steps, all complications. So what are the complications associated with connector? Disconnect. Disconnect is a very obvious, very subtle leaks. Or air sucked, he is talking microbubble. Sucked in or sucked out? Depends upon the pump head direction. Air can be sucked in, blood can leak out, infection, burst. So this carries that danger. This cannula carries that danger. While this one, which Nihal is having, is built-in connector, no chance of that problem occurring. Okay? Understood everybody? Now we shall start with individual cannula. Chal beta, tere se. So why this is first question, why this is metal tip? Hold it up, let everyone see. Everyone may not be using it. Why it is metal tip? Why it is metal tip? Why not plastic tip? We have got plastic tip. So metal, because of its stiffness, offers better stiffness even in thin wall. While plastic, to make it stiff, you require thick wall. The result in ID-OD ratio. And who is Pacifico? Which part of the world? Do Pacifico, America and Alabama. And he's a pediatric surgeon. And those days we used to do pediatric operations on circulatory arrest. So he didn't want to circulatory arrest. Circulatory arrest, the restriction of time, bleeding problems. So he said, I will do it on bypass. But if you do on bypass and put this type of cannula for an infant, which will be 3 or 4, something like that, this will result in tremendous amount of resistance. So he developed this cannula, which is a metal tip. Okay? So because of metal tip, ID-OD ratio, and there was one cannula, Amma, where is that very small cannula you had? Pacifico cannula, one of you is having? No? Anyway, there is one cannula which very small, I think 3 French or 5 French. That small cannula. Do some exercise in the morning, stand up next to me. Okay, Pacifico cannula. What are the side holes for? Loudly. Side holes for? No, I will hold. Side holes for? Now this should be fata. Sir gets bored. Sir says, क्या इन लोग पैसा पूछते रहते हैं anatomy? जल्दी बोलो. Anatomical question.
To prevent complete collapse of the vein on one side.
No, that is the end hole. End hole, if the vein collapses on the side hole, blood flow should continue. So there is end hole. I am asking, what are the side holes for? Side branches. So what is the side branch of SVC? Azygos. And? Which innominate? Left. Vein or artery? So, my God. So answer should be left innominate vein or left brachiocephalic vein. What about IVC? Hepatic veins. Okay? Let me ask you one notorious question. This is SVC cannula or IVC cannula?
So I think it's an IVC cannula. Size is 28.
So how much he gets? He will be asked to come back after at least 1 year. Is there anything like SVC cannula, IVC cannula? Anil Tendulkar's SVC cannula will be his IVC cannula. Just depends upon the size. Which is bigger, SVC or IVC?
IVC is bigger.
Why?
Because it has 70% of the flow.
66% flow, 33% SVC. So bigger cannula will be for IVC, smaller cannula for SVC. Okay, now look over this blue line. Can you see this blue line? What is this blue line for?
Indicates the direction of the tip.
Very good. Blue lines indicates the direction of the tip of the cannula. So if it is SVC, who should be seeing this blue line? Anesthetist, if they are still present, not gone for coffee. Sorry, you are here. I can't comment on anesthetist. See today no car pickup today. And if it's IVC, my Sinmol, Joe Moore, who is next to me, my scrub nurse, she should see this cannula. After that, what is written down?
The company, Medtronic.
Medtronic. And?
The size, 28 French.
28 French. So what is 28 French?
Is the internal diameter.
You are ensuring that you fail. And then if I fail you, all of you said, Tendulkar was transferred from KEM, so he has got khunnas against KEM. That's why he failed me. Yes, correct. Nihal is getting just gold medal. You are from which institute? Jaydeva. No wonder. Before your boss comes, you finish all your answers. Your boss comes with all gadgets attached to his body. So what is formula for circumference? Ayyo. Nihal, moment your eyeballs go into left upper quadrant, that means I know you don't know. 2 pi r or pi d. So if you consider value of pi as 3, because we are clinicians. And what is this size, French? 28. So 28 divided by 3. Now 3, 27. 9 millimeter or less than 9 millimeter will be the diameter. So French corresponds to, my dear, with insertion of balloon pumps, swan guns, and cardiac surgeons want to become interventionists. This French convergence should be absolutely, you should be knowing. These are the things which straight away take you in that sap shidi, snake and ladder game directly to the bottom. Then you will say, I only said that and this happened. So that just creates bad impression. What is this? In some cannulae, there is a white slot over here. That's for tying. That's for after SVC cannulation, tying. Okay? Chalo. Now, he being from KM, I like to trouble students coming from KM. So describe either SVC cannulation or, so cannula part is over now. Now you want to start surgical part or finish all the cannulae?
So let's finish the cannulation with this SVC IV. So there-
Cannulation or cannula?
the cannulation with this particular.
Cannulation with this cannula. Chalo. All of you, combined effort, spearheaded by him, SVC cannulation. Bolo. You must have a pro forma. Since yesterday, I am telling you, you must have a pro forma.
Can
So
you give a mic
simple,
to him?
Start
Mic.
preparing the pro forma. This is pro forma for all cannulations. So SVC cannulation is prior to something or after something? After aortic cannulation. So no need of discussing ACT. Understood? Because aortic cannulation already done. First SVC or first IVC?
First SVC,
Why?
so it can decongest the heart and
Cha.
you can go on to single
No.
Students who are answering, please use the mic.
you
Online
require-
people can't hear you. Students, you answering, please use the mic.
Okay.
Give the mic to him, hello.
Exposure is easy, it's right ahead, so
So SVC is easily seen. Where IVC requires retraction of RA. And moment there is retraction, there is decreased venous return, hypotension. So SVC pulse string and SVC cannulation always done first. Chalo. Anything about pulse string?
using trioproline.
Trioproline,
multiple
even for baby or for all patients?
for adults.
For adults. Very good. So show your maturity now. I will appreciate, he says, trioproline for adults. Very good. So now you can hold it. At Narayana, anybody from Narayana? Narayana? So you always do thioproline, I'm told? Huh? They always do with thioproline. Okay? I vary according to the case. Redo, babies, friable, congestive cardiac failure, foroproline. Okay? Very good.
I take multiple bites in a circular fashion.
No, don't tell me now I put needle holder in the center. ऐसा उतना detail का जरूरत नहीं है. Any shape of that pulse string?
Pentagon.
No. U-shape. U-shape. I take elliptical pulse string in the long axis of SVC. So if this is SVC, it's an elliptical pulse string in the long axis of SVC. So when I tighten the pulse string, SVC is not narrow. What structure you will take care of?
SA node.
SA node. How do you know SA node is
The
here?
yellow pad of fat between the RA-SVC junction.
Very good. At RA-SVC junction, the pad of fat. Excellent. Pulse string taken. Now,
Where is the pulse string taken? Between the innominate and the SA node, where you take it?
2 millimeters above the SA node.
what is this?
Pericardial
Pericardial
ion
fold.
reflection.
So just below this pericardial fold, you take. What is the anatomical landmark of this pericardial fold? At the junction of pericardial and extrapericardial, SVC, azygous vein opens. Absolutely fixed landmark. So, if you take a pulse string here and put your SVC cannula, the side hole will be draining the azygous. Okay. Pulse string taken. Chalo, फटाफट बोलो यार.
Take a horizontal stab.
Now, why you want to take horizontal stab?
Sorry, vertical stab and then
Don't say vertical. Correct word is longitudinal.
longitudinal.
And what you think, my dear, SVC, like just now I carry a stab knife and I bring it near you, what will happen? तू क्या पंजाब दा पुत्र है ऐसा खड़ा रहेगा दम है तो डालो मेरे तो तू क्या करेगा ऐसा होगा ना. So what is SVC pressure? 4, 5, 6, 7 millimeters of mercury. Correct? So what will happen if you try to stab?
double puncture.
It will not stab. So what do you require?
Forceps.
Forceps, 1 or 2?
2.
See, all these things you are supposed to speak.
Yes, sir.
तुम क्या बोलेगा बाहर जाकर? अरे क्या मैं बात करते गया. So examiner is asking you all this. So all these things to be told. So what instruments you require before cannulation? 2 forceps. 1 to the assistant.
One for you.
Bad one is given to the assistant and good one is given to the surgeon. Okay? And according to the quality of SVC. With baby, you may ask for even fine tip DeBakey forceps. Now you put most important is to lift the SVC rather than stretch the SVC. Most of the assistants, particularly in KM hospital, they are interested in seeing. So they are the protector of the patient. So they are seeing the mitral valve like this, and surgeon is seeing the mitral valve like this through the head and shoulder of the patient. So always pull it up. Then comes the stab incision. And what you do? Don't just puncture it. The whole idea is not to give a bindi. You make a saw-like movement. Okay? Next.
You introduce your dilator, the artery forceps.
Not your dilator.
The artery forceps as a dilator.
Examiner will do the job of dilating. Okay? So you ask for an artery, long or short?
Long, sir. Short.
From anterior to posterior, what are the structures just for your knowledge? First is aorta. Next is SVC. Next is ... IVC. And last is short instrument, short scissor, short suture, short needle holder, short, everything short, everything long. Okay? Done. Dilated. Next.
Introduce your
Where is that cannula?
the cannula.
How do you introduce? You are the surgeon, and you are introducing. Show.
And my left hand.
Your left hand, forceps, I am your assistant, we are holding it up. How do you introduce?
I will spread my side and I will introduce it towards the head end of the patient.
Okay. Some people introduce straight away like this. I prefer to introduce. This is a very easy movement for a surgeon, okay, for any human being. Wrist flexion. So I introduce like this and then rotate it towards SVC.
He is the surgeon. This is the SVC that side.
So he introduces like this. I introduce aortic cannula also. Some surgeons use like this, some surgeons do like this and then rotate it inside. So introduce like this and rotate it inside. Okay? Now the lot of blood will come, you will not able to see. So what will you do?
We'll ask the perfusionist to go suck us.
Why perfusionist? Keep the suction. Suctions are already on. Aortic cannulation are done. So in format, you must always mention where do you keep the suction. What type of suction is you required? No, you require a stiff macro tip suction, which you wrongly call Yanker suction. Correct word is stiff macro tip suction. Some suction is already there in the pericardium at the bottom. So any cannulation, you will tell the order. If you have aortic cannulation, you will tell your ACT plan. Without this, we will not do. At your institute, nobody is going to challenge it. Nobody is going to laugh at it. What is the sequence? What instruments are required? Which blade is required? What order it is done? Okay? Gone inside. How do you know you are in the center of SVC?
Make sure that the line points towards the...
That tells you the direction of the tip. How do you know you are inside the SVC lumen? What complication can occur? He can go into the adventitia. Many people first dissect the adventitia and see a black glistening SVC and then only puncture it. So how do you know? Sorry, he is answering. Your name? Sharad from Jaydeva? Very good. Sharad? Column of blood will move. Column of blood, column of blood. How much will be the column? How much low? CVP. So you should say according to, and you don't have to search very CVP. The monitor is right in front of you. I'm sure in Jaydev also, there is a monitor right in front of you. So as many millimeters of mercury, that many centimeters of water. And column will go up and down with inspiration and expiration. Inspiration, expiration. So these three, same thing will be for aortic cannula. How do you know your aortic cannula is inside? I don't know whether transesophageal probe is used for this. I don't know. But I am not from the era of transesophageal probe. Are you using? Prasanna sir has not started using for transesophageal probe? No? Okay. You insert a cannula
Sir, who made that?
and a level. Sorry?
The voice was yours only, sir. The change of voice.
No, I don't know. Who talked like that? I thought he's very angry. Huh? He's the devoted bhakta of. You insert a cannula and blood level starts rising. अरे जल्दी बोल यार. He's looking at it. Clap लगा रहा है.
Connected to the wire.
Remove and do what?
Change the cannula
Two.
to higher, larger size.
Ayo amma, why it is rising? Why it is rising? No, CVP is 2 to 3. You have done sternotomy. In that sternotomy, lot of blood loss has taken place, and you are told her not to use blood. If you use blood during sternotomy, khalas, इज्जत का सवाल. Arey, you have put too big a cannula. So all the blood from SVC has no other place to go but to rise in the cannula. So what you should do? A smaller size cannula. Remember, your perfusionist gives cannulae just from his or her judgment. There is no formula. Am I right? There is no formula for calculating how much SVC is. They just say, sir, 24, 28, I too. Then so it may not be 24. Okay? Which SVC is actually small but looks big? Left upper quadrant, everybody's eyes? Huh? No. Yes. But LSVC, it looks small also and is small also. I am asking, looks big but actually small. PAPVC into SVC. It will look big. So you'll tell the perfume, bada, give 28. So you ask for 28 size, but actually not more than 22 will go. So if you cut this pericardial fold on SVC beyond right superior pulmonary vein, you will actually see the size of SVC. Okay? Understood? Sir was yesterday's virtual class was asking, a patient is for bicaval cannulation, and moment you start taking pushing for IVC, BP falls. What will you do? Release the heart. In the Tukaram Dondu in the ward, in the OT, they will also tell you. Plus, our friends are there. So how do you go partial bypass? IVC line. So first attach a wire. To that you attach SVC and IVC cannulae. How do you attach SVC IVC cannulae? Like Charlie Chaplin. Understand? Very important. Don't attach like this. Attach like this. So when you hold it, the cannula should look like this. Okay? Or Raj Kapoor, I don't know which one you like. Okay? Understood? And now you clamp IVC. Why you have to clamp? Air will be sucked in. This is siphon. What is the venous drainage? Siphon. So air will be sucked in. Very good. So go on bypass. You have gone on bypass. Perfusionist says, I am on full. What will you check? RA collapse. Don't talk something which others are checking. I am asking you. RA should be collapse like this. Anything else? MPA. MPA also should be collapse. Which case MPA is not collapse? VSD. This is that shit. Now straight away, because of shit, you have come straight away through the snake to 0. PDA. Number 2, if a patient's LVDP is high, moment you go on bypass and start cooling or temperature is already low. What is temperature of the perfusate, by the way? Before starting bypass?
No, that'll be 37.
Arey, OT temperature. What is OT temperature? (18 to 22 degrees centigrade), unless she keeps it purposefully warm, which she will do in a case of redo for release of adhesions. Moment you go on bypass, patient starts cooling. Tight MS, LV contractility decreases. Slide, LA pressure goes up. Dr. K.M. Cherian first is to put an LA line before doing any case, any cannulation. So keep a watch on RA and MP. RA is, perfusist says, I am on full. But RA, what will you do? Sorry? Now I am going to ask you which cannula? Venous cannula. Which venous cannula? IVC cannula. Most common is IVC cannula. The tip has wedged into the hepatic vein. So just go on pulling millimeter by millimeter. Where are you looking? Where are you looking at? Not Anil Tendulkar. RA. Moment you see RA, stop doing that. Again you'll have to tie. Okay? Any other questions, sir, on SVC
The
cannula?
IVC cannula. Now, he is the surgeon. This is the IVC opening. How will he insert the IVC cannula? Can anyone come and tell us?
Yeah, come. You want to show?
Anybody can show. Take this as you are the surgeon. This is that. Yeah, stand and show everybody. How will you insert?
And my finger would be over it.
Then?
No, sir wants to see the inner movements, I think.
Yes, inner movement.
Somebody hold the mic for him, please. One of you, the
Take
sound.
your left hand out.
Hold a mic, please.
So I would ask you to
No. 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 Rotate how?
Around the lateral wall.
Yeah, so you insert it into the right atrium and it goes anti-clockwise into the IVC. Why not clockwise?
Station tube में. Now I hear it properly. So not station tube, but station
Put it like this and then you rotate it.
on the lateral wall.
Then it will go inside the IVC. Never clockwise because the valve will get caught.
Okay? Sir, continue. Huh? Now quickly cannulae, each and every cannula.
People are asking for cannulas. Yeah. Rather than the cannulation techniques,
Acha,
they are
online
requesting for
people mean
cannulas.
Students.
Students,
I thought teachers.
No, student.
So Shiv Chaudhary from Delhi is saying cannula now.
Yeah.
Okay, what is this? Ostial cardioplasia cannula. Which ostium? Left. Why? The angle is almost straight. And why you cannulate, give cardioplasia in the left first? Very easily seen. That is the first answer. Number 2, majority of the blood supply, LV is by left. Very good. Why this tip is, what is beauty of this tip? Atraumatic. Anything else? Feel it. It's compressible. It is compressible. Okay? Compressible. Don't compress like this. Compress like this. So what is the advantage? Even if it is a bit big in size, it can be easily inserted. What is this surrounding circular disc-like structure? Not hold it. Oppose against the aortic wall and prevent any reflux. Prevent any reflux. This is non-malleable. Okay? Once I said non-malleable, and one of the student, like his size, immediately, like Arjuna, he broke the, and I had to pay for the cannula. So these are decent strength people. I see a lot of students with lot of strength. So remember, cardiac surgery is not for strength. My boss reminded me constantly, any dissection around a vessel, moment you have to use force, you are in the wrong plane. Ductus, IVC looping, SVC looping, it should be without any force. Okay? How much cardioplegia is given? At your center? 60%. No, aortic cannula, coronary cannulation? 60-40. Okay. Heart stops immediately or doesn't stop immediately? Doesn't stop immediately. Heart stops immediately after giving into RCA. Because RCA has got SA nodal band and AV nodal branch, which immediately results in electrical arrest. But RCA is difficult to visualize. How do you visualize RCA opening?
Located outside you.
So assistant locates from outside. It's a search rescue mission. Surgeon everts the lower lip of the aorta, and assistant in the region of anterior region just puts a middle finger, one single finger, and invaginates into aorta, and you see RCA ostium. Okay, so that cannula, this is malleable incidentally. This is malleable. So this can be malleated according to the cannulation site. I think one person had right angle cannula. One person had right angle cannula. Okay, so this is for RCA. So more angle is RCA, left is almost like a straight line. The speed also is slow. Now very standard question after aortic cannulation, as a surgeon, what will you check? General. Yesterday Prasanna was telling, root cannulation. What will you first check? Aortic, root pressure with your thumb, right thumb. Next hand goes around the heart. What are you checking? LV distension, not distending. Next, what will you check? Coronary arteries. Which coronary arteries are seen by the surgeon without lifting the heart? LAD. RCA branches are seen. So RVA branches, acute marginal. LAD, if you are lucky, you will be seeing. LAD will require lifting the pericardium and that. How the artery will look like? Full and red. How does the vein look like? Black. And slowly over a period of time, it turns into same color as the coronary artery color. Okay? Heart stops is the last part. Even if you don't give cardioplegia, heart will stop. So heart stop, that will stop for permanently. But heart stop should be the last answer. Okay? Chalo. Any more about?
What else for the proper delivery of the confirming the delivery of the cardiac?
Cue the mic, please. Hello.
So which situation RA is open? Already opened. KEM. They want to do more cases. Anesthetists are standing with a watch. Sorry, 12 o'clock. Now we can't give you open heart, like that. So we are constantly racing against time. Which cases RA is open? While cardioplegia is on? ASD closure. क्या सोचते बेटा? Which cases you do bicaval cannulation? Huh? Whenever right atriotomy, right ventriculotomy, bicaval cannulation and looping SVC, IVC and snugging or snaring. Second indication? Ayo. Mitral valve replacement. You want to do mitral valve surgery, not replacement, surgery, you must have bicaval cannulation. When we discuss that, you will discuss. Chalo. Nihal, I want your cannula. Chalo. This is, look at Nihal's cannula. Plastic, straight plastic tip, straight plastic tip, aortic cannula.
Yes.
And what is that
It's
one?
wire
No,
reinforced.
behind just the tip,
It's the hub.
it's a hub to ensure that
That's
too
a
much
limit of
cannula doesn't go inside. It is adjustable or non-adjustable?
Non-adjustables.
Non-adjustable. So you may have a, do you have a cannula, Amma? Straight plastic cannula with a adjustable? No, acha, this one. This is not a classic one. It has a adjustable. See this adjustable. So you can decide how much it will go inside. This is not. So what is the danger of not having a hub?
You might hit the posterior if you push it and
When examiner asks you this hub, he wants a particular. Yesterday, Prasanna is telling you again and again. Every question has a catch phrase which you have to tell quickly. Selective arterial cannulation. So which artery will be selectively cannulated? Right brachiocephalic or innominate artery will be cannulated. You may not be knowing as to
Called the guard or the hub, the guard.
various names are there. Some call it butt also, not but. Okay. So this is aorta. This is how the branches take origin at a tangent to the circle. This is how engineering is built in our body. So this flow straight away goes like this. This is at a tangent. This is at a tangent at that spot. So classic is this. So you are supposed to adjust by seeing your purse string side and the innominate origin. So if this is the situation, I make sure this is not long enough to result in selective cannulation. By chance, if you put a smaller one, perfusist will say, oh good, no resistance, I can give flow, everything. But all that 5 liter flow will go into one side of the brain. That's the biggest problem of selective arterial cannulation.
Can that cannula go to the ascending aorta?
Sorry?
Can that cannula, when you put it, can it go to the ascending aorta?
Descending this.
Instead of here, going here.
It is possible with curved aortic, curved metal tip cannula.
How
It
many
can go
of you are
towards the-
left-handed surgeons? Yeah. That is the problem. If you try to do your aortic cannulation with the left hand, possibility of it going to the ascending aorta. Right-hand surgeons don't do it, but left-hand surgeons, be careful that if you're trying to do it with the left hand, it goes into the ascending aorta.
So just like the DLP venous cannula, can you see this? Can you see this blue line? अरे निहाल हाँ ना बोलना, आपको बोलना बहुत जरूरी है. So this bevel should be directed towards. Your girlfriend is anesthetist. Huh? So descending aorta. This bevel should be descending aorta. Descending aorta is a silent area of emboli. All our intercostal arteries, all our intestinal arteries are silent area of emboli. Lots of collaterals, a bit of clots, air bubble, kachara, calcium, particulate matter, here and there won't matter. At the most, patient will have some pain here and there, that's all. Okay? So, each company will produce this marker accordingly. So, quickly you must see, good morning sir, hi. So, quickly you must see this marker is pointed towards what? This marker in this cannula is pointed towards the toe. Toe. Some company pointed towards the heel. So this line will be seen by, as you rightly said, by anesthesiologist. Okay? And should be lying like this. Tell me quickly, based on the same format, aortic cannulation at your center. Yes, the mic.
I would heparinize the patient, 300 to 400 units per kg, and once ACT is achieved
Not
of
300, 400, either 300 or 400
300 units per kg, sir.
per kg.
Per kg,
dose.
yes.
Okay.
And once achieving a ACT of 450, I would start taking the purse
There are
strings.
various ways of doing. At KM hospital, olden days, we used to give heparin and start taking purse string. So purse string taken started, heparin given. Because the ACT tubes those days used to cost 18 rupees. Those plastic tubes, 18 rupees was we used to charge princely 150 rupees for a CMC. And patients used to say can't afford. So those days used to cost 18 rupees. So what we used to do, start purse string, moment purse string is started, anesthetist will give heparin. So don't wait for that. Some places they wait. And what is the ACT level required for starting suckers, cannulation?
300, sir.
250, 350, 450, approximate, okay? So starting suckers, 250, 350, 450. That does not mean you are going to do ACT 3 times. Just letting you know. Moment is the 250 plus, sucker is put on, 350 plus, you start doing aortic cannulation.
Cannulation, yes.
Number 2, anything about aortic pressure?
I would want the pressures less, systolic less than 100 systolic, sir.
Yeah, so go on talking
I would
like
like
that.
100 systolic. I
Done.
would take
Three, prerequisite, 3. You look, check for.
plugs and
So
calcium.
my boss I used to tell my boss, sir, no calcification. He used to tell me, Arey, in Marathi, starting with bho, the calcium has already gone to the brain. While you were palpating, the calcium is already released to the brain. So do you do any epi-aortic screening?
So based on the X-ray, we can, based on the X-ray, if you see some
X-ray is very
calcification.
bad, very poor sensitivity. CT is better. So you can say in an elderly patient with evidence of atherosclerosis at multiple spots, not only coronary with renal, coronary with carotid, diabetic, hyperlipidemia. These are the high risk patients, high chance of having calcification. Okay.
I would use a 4016 suture,
For
two purse
purse
strings,
string.
two purse
Very good.
strings, one purse strings.
And what is the adjective of the purse string? How many purse strings? 1 or 2?
Two purse strings, one towards the surgeon.
So what is called concentric?
Concentric.
Two concentric purse string.
Yes.
Adventitial purse string.
As distally as possible. What
Yes.
does it mean? Stop? Stop? Okay. As distally
sir.
as possible.
With one snugger ending towards the surgeon side and one snugger ending
And the
towards
purse string should be diagonally opposite. One towards surgeon, one towards assistant. At KEM, we used to use this curved metal tip cannula. And this metal tip cannula has a flange, this shape. And this is the tip. And this tip should be directed towards arch of the aorta. So this automatically purse string on the aorta should be 4 o'clock and 10 o'clock. So this is 4 o'clock and this is 10 o'clock. So these flanges will go here and the tip automatically directed towards arch of the aorta. How do you define arch of the aorta on the patient? Left shoulder of the patient. Then
Once the purse strings are taken, I would
you check the flow. And how should be the flow? Catchphrase, free flow.
yes.
How much free? If SVC cannula was according to CVP, aortic cannula pressure
Based on the
should be
systolic
according
pressure.
to
Systolic pressure.
systolic blood pressure. Simple, should be free.
Yes.
Understand? Then you know it is inside. Or nowadays, transesophageal echo to see whether the tip is inside or not. And then you connect. Thank you very much for a patient hearing, and thank you for being present at 8 sharp in the morning.
Thank you, sir. That was the reason why we had kept your talk at 8 o'clock so that
That,
we
that
activate
you
this.
keep because I am available at 8 o'clock. Keep this separate and keep.
I
that
now
separate.
request Dr. Shiv Kumar Chowdhury
So in
to
case we get a
render
chance,
his lecture on basics of aortic surgery
Keep
for our
these separate.
residents. Dr. Shiv
Keep this
Chowdhury
separate. No, separate
is
is
retired
with him
professor
only.
and head of Department of
Mukunda,
CTVS at
if we
All
get
India
a
Board
chance,
of
we'll
Medical
discuss that.
Sciences, New Delhi. He is presently Executive Director of Aortic Surgery at Fortis Escorts Heart Institute, New
Ma,
Delhi.
Sarupa.
Dr. Shiv Chowdhury, please.
Good afternoon, friends. Aortic diseases have become one of the major health problems globally. In US alone, it is 10th commonest cause of death, and similar is the situation in India also. As such, the aortic surgery is a large topic, so it won't be possible to cover in 20 minutes time. So I chose one of the most important topic and the real emergency in cardiac surgery for our young residents, and that is acute dissection. Acute dissection, you can say it is the death personified. What happened in dissection? The blood enters in the layers of the aorta. It enters in the layers, that is the media. We know that the aorta is made up of three layers, the intima, media, and the adventitia. So blood enters between the layers of the media, and then it propagates distally and proximally. For clinical purpose and for type and various classifications have been proposed. So the commonest classification what is being followed clinically is a Stanford classification that is based on the segment involved, not based on the location of the tear. So in type A aortic dissection, it is the intrapericardial part of the aorta is involved, that is root and ascending aorta. It may extend distally anywhere, but if the intrapericardial part of the aorta is involved, it is type A dissection. In type A dissection, the remaining part of the aorta may be involved other than the intrapericardial part of the aorta, that is type B dissection. From point of view of duration, acute aortic dissection is up to 15 days from the onset of the pain. Subacute dissection is from 15 days to 90 days, and chronic dissection is after 90 days. So, what happens because of dissection? Three major things can happen which determine the symptoms and the course of the disease. Because blood enters in the layers of the wall, so the wall of aorta becomes weak and it may subsequently rupture, causing even massive hemothorax or pericardial tamponade and death. We all know that the aortic valve is attached to the intima of the aorta. So when the this intima separates from the media in the root of aorta, this aortic valve cusp will prolapse and will cause aortic regurgitation. And similarly, if the dissection process involves the branch any branch which is arising from the aorta, it may get narrowed down and may get occluded. So all the clinical presentations and the natural history depends upon which segment and which branch is involved. You can see this, the blood has entered into the layers and subsequently this false lumen is expanding. False lumen is the newly created lumen. We call it false lumen. The original lumen is called true lumen. So this false lumen will expand and ultimately it may give way, causing massive hemothorax or pericardial tamponade. And when it ruptures into pericardial cavity, it will produce pericardial tamponade and ultimately patient will die because of pericardial tamponade. As I mentioned, the aortic valve may prolapse, and because of that, there may be severe aortic regurgitation. The branch vessels which are arising from the aorta can be compromised. This false lumen is entering into the coronary artery here and it's compressing the true lumen, so patient may present with features of coronary ischemia. Similarly, when the false lumen is entering into the origin of the arch vessel, one of these arch vessels may get occluded and patient may develop stroke because of that. Here we can see that the one of the renal artery is compromised because of the false lumen entering into the one of the renal artery, and patient will present renal arteries are involved. Going distally, the one of the iliac artery may get compromised because of the false lumen involving the origin of the iliac artery, and patient will present with features of acute limb ischemia. Similarly, the mesenteric artery, superior mesenteric artery may be involved, and this may lead to acute mesenteric ischemia and hemodynamic compromise. Following the natural history, what happens? In first 24 hours, because of the dissection and its related complication, nearly 40% of the patients will die. At the end of 1 week, nearly 75% of patients are dead if a proper intervention is not done. And at 1 year, only 5% of the patients are alive after acute type A dissection. So it's potentially lethal condition, and in first few hours, or I would say first 48 hours, are very crucial, because if a proper surgical intervention is not carried out, the mortality is very high. How these patients will present? An acute aortic dissection is just like 10-headed Ravana, Dasanan, and it may present in different forms. So let's see what may be the clinical presentation. The most common and the consistent clinical feature is pain. Pain would be depending upon whether it is type A or type B. A type A pain usually starts anteriorly in the retrosternal area and then it travels to the back, whereas type B pain usually starts in the back and the abdomen. The character of the pain is very peculiar. It will be sudden in onset, severe pain, worst the patient has ever felt in his life, maximum at onset, and then decreases, and its quality will be very sharp, tearing and ripping. The most characteristic thing about the pain is that patient will be able to localize the pain in terms of second. If some patient tells about a pain and very precise temporal localization, that he was at the first step of the staircase, or he was exactly entering at the door of the room and he had pain. If somebody is giving this type of history, then we are sure that we are dealing with a patient of dissection. Sometimes these patients may also have features of coronary ischemia, especially if the right coronary artery is compromised, and these patients may falsely be diagnosed as myocardial infarction, and the thrombolytic therapy may be given, which may be catastrophic. So when we see such patient where history of pain suggests dissection, but the ECG suggests myocardial infarction, then we should carefully evaluate these patients. Because if we give thrombolytic therapy to acute type A dissection patient, the intraoperative bleeding will be catastrophic and we will have problem in that. So how to distinguish these two group of patients? In dissection, the patients are usually younger. There may be some connective tissue disorder, feature of connective tissue disorder, whereas in acute coronary artery syndrome, the patients are usually older and hypertensive. There may be history of angina, and pain localization is in terms of second. The character is very sharp, whereas in myocardial infarction, the pain builds up in minutes to say 15 minutes, half an hour. It's vague and heavy, and the temporal relation is usually poor. And along with that, in patient with dissection, there may be a pulse deficit because of one of the artery, the arch vessel compromise or iliac compromise. There may be differential pressure. The different arteries may show different pressure. Then because of the aortic regurgitation, a wide pulse pressure may be there. If patient has got cardiac tamponade, heart sound may be muffled, or patient may have malperfusion features of any of the arteries like cerebral malperfusion, limb malperfusion, or mesenteric malperfusion. If we have any of these things, then probably we are dealing with dissection. And if a patient is agitated, in a type A dissection patient, if patient is agitated, most probably either he is hypoxic because of acute pulmonary edema or he is tamponading. So it should not be taken lightly. So which investigations are required? Only 2 investigations will confirm the diagnosis and will help in the management of dissection. First is a transthoracic echocardiogram. It will tell us about the presence or absence of dissection. And at the same time, it will tell us the function of the aortic valve, function of left ventricle, and most importantly, if there is any feature suggesting of cardiac tamponade. The CT angiogram is will delineate us the anatomical detail. It will confirm the diagnosis of dissection. It will tell us the extent of dissection, and most importantly, if any branch vessel is compromised, CT angio is the investigation. It will help us to diagnose if there is any hemothorax. But the most important thing is that this CT angio should be a gated ECG gated study. Non-gated CT angio should not be used for diagnosis of an acute aortic dissection. In emergency setting, TE should be avoided because the patient is already in pain and hemodynamically compromised. TE is only done in operative room under anesthesia. Coronary angiogram is usually not required because in acutely dissected patient, an attempt to do a coronary angiogram may convert the dissection into a frank rupture, so it should be avoided. The stabilization includes anti-impulse therapy. It's not antihypertensive therapy. In antihypertensive therapy, our aim is to reduce the blood pressure, whereas in anti-impulse therapy, our aim is to reduce the rate of rise of the blood pressure. So we use beta blocker at the first line of therapy, and vasodilator should never be used in these patients before adequate beta blockade. So beta blocker we can use esmolol or metoprolol, and nowadays we use labetalol. Once adequate degree of beta blockade is achieved, and even then if the blood pressure is on higher side, then we start vasodilator. And our aim in such patient is to achieve a mean pressure of 80 to 90. We don't monitor systolic pressure because in significant AR patient, a patient having systolic pressure of 100 and diastolic pressure of 0 will have mean pressure very low and will lead to coronary ischemia and patient may fibrillate. So we should rather follow the mean pressure rather than the systolic pressure. And in patient with severe aortic regurgitation, heart rate should not be reduced below 60, because if we reduce heart rate further, the diastolic period will be prolonged and the AR will be aggravated. The line of treatment in type A dissection is emergency surgery. So all these patients should be rushed immediately for surgery because that is the only thing which will save the life of the patient. And the aim of surgery in type A dissection patient, I will just summarize. 1. Eliminate the intimal tear in the proximal aorta. Proximal aorta means root, ascending aorta, and proximal part of the arch. Eliminate the risk of rupture of proximal aorta. Achieve a competent aortic valve. Restore true lumen perfusion distally, and correct any malperfusion if it's there. So what needs to be done? Ascending aorta, we always eliminate the ascending aorta. Arch, we fix or replace the arch. Root, again, either we reconstruct depending upon the extent of disease or we replace the aortic root. And in most of these patients, these aims can be achieved by replacing the ascending aorta and hemiarch replacement, plus plus a root procedure if required. So coming to the root, what can we do? If the if the dissection involves only one sinus or it's not reaching up to the annulus, if the valve cuffs are good, if the root is not dilated and AR is less than moderate, then probably we can fix this root with a local repair. And in local repair has got three components: refixation of aortic commissure to achieve a competent aortic valve, obliteration of the false lumen, and preparation of the proximal cuff for distal anastomosis. But if the root is diseased, it's dilated, cusp are not good, if dissection is extensive, if patient has got connective tissue disease, then the root replacement with a composite valve conduit is the procedure of choice. Coming to the ascending aorta is replaced along with hemiarch and in open fashion. Nowadays, an open distal anastomosis is the standard of care and on-clamp anastomosis should be avoided. Coming to the arch, prophylactic resection of the arch should be done in all the cases. And if there is an intimal tear or aneurysm, it should be resected and that will demand for an arch replacement. The third component of arch management is quite controversial. That is prevention of delayed complication of distal residual dissection. This is the step which depends upon so many factors, depending mainly on the infrastructure, surgeon's choice, and the morphology of the distal aorta. Various options in such cases include hemiarch with debranching, which may involve a delayed stent grafting in selected patient, then arch replacement, different type of arch replacement, and stent grafting later on. These arch replacement and hemiarch replacements are endovascular compliant hemiarch and arch replacement so that we can do a stent grafting after a period of 2 to 3 weeks. And nowadays, a good number of centers and good number of surgeons are also doing a frozen elephant trunk in such patients, in which arch is replaced along with the proximal DTA, in which a covered stent graft is placed using a composite device. Even after discharge, these patients are not cured, and a long-term surveillance is required, which needs a regular follow-up, repeated imaging, and very strict control of blood pressure. Thank you.
Thank you so much, sir, for the wonderful presentation. Okay, so the next session is on knowing the guidelines and rules that are a must for any cardiac surgery resident. Rendering the framework on guidelines is Dr. Pradeep Narayan. Dr. Pradeep Narayan is Senior Consultant Cardiac Surgery at Rabindranath Tagore International Institute of Cardiovascular Sciences, Kolkata. He is also Editor-in-Chief of the Indian Journal of Thoracic and Cardiovascular Surgery. Sir, over to you.
Okay, thank you very much. So I'm going to be talking about guidelines in practice. As I'm sure you can imagine, there are several guidelines and it is not possible to talk about all of them, but I have chosen certain important ones, or the ones which I thought were important to talk about today. And I've taken the most contemporary ones, so I don't know how much useful it will be for your practice, but it'll hopefully be important for your exams. whatever we do in practice may or may not match the guidelines because practice is dictated by several other factors that are not accounted for in the guidelines. Anyway, let's start. So to make it slightly more interesting, guidelines are very boring as you know. So to make it slightly more interesting, I've tried to give it a case-based pattern. So we'll discuss a case and we'll talk about what the guideline recommends in that context. And it would be really helpful if you could either enter some responses in the chat box if you're online, or even if you are in the audience, you could sort of give your opinion. So let's start with the first one. So we have a triple vessel disease, 64-year-old. And I just want you to stress on the fact that the right coronary artery has a 70% mid-segment stenosis. Now, the question is, which is the best conduit for this territory? Is it a radial artery? Is it a saphenous vein graft? Should it be a free rema? Or should it be an in situ rema? Or because you don't believe in grafting the RCA, you could graft the PDA and use a sequential lima to graft the OM and the PDA, lima rema Y. So, any thoughts, any responses from anybody? Okay, I can't see the chat box really for some reason, so it doesn't matter. And I can see the chat box, but there are no responses here. So I'll just go and give you the answer. The answer is, if I can move my slide, it is a saphenous vein graft. And the reason is any arterial graft should not be used to bypass a right coronary territory when the lesion is less than 90%. You can see that the recommendation class is 3 and the level of evidence is C. So before we go any further, I think it is important for us to remind ourselves, I'm sure all of us know, that what exactly are these classes of recommendations and level of evidences. So let us take a quick look at the classes. All you have to remember is class 1 is recommended, class 2A should be considered, 2B may be considered, and class 3 is harmful and is not recommended. So if you remember, use of arterial graft in stenosis less than 90% was a class 3 recommendation. Now, what is level of evidence? So level of evidence, there are ABC, level of evidence, level A is the highest, which comes from meta-analysis and several randomized controlled trials. B from a single randomized controlled trial or several observational studies, and level of C includes everything else. So registry data, retrospective studies, expert opinion, everything. Second question. Another patient with triple vessel disease with a reduced ejection fraction, but the patient is now 74 years old and his ejection fraction is 30%. Now, what is the best possible response here going by the guidelines? PCI is preferred due to low procedural risk. CABG can be done, but the survival is uncertain, benefit is uncertain. Or CABG is recommended to improve survival. Or CABG and PCI provide equivalent survival and the decision should be made based on other factors. And finally, medical therapy should be instituted here. Again, I wish there was some form of interaction because it's a rather unilateral discussion here. But the answer is CABG is recommended to improve survival. And you can see the class of recommendation is 1 and the level of evidence is BR. BR stands for randomized trial. So level B, randomized trial. And what is that randomized trial? It comes from the syntax data. You can see that the MACE rates at 5 years with CABG is much lower compared to PCI. There are also some meta-analysis which have been carried out, and that is why the class of evidence is 1. So we have clarified 2 things, triple vessel disease with reduced ejection fraction, and previously we looked at the right coronary artery territory. Now let's move to left main stem stenosis. So here, just to summarize, it's a 59-year-old patient. You can do both PCI and CABG. He has got angina, but he's stable, and his syntax score is 32. What do we do? Anatomy is suitable for both PCI and CABG. So PCI is superior, or CABG can be considered but uncertain benefit, or CABG must be done to improve survival, or PCI should only be done, or medical therapy. Again, the answer is CABG is recommended to improve the survival. It's a class 1 evidence. There is unequivocal data that suggests that in left main stem stenosis, in complex diseases like intermediate and high syntax scores, CABG is the preferred intervention. PCI may be considered if CABG is not possible only in low syntax scores. So that's something else to remember. And okay, now let's move on to ST elevation MI. This question keeps coming in the exams. So you have a patient who presented with ST elevation MI within 2 hours to your hospital, which is capable of both CABG and PCI. What should we do? Should we thrombolize primary PCI, CABG, medical management, or stabilize the patient and do whatever intervention you want a bit later on? Again, these are easy questions, but sometimes in the exam setting it can be tricky to remember. So primary PCI. In general, ST elevation MI, PCI is the intervention of choice. If they come within 2 hours, if PCI can be done within 90 minutes, it produces the best results. It is gold standard. So it is a class 1 recommendation within 2 hours, within 90 minutes for sure. PCI is the intervention of choice. Now let us just make it a bit more tricky. Instead of 2 hours, the patient now presents after 16 hours, but he's still got angina. What should we do now? Should we not bother with PCI or CABG, just keep him stable, or should we do fibrinolysis, or should we do PCI or should we do CABG, or should we discharge the patient? So I'll just give you a second to think, and the answer is still PCI. So if somebody has got ongoing symptoms, benefit of revascularization is there within the first 24 hours, but it should be PCI. But the recommendation, unlike the first 2 hours, now has class 2A recommendation. So first 2 hours is class 1, but after 2 hours, up to 24 hours, it is class 2A recommendation, still beneficial. Let's make it a bit more tricky. The same patient comes to you after 36 hours, but now he is pain-free, he is stable. What should we do? Should we go for still PCI or thrombolize, or now should we do CABG, or we just manage him medically? And here I really want you to pause and think. I know I can't get your answers, but please pause and think and see if the answer matches what I'm going to suggest. So the answer is do nothing. If they have, it's a completed infarct, there is no role of any intervention in this patient at this stage. It's a class 3 recommendation. Now let me go back 36 hours. Now, as I said, there's sometimes the practice and the guidelines are discordant. If you go into your own hospital, you'll find a lot of patients who present on the second day or the third day after ST elevation MI. They get primary PCI, sometimes they might even get CABG. But if they are stable, if they are pain-free, they should not undergo any recommendation, any intervention. Now, let's make it more complex. So the same patient, he comes after 36 hours, but now he presents with shock. What do we do now? Do we manage him medically, stabilize him medically, or do we put a IABP, fibrinolysis, immediate revascularization? None of the above. He is in shock. So now the answer suddenly changes again. So previously 36 hours I said don't do anything, but the patient was stable. Now I'm saying that 36 hours later, if he's in shock, we have to intervene. He needs or she needs immediate revascularization. Shock overrides timing. If they're in shock, we have to intervene. This becomes now a class 1 recommendation. So from class 3, it moves to completely opposite class 1 recommendation. Now, if you remember, here I have shown you an option IABP. Now, almost all of us believe that if somebody presents with cardiogenic shock, the first thing to do is to put an IABP. So let us ask ourselves this question. A 65-year-old man presents with same case, acute MI, cardiogenic shock. I want you to read the options carefully. Routine IABP use improves survival and is recommended. Routine IABP use reduces mortality in cardiogenic shock. Routine IABP use is associated with harm and should be avoided. Routine IABP use is not recommended due to survival benefit. And IABP is contraindicated in all patients with cardiogenic shock. That is clearly wrong, but think of the other four. And believe it or not, the answer is actually routine IABP use is not recommended due to lack of survival benefit. Now, this is not the same as it is contraindicated or you should not be doing it. The stress is on the word routine. So it should not be a knee-jerk reaction that somebody comes with cardiogenic shock, we first do an IABP. No. If we can intervene in terms of PCI, we should do that. If there are specific situations like severe MR or ventricular septal rupture, those are clear-cut cases of putting in an IABP. But it should not be routine. The shock trial, IABP shock second trial showed that it has got no benefit. In fact, it might be harmful. Now, let us go back to our original patient. 36 hours later, he's in shock, and we have decided to intervene. Now we do a PCI, which fails. They cannot put the stent in. What do we do now? Do we put him on medical therapy? Do we repeat the PCI, get somebody else to come and do it? Do we go for thrombolysis, or do we now shift the patient to CABG, or should we say thank you very much, let's discharge the patient? Well, the answer is you go for urgent CABG. You have to, so this is one of the very few indications of CABG. If patient is in cardiogenic shock and PCI cannot be performed, then urgent CABG is beneficial. That's a class 2A recommendation. Now let us go one step further. So on the angiogram, we see that the PCI has failed. There is a small infarct, but the targets are very poor. What do? Do we say, I'm a great surgeon, I'll do a CABG anyway, or should I avoid CABG, or should I make another attempt at PCI, or do thrombolysis? And the last option is wrong. It should be do nothing. The answer is avoid CABG. Because the risk here is much, if the targets are not good, patient is in cardiogenic shock, we are not going to provide any benefit to the patient. In fact, the risks might be higher. Now, this question, probably this is the last one on ST elevation MI. So you have a patient in the village who is quite far. What do? Do we give them aspirin, clopidogrel and transfer to the hospital? Do we carry out a fibrinolysis? Do we refer them for CABG or refer them for PCI? The answer is pretty obvious. I think here you have to do a fibrinolysis and then transfer the patient for either PCI or CABG. So here, welcome to Volkswagen. Sorry? The geography defines therapy. Since we have talked about ST elevation MI, I think it's only fair that we talk about non-ST elevation MI as well. So 64-year-old man presents with non-ST elevation MI. Now let us look at the options. PCI should always be preferred to in non-ST elevation MI if possible. CABG should always be preferred because it's not ST elevation MI. And we have said that PCI has already got all the patients of ST elevation MI. Or the mode of revascularization should be based on disease complexity. Or should we let the patient choose? Patient choice is a buzzword. Or should we carry out CABG only if PCI fails? Again, it would have been nice to know your thoughts, but the answer is the mode of revascularization should be based on disease complexity and patient comorbidities, meaning you don't worry about that the patient has got non-ST elevation MI. If this is a case where you normally do a CABG, you should do a CABG. If this is a case where you normally do a PCI, you should do a PCI. What do I mean by that? If they have got a mid-vessel LAD lesion and a 55-60% RCA lesion, then probably PCI is better. But if they have got a multiple coronary artery lesions, tight stenosis, proximal LAD, left main, high syntax score, then obviously the choice is CABG. Now, we have talked about a lot about CABG and myocardial infarction. Let's see a couple of questions on aortic valve replacement. So 66-year-old man, I should say patient, has got severe aortic stenosis, but he has got no symptoms. He just underwent an office screening as part of his retirement plan, and they found that he has got severe aortic stenosis, but he is completely asymptomatic. He can climb 2 flights of stairs, but they also found that his ejection fraction is 45% and his surgical risk is low. Now, let me tell you that all the 5 options given below are indications for aortic valve replacement in this patient. So previously, 10-15 years back, the strategy for asymptomatic aortic stenosis was to wait and watch. That has now changed. Now the recommendation is if any of these 5 features are there, we should operate on them. But that is not the question. The question is, which of the following is a class 1 recommendation? Very severe aortic stenosis, BNP levels 3 times normal. On exercise testing, the systolic blood pressure falls more than 20 millimeters of mercury. Ejection fraction 45% and no coronary artery disease. Severe valve Vmax is progressing very rapidly. Well, I think you may have guessed the answer. The answer is LV ejection fraction 45%. So anything less than 50% is a class 1 indication. I'm just checking the time because I don't have a timer on my screen. So I think I still have got some time. Second question on aortic valve replacement, and this is quite important because this comes from the most recent guideline. A 73-year-old patient who has got severe symptomatic aortic stenosis. So he's not asymptomatic. This is severe aortic stenosis, low surgical risk, and suitable for TAVI. Now, what is the best management approach here? SAVR is mandatory because he's low risk. TAVI is recommended. No intervention as he's old, he might just well have some medical management and why bother with an operation? Or you delay, as we saw previously, treatment till it develops LV dysfunction. I'll just pause here for a couple of seconds. I just want you to think. 73-year-old, low surgical risk patient, what does the guidelines suggest for this patient? I'm guessing that most of us, quite rightly, should think that SAVR is absolutely mandatory. But actually, no. The most recent 2025 guidelines say that TAVI is recommended. So this age cutoff has been changed from 75 to 70. So anybody below 70 should have SAVR and anybody above 70 should have TAVR. Now this is where I said that what we practice and what the guidelines suggest may not always match, and there are certain external concerns that guide our practice, but this is what the guideline suggests. Okay. Now let us move to some perioperative care which most of the residents have to deal with. Somebody has come for CABG, he's on aspirin, he's 62-year-old. What should we do? Should we stop it 7 days before surgery, 3 days before surgery, or should we just continue it till surgery? Or should we replace it with something like clopidogrel or ticagrelor? Or should we double the dose preoperatively? I think this is an easy question. The answer is you continue aspirin. In fact, it is a class 1 recommendation. Aspirin should not be stopped. And this data comes from several randomized controlled trials. And I'll show you the reason for that is aspirin reduces myocardial infarction and graft thrombosis in the postoperative period. Even after surgery, you're meant to give aspirin within first 4 hours. If the patient is not awake, it should be given through the Rein's tube. It does not increase bleeding and it is very protective in the perioperative period. So aspirin should not be stopped. Aspirin should be initiated as early as possible. But what about ticagrelor? So that's Brilinta. Some of you may know it as Brilinta. So somebody has come, cardiologist, they had a ACS, they were put on Brilinta. When should we stop? Should we continue immediately because we are good surgeons and bleeding doesn't concern us, or should we wait for 12 hours, 24 hours, 3 days, or 5 days? Okay, I don't know how long you stop it for, but the guidelines say that you should interrupt it for 3 to 5 days, ideally 5 days, in an elective situation. In the urgent CABG, where there are concerns, they may have a left main disease, they may have, sort of frequent episodes of ST changes. If you can stop for 24 hours, you should. Otherwise, even that may not be required. So in urgent cases, the recommendation is 24 hours. In elective cases, it's 3 to 5 days. What about, okay, why wait for 24 hours? Because early surgery increases bleeding risk, that's proven. And 24-hour, if you hold, then it reduces the transfusion rates. So there is evidence for both of these things. You can see the paper is quoted at the bottom by Lawton et al. There are 2 papers actually. What about prasugrel? So prasugrel, the patient is on prasugrel. How long before you should stop before the surgery? I'll go straight to the answer. It should be 7 days. This is a drug where you should ideally stop for the longest period of time. 7 days is the recommendation in elective cases. If not urgent, it's easy to remember, 24 hours. So this is a summary. Clopidogrel I purposely didn't go through because you can just interrupt it for 5 days, that's a recommendation, but now it has also been reduced to 3 days. But this is a summary. So clopidogrel 5 days, prasugrel 7 days, ticagrelor 3 to 5 days, at least 3 days. And the interruption for urgent cases is 24 hours in all cases. I think that's the end of my talk. Thank you very much.
Thank you, Pradeep sir, for the lovely talk. The forum is open for questions.
Any questions from the audience?
For example, when there is guidelines between SAVR and TAVI, should the onus of informed choice should be given to the patient?
Absolutely.
So we should let the patient decide between TAVR and SAVR?
So it depends. Like, if you have a 40-year-old and the evidence is in favor of SAVR, the patient should not be given that choice at all. The patient should be told that TAVR is dangerous for you, you should not be having TAVR. When it is borderline, and I say, below 70, I still think you should not be giving the patient a choice because the guidelines recommend SAVR. Between 70 to 75, I think it can be discussed with the patient if they want to go for SAVR or TAVR. But, I mean, it depends. Patient choice is, I think, very frequently misused term. And we say that the patient chose total arterial, the patient chose robotic surgery, or the patient chose TAVR. So it depends on how we counsel the patient, what we tell the patient. If we tell the patient that, look, you are 65 years old and surgical aortic valve replacement is better for you, I don't think any patient is going to go for TAVR. So the discussion should only be in gray zones.
So if we present...
Both should be present when talking to the patient. It doesn't happen.
If we present them with facts, unbiased facts, and let them make a choice, there's no...
Absolutely. So when I'm saying patient choice, I don't mean that don't talk to the patient. We always have to present the evidence to the patient and tell them that we are choosing this because this is good for you. So that patient has to be counseled. All I'm saying is that we should not leave it to the patient to decide. We have to guide the patient to decide.
Thanks,
Thank
Dr.
you, Pradeep sir.
I had a question.
Who has a question? Yeah.
Yeah.
Pranav, the last question.
Yeah, when you have a difference between the American guidelines and European guidelines, what do you do?
So there is not much of a difference. I mean, do you have any specific example?
Not at present, but
Yeah, I'll tell you
earlier I
that.
used to compare the two and I used to find some differences, like
Yes.
valve guidelines,
Correct.
when not to replace an aortic valve. So he says LVEF 45%, LV in ID systolic 45 millimeters. Later we had these criteria that the risk becomes prohibitive when it exceeds these limits. But now they have revised it and changed the numbers. So what was previously permissible is
Right
not
now, there is
permissible.
a lot of consistency between the two guidelines. I think in the recent guidelines, the American guidelines have not been revised since, I think, 2021. That was sorry, maybe I'm getting the date wrong. But basically, right now, there is not much of an inconsistency. They both agree, say 50 to 65 is the gray zone in terms of bioprosthetic or mechanical. AHA says 50 to 65, and that age has come up to 70 in the European guideline. So that is a very borderline case, and I think to a certain extent we have to tailor it to our own population. We have to tailor it to, for example, to give a specific example, let's say the patient is 60 years old. Do we put a mechanical or bioprosthetic? Now, it's a gray zone, but here we also have to look at the survival of Indian patients, the lifespan of Indian patients, which is considerably shorter than the European or the Americans. So I think you have to take your expert judgment based on your experience and patient choice, of course. Here, patient choice becomes very important.
And a possible valve-in-valve TAVR in future.
So valve-in-valve TAVR, I don't think we should even think about it. And I can talk for another 20 minutes on that, because why would you plan the strategy for your operation failing? You should plan a strategy where your operation is for the life. So if you are putting a bioprosthetic valve in a patient who is 70, this will last this patient till he is 85, and he is probably going to die before that. And even if it doesn't die, he may not require a valve-in-valve TAVR. But if you are implanting a bioprosthetic valve in the age of patient who is 40, then you have to think about valve-in-valve TAVR, and I don't think why we should be putting a biological valve in a 40-year-old, unless there are compelling reasons. So I think this lifetime management is a term that has been coined by the industry. I think it's not a good term. See, all our lives we have operated on patient thinking this is the only operation the patient is going to get. Suddenly we are told to think lifetime management, valve-in-valve TAVR. So, I mean, it's possible, but I don't know if we should be thinking in that fashion.
Thank you, sir. Thank you so much, sir, for being with us. Now let's move on to the next session. So just there's just a slight change in the schedule. So we have AI for CTVS residents beyond ChatGPT. So I have the pleasure of welcoming Dr. Karthik Ramesh and Sri Krishna Chandra to enlighten our young minds about the limitless possibilities of meaningful application of AI in daily life. Dr. Karthik Ramesh is a Chief Research and Innovation Evangelist at Sri Madhusudan Sai Institute of Medical Sciences, Muddenhalli, and Sri Krishna Chandra is Chief Technology Officer at Gamma Group of Companies and is joining us from Hyderabad. Over to you, gentlemen. And Dr. Hiramat will moderate this session. Thank you.
So basically today we have Kiran and myself representing the Gamma Group of Companies. And I'd like to ask, also you take the pleasure of, first of all, before I hand over to Kiran for his quick 10-15 minute talk on AI beyond CTVS, I'd like to have the pleasure of introducing Kiran. Kiran basically currently serves as the group Chief Technology Officer. He's also founder of Swecha and General Secretary of the Free Software Movement of India, and known as a prominent technologist and a person who's believing in the community development, both literally and in terms of the open source community, how to facilitate the use of free and open source software, especially in the space of AI. Swecha is a non-profit organization, so beyond his full-time job, he also manages the largest group of over 1 lakh interns who are contributing day in, day out to free and open source software movement. Kiran is also the president of the Forum of IT Professionals. He holds several leadership positions. And currently, most importantly, he's heading Vishwam.ai, which is a center of excellence focused on AI for the global south. So Kiran, without much ado, I would like to hand over to you. And following Kiran's talk, I will specifically deep dive into AI for CTVS. Thank you.
Yeah, thank you very much, Karthik, sir, for a very broad and too much of an introduction. But I think I'm honored to be here to be speaking with the young minds who would be serving the nation, and particularly getting trained under the all the stalwarts and who is who, and the philanthropic ecosystem that you're coming. Your hearts would be definitely there in serving the commons and the people who are completely deprived. And I think, thank you so much for inviting me. And I'm pretty sure that if I ask a question, I would have loved to be there in person, interact with you all, where I could have the feel of the conversation as well. If I would have asked a question, how many of you use ChatGPT? And I think it has become more or less a replacement of our search. Maybe it's ChatGPT, or you go to any search engine today. Initially, if you only just use Google to search, you would be getting a few millions of links that you need to traverse through. And for me to get to the link and go and read and have a look at it, what is the first most thing? It is basically trained on the user behavior. Most popularly, click links surface on the top. So when we are doing in the scientific community, we'll be looking beyond that, and we'll have to go to second, third pages to get the reasonable links for us to be able to understand stuff. To solve this problem, I think we have entered fortunately into the AI age, where the large language models, which are already trained on large sets of information, terabytes of information or petabytes of information, digest it, the data is ingested into it, and they are supposed to basically give us the information out. And here is the catch. This is a new technology, and how do we actually take a scientific look at what this new piece of technology is? From the developmental psychologist study that has come out, and Jan-Lee Kuhn, the Turing Award winner, quite often mentions let us say, if you look at the latest version of the ChatGPT, it has been trained on close to 10 to the power of 15 tokens. So assuming that one token is equivalent to a word, if you or me were to sit and study 8 hours a day continuously with reasonable speed, it would take at least somewhere around 3 lakh years for us to read everything. And when you look at it, ChatGPT is able to, or any of the large language models are able to respond back with such a huge amount of information. And does that mean that it is superhuman? This is the next important question that really comes to our minds. If you look at what happens, there is another study which says that a child who is 4 years old, since the child is born, and he or she basically observes the world for only 8 hours, the visual cortex of the brain that receives information through the eye, it transmits at a speed which is debatable, but assuming that it transmits at 20 megabits per second of information to the brain, the total number of tokens that a child who is 4 years old learns from the world outside by observation, looking at the nature, looking at the parents, looking at the household, etc. The total number of tokens that a brain is trained is close to 10 to the power of 17. If I were to do a mathematical calculation, it means that a 4-year child is 100 times more efficient than the ChatGPTs of the world. So the large language models, when we're using it for scientific studies, we'll have to understand the limitations in which this technology exists and what needs to be done with the technology and how it has to be used. What it effectively does is that it tries to mimic human behavior. It is in the very nascent stages of it. and it basically predicts the next word and gives us the information. And we need to understand that I made a statement in the beginning when I said that with this conversation that we do, it basically looks at all the websites in the internet and it is ingested into the information, has been ingested into it and it gives us back. It is not like that the entire thing is put in a data bank or a database and it deterministically picks out the information that we ask, searches for it and gives it. It does not happen that way. When we feed the information to the large language models, it essentially happens that the information is learned, it gives weights to a certain decisions. Like you all take decisions in surgeries, if a probability of an A event, then you take a B event. Or if there is this kind of a drug combination is going to be ineffective to a patient, this is the drug combination which might work. So there are a certain probabilistic things that is there. So the weights are attached to decision making, and that is how these LLMs of the world give you information which is probabilistic and it is not deterministic. And I think this is the limitation that we need to understand, and we call it as an inbuilt byproduct. We don't even call it as a bug. We call it as a byproduct of how large language models process information. And we call it in one word or the other hallucination. If the LLM does not know the answer, it doesn't say that I'm not aware of it. It tries to predict something which is closer to it. So for the scientific studies, scientific advancements, while these tools are very effective in document processing, making precise summaries, a very good executive assistant for you to basically give hundreds of pages and asking it to give you the summary, etc., etc. Be wary that while doing so, it is very important for us to look at a critical evaluation of how we are using this technology, given its nascent stage of its development. If you look at where we are poised in the large language models of the world today, we are in a very nascent stage of this technology, which is going to become better only day by day, and moving forward, we are going to live with it in a very more close way where we're going to have digital twins of ours which we're going to mimic. And I'm pretty sure Dr. Hiremat's avatar is ready and it was launched recently. Has it been launched, Karthik? It's a digital twin where we basically
launched, yes. Yesterday they launched it, Jaydeep and Tilakya.
So the digital twin of Dr. Hiremat will definitely never be an equivalent to Dr. Hiremat, because the brain dump of Hiremat getting into the digital twin's knowledge base is not just a straightforward thing, and it takes a lot of time to get there. But what is it that the digital twin can do? The digital twin, because I would love to talk to Dr. Hiremat after me getting treated from him, I'm taking it as an example, it could be any other doctor or one of you tomorrow, that if I would like to basically ask a question as a follow-up question, I would definitely not be in a position to meet him, not because that he does not want to meet me, but he's basically busy or engaged in solving the life problems of many people out there. But I would definitely want to have a follow-up question on it, which it might be a pretty straightforward thing for the doctors to respond back. But for me, it could be the biggest problem, maybe on the drug administration kind of a thing, or maybe on a certain kind of an activity that I would want to do after getting treated from him. So these could be some questions which the digital twins can start simultaneously responding back. Beginning from having a digital twin, which is not a social taboo, because we're going to have guardrails and contain the entire technology to limit to it, where we're going to ground the technology to a level where that it doesn't become faulty, or it doesn't hallucinate, or it doesn't predict certain things. So there are new ways of doing it when we basically want to get to that part of it. So digital twins is something that we're going to live with, and I'm pretty sure by the time you all would have reached the success rate of many of the senior cardiothoracic surgeons who are sitting there in the room, who of it are there, you all would be definitely having not just your digital twins, but like a cyborg, you are basically there to understand the entire human biology, and you'll be using the robotic techniques to contain the techniques and see what to do, how it goes. The entire landscape is definitely going to change. Then how do I basically brace for it and how do I prepare for it is an important aspect of it. If I were to make a digital twin of my own, I need to basically have my knowledge base completely ready and documented it for myself, at the least. Because the earlier generations were not prepared for it. Some of the people who are pretty active in the academic sphere only documented a certain number of cases which they thought might be good and valuable for reference, or they could present it in a paper somewhere else. Who had academic interest are the people who actually documented some of these observations and all. But I think documenting every knowledge that we learn, every way in which we behave, particularly in the field of medical sciences, every decision that we would arrive to, and is something which would become a prerequisite for us to be bracing towards the changing landscape of the AI world. AI world, because I would say that this is only a 4-year, 1% of a 4-year-old child's behavior that we are seeing on the internet in the GPTs of the world that are there today. So, but I think because it's in the very nascent stages, for us to be having a successful digital twin which performs well, or for us to be able to cohesively coordinate with the technology that is available outside, we need to be having our own notes and everything ready. And AI is definitely going to be a new normal. Like you have been using mobile phones, AI is going to be a new normal for it. But there are 3 life skills which I would suggest that everybody in the room should be ready with while bracing it for the future. Apart from one language of communication, which you all are already very good at, one programming language is something that you need to understand to be able to understand computers. Do it now when you are young, because once you get into the profession, it would be difficult for us to understand the programming languages, or if you, it's not difficult, but you'll not find time. And the third thing is a basic understanding of mathematics, which we basically gave it up after 10th standard, because this entire AI world is going to be driven by mathematics. And I think these are the 3 life skills which we need to be having, be it lawyers, be it doctors, or be it any profession. Yeah. And I think with this, I wish you all the best. And if I overstepped my time, I'm sorry about it. Thank you very much.
Thank you, Kiran. And just to introduce, Kiran and Karthik Ramesh are one of the top 200 AI masters in the world. The company which is based in USA, and we have 2 of his team members, younger generation AI masters, Tilak and Jaideep, who are sitting in the hall here. Today, before we end up this session, we'll showcase 3 to 5 minutes of yesterday's avatar, where the patient herself, yesterday we took a case history. So that case history, with the digital avatar, we have taken the case history. These 2 engineers sitting here for the last 48 hours, they have taken the history of that patient, and that will be showcased in the form of a video. Now, what is the advantage of this? Here, now you are students, we were students, the biggest advantage what you should not do, that you already know the diagnosis. So what I try to introduce in this core is how you can avoid diagnosis tomorrow in your clinical practice also. That I had given them the feedback, and with that they have come out. AI avatar is an assistant to you. So that once the avatar speaks to that particular patient, that complete recording we have done yesterday night at 1 o'clock. So once we take that recording, the AI analyzes itself. One point what Kiran clearly told now, Tendulkar is the senior most teacher, or the opening batsman in most of the scores for the last 12 years. How can we have another Tendulkar? Next 30 years, 40 years, or God forbid how long we live, we need to have an avatar. So what Kiran's important points, what he told us, that the avatar digital twin should be knowing all your aspects of what all knowledge you have. That's our responsibility to give a feedback to the engineers who design your digital avatar. When that is done, based on the questions what they ask, it's very fast to give a proper diagnosis. They showed me today early morning, 4 o'clock, they showed me what they have done. So one thing is, when you take a diagnosis, yesterday the discussions went on. What was the diagnosis? Already you know the diagnosis. It's VSD. You are unable to think beyond your diagnosis because you already know the diagnosis. That's a biased mind. Whereas AI avatar will go with the unbiased mind. Today the same case, yesterday's VSD taken with the history power, it gives 3 differential diagnoses. And I checked once, twice. In fact, they had taken, this is the 4th patient, they have been doing it for the last 48 hours. And the 4th patient, when I gave a correct feedback, it could pick up the diagnosis which the patient has. So it gives 3 differential diagnoses. Then in that 3, based on then the human brain comes into picture. This will streamline the clinical examination findings, saves your time, the time you go to the patient to see it. That's a very good example on a VSD what they have taken. The AI has given 3 differential diagnoses and the AI raises red flags. This is very important feature. AI raises red flags. Red flags in the sense the mother tells palpitation with loss of consciousness. That's a red flag wherein the clinician should be alert with that. So some important findings which is not able to understand, or if the AI is trying to point out one important feature. For example, in when you see references or when any important lot of chart is there, in that you displays it by red or in bold letters for our eyes to catch it. In that it raises red flags also. This is the first time we are introducing this, and I think with the help of such AI masters, definitely we can make a huge difference. Now, how AI can help revolutionizing patient care and innovation in cardiac surgery, I think I request Dr. Karthik Ramesh, who is an AI master by himself. He is a professor at our own institute. Over to Karthik Ramesh, please. We can have questions after this for a few minutes. After that, Dr. Ali Zamir Khan is there online.
Yeah, thank you very much, Dr. C.S. Hiramat. I hope I am audible. So first of all, I'd like to thank Dr. C.S. Hiramat, the organizing secretary, and he's also my mentor. A question which I get often asked, and many of you may have thought about this: why are AI people coming to a cardiothoracic conference? And I'll finish my presentation in the next 5-7 minutes. But I want to just highlight what Dr. C.S. Hiramat has said. AI is inevitable now. It is an assistive intelligence, like Dr. Anadurai told us yesterday, the moon man, that has to assist the human intelligence. But today, AI has already entered 25 years back when Intuit Surgicals brought the Da Vinci robot into the market. AI had already entered the field of cardiothoracic. So it is not people like us who are working with AI in other industries who are coming here. You are already working with high-end robotics, be it SMSIMSR, be it Intuit Surgicals, and Merrill has also come out with there are certain Chinese versions. So we have to move beyond robotic assisted surgeries to large language model. And this is where I'm very thankful to Dr. C.S. Hiramat, because through such conferences, we get to get the meeting of mind of how application of technology can be done to medical science. That I have only 5 slides to talk to you about, and I'm going to talk about cardiogenic shock. I'm also very lucky to work with one of my other mentors, who's also kind of mentor, I should say, to Dr. K.R. Balakrishnan. To address cardiogenic shock, we have also come up with this device in a company called Floyd. There also we are trying to integrate with the device, and also we have come up with the artificial LVAD, where a person who's suffering acute heart failure, today we compete against the likes of Abbott, where we can bring in our made in India technology to address these issues. Now, what is the role of AI in cardiogenic shock? Now, if I have an instrument like, Floyd's instrument, which I can insert through the thigh artery, and during cardiogenic shock, I can, revive a patient in the first, in the golden period, in the first few minutes. Similarly, if a person does not get a transplant, I can implant the LVAD, what's called as cardiobionic, which is coming up made in India product. What is the role of AI there, right? So the role of AI is to help in the identification, prevention, risk management of such customers, or such patients. Ideally, it serves as what we call as a triage tool. Let me tell you, Kiran was saying AI is an aid. So human doctor is definitely going to be in the loop. Whether or not AI engineers or AI people like us are there, the surgeon is never going to leave the hand of the scalpel, and he is not going to leave the patient just on the mercy of AI. So you are able to measure, you're able to generate scores. So AI gives us the foresight to act before a crisis. And I'm giving you a specific example of cardiogenic shock. Not only this, as surgeons, Dr. Hiramat often tells me, he comes out of cardiac surgery of 8-10 hours, does 3-4 surgeries in a day, and he has to document all of these things. So using conversational AI, the pranic tool, so you can also document it. But it's not just the conversation. the lab data, the imaging data, the vitals, the ECGs, the echocardiograms, the CT scans. Today you do a complete CT scan, which has 169 different cuts of the human heart. How can you integrate all this real time as a single human being who is already focused on saving a life of a patient? That is where AI comes. I'll give you an example of a stop shock score, which AI has developed, which is nothing more than a statistical score. It's a predictive, if I to simplify it and oversimplify it to a target audience of resident doctors, cardiac surgeons here and professors. It's just an AI predictive score to determine what is the risk stratification for a cardiogenic shock patient at the first point of contact. Now, AUC is the area under the curve. So stop shock's curve score produces a area under curve score of 0.844%, which is very good, and a precision R target of 94%. Now, using this and using readily available emergency response ambulance variables without special inputs, this has already been implemented in some hospitals abroad. So stop shock gives you a classic example of how an AI-enabled score is placing the predictive power in the hands of emergency personnel. We are talking about people who are actually going to attend to the patient who has collapsed because of cardiogenic shock, paramedics. You're talking of ER physicians. Now, the last part of my presentation, as I said, I'll keep it within 5 minutes in the interest of time. AI can be used to predict based on the clinical history of the patient, the food habits, how and when they last visited the doctor, the ECG score. Now, many times the ECG machine itself gives the reading, but many cardiologists and many ECG operators have told me that's not very reliable unless the surgeon looks at it. Now, today with the help of AI and the ECG report and the ECG report analysis which is there, before it goes to the doctor, we have algorithms to analyze the ECG signals, actually integrate what we call as the multimodal data stream in real time. Similarly, pathological lab factors, symptoms, imaging data, vital signs, all of this, when you say triage, you're bringing this, the doctor's inputs and the AI analysis together, the data, the AI analysis and the doctor in the loop to bring a better prediction about the patient. Now, I talked about heart transplantation. This is where I'm working with Dr. K.R. Balakrishnan in Cardiobionic. So we look at an AIU score of AI generating a model of 0.962. So there is near perfect discrimination for early detection of allograft rejection. This will also reduce the invasive biopsy burden. Similarly, matching donor recipient. Now, Dr. C.S. Hiramath and I set up in Mudanalli the heart valve bank, which is the world's only homographed heart valve. How do you define or how do you decide when there is a shortage of heart valves or in transplant shortage of hearts, who is the likely candidate to receive that heart? So AI-enabled thing can be used to measure the volumetric measurements. Is the donor heart which has come to us, is it good? Is it a good size man? Let me quickly give an example. As you know, people in the West or people like me who are well built, the size of the arteries will be thicker and the heart size may be higher. So how do you know the donor heart is going to fit perfectly? Similarly, primary graft dysfunction also can be predicted with AUC of 0.868. This is post the transplant. So before the surgery, during the surgery, after the surgery, simple example of how AI is used. Lastly, you can bring in AI into optimized treatment pathways. You can bring in, we were also having a conference last week with Dr. Sudhir Srivastava, where Dr. Hiramath and I, co-chaired and addressed the panel of how you can integrate conversational AI, like the avatar of AI, into the SSI Mantra robot. Similarly, you can build these scores like MIT AI score, right? The mitral regurgitation patients who are undergoing this transcatheter H2H repair, how do you determine whether this is the right fit for them, the score? Similarly, integrating all available cardiovascular information systems in the surgery, in the operating theater, with the CT scan, with the reports, during the operation, AI can provide a consolidated view. Lastly, improving the departmental efficiency. Now, last point I want to mention, I live in Dubai, for example. All of cardiac surgery, the burden goes in UAE to Cleveland Clinic. How does Cleveland Clinic manage compliance? It has to supply the data to the government to say that these many patients fit. AI can simplify this and it can free the clinician from the documentary overload and also help in decision making. Lastly, we are talking of large language models, which Kiran touched upon. Beyond ChatGPT, you can now talk to any ChatGPT, including your phone. While it is not legal or medical legal does not allow us to use that analysis, but at least you can use it as a symptom analysis. You can feed in some data with, I won't say 100% accuracy, with reasonable 75-80% accuracy. At least a multimodal data can be fused so that you get some kind of a predictive inference. Now, I will not recommend this for publishing papers. I'll not recommend this for treating. But this is what we are looking at, how large language models today can be used pre-surgery, during, for generating notes, and post-operative for follow-up of the patients. Many patients, including the institute where we are, have to come back for follow-up. So AI can be used. Lastly, I want to say that it is going to be a combination of human, artificial intelligence convergence. Robotic cardiac surgery moved from Da Vinci platform today to SMSIMSR, where we're integrating. And the goal is to provide value-based care, so where AI becomes not assistive, not artificial, but it becomes an authentic source of intelligence. So lastly, I want to just state that AI will not replace the CTV surgeon, but CTV surgeons who uses AI will replace the one who does not. And that is where we have, great surgeons like Dr. C.S. Hiram, Dr. K.R. Balakrishnan, Sudhish Shardan, many of you in the room whom I'm not seeing. Unfortunately, due to fracture, I could not make. But I'm sure you are all going to define, especially the residents, of how AI is going to be enabled. Thank you very much. That's it from my side.
Karthik Ramesh. One important information I would like to do. Today we have the next is a thoracic case to be taken. Unfortunately, none of the residents came forward to take the thoracic case. And I was thinking how to do. Me and Dr. Sri Krishna requested two of the residents to force them to take the case. They are taking it outside. Now I can implement this AI of digital avatar to take the case.
Right, sir.
Okay. But digital avatar will not write your exams.
Correct.
You should remember that. We are here for you to clear your exams. I do not know how to do that. You should come forward to plan. Why we introduced the AI system this time, first time in the score system. This is first of its introduction today. And nobody is ready to take a case. That will assist you. And that will not give you a single diagnosis, because the AI mind is not biased. You are understanding? It can give 2-3 differential diagnoses. And always examiners are much more happier if you give differential diagnosis, because your knowledge is based on your discussion rather than the diagnosis. This is very important. Go with the unbiased mind.
I want to add one point. Dr. C.S. Kiramat is very soon going to be the visiting professor in IIT Madras. So why a surgeon like you is going to address an AI student? The reverse also is happening.
Yeah,
where you are now going to IITs and you are going to work with the IIT students, teach them about the healthcare and medicine side. So we cannot separate these two. Is the message of to which I would like to leave the residents. As you said, more and more technology and medicine are going to go hand in hand, sir. And I really thank you for the opportunity for Gamma Group. And with Kiran on the line, I just want to add one last line, sir. Sorry, is that we are going to offer a master class in AI. We are simplifying and oversimplifying AI, so it can become like many surgical tools, an additional tool, like a Swiss Army knife in your hand, which you can use, as I said, with the power of data, with the power of predictive algorithms and power of large language models. We'll be launching with Gamma Group, which Dr. C.S. Hiram has kindly announced yesterday. We're looking forward to a longer partnership with SCORE program, sir. And Prasad also listened to the recording yesterday. He conveyed a special thanks to you, Dr. C.S. Hiramat, to Sadhguru Sri Madhusudan Sai, and all of the professors and residents. We are always here to support you. Thank you, sir.
Thank you, Karthik. I think with this cardiac surgery, various specialties are coming up. Minimal access, thoracic, robotic. Similarly, cardiac surgery with AI specialty, some of the residents can take forward future. With this, I think over to Dr. Ali Zamir Khan. Dr. Pooja, can you take it forward, please? Thank you.
Yeah, we shall now have the awaited
Thank
lecture.
you, Karthik and Kiran and the entire Gamma group of team members. Tilak and Jaideep, thank you so much.
Thank you very much, sir.
We shall now have the awaited lecture on case presentation in patients with thoracic etiology. I would request Dr. Ali Zamir Khan, Professor and Consultant Thoracic Surgeon from Blackpool, United Kingdom, to render his invited lecture. Over to you, sir.
Okay, Professor Hiramat, Sri Krishna Rajashekar Reddy, and my dear friends in the audience, thank you very much for inviting me to speak at this important event. My job is to make your life easy. My job is to make sure that you pass your exam. And I am going to take you through a pathway of how to do a clinical examination. I will also talk about how to do a respiratory or pulmonary assessment for lung surgery. And last but not the least, I'll give you some tips on how to behave just before the exam. So basically, my suggestion to every one of you is that there is going to be only limited number of cases in thoracic surgery. Everybody get yourself a 200-page notebook. These are the cases that will come. You put the title on the top of the page and then take a history and design a case. So take one history for every single pathology that I'm going to show you. So the patient will either have pleural effusion, empyema, or TB. There may be a case of lung cancer, hydatid, a mediastinal mass, an esophageal cancer, thoracic outlet or hyperhidrosis, chest wall tumor, emphysema with discussions on LVRS, and a diaphragm case. So take these cases and make a case history, write down the clinical, the history, the clinical findings, and practice it repeatedly. The good thing about thoracic surgery is that the symptoms and the clinical examination usually will lead you to one of the cases, and you will understand what sort of a case you're dealing with, okay? So when you start the case, let's start with very basic stuff. So let's look at clinical history. There are 5 main symptoms that you have to look at. One is dyspnea, next is cough, hemoptysis, weight loss, and fever, okay? Out of this, each one of these, what you have to investigate is ODP, origin, duration, and progression of each one of these. And if you take a history really well, very often you get a clue as to what you're dealing with. So history is extremely important. Don't forget past history, particularly because we are looking at comorbidities. So, cardiac history is very important. History of a stroke is very important. Pulmonary embolus, DVT. So past history for comorbidities is very important. Don't forget to take a surgical history, because a past surgical history might help you to decide what is happening at the moment. For example, if the patient has had a colorectal cancer excised in the past, maybe you're dealing with a case with metastasis. So this is how you kind of use the history to reach the diagnosis. Don't forget to ask for previous anesthesia, particularly whether the patient was okay with the general anesthetic, because that will help you to decide whether the patient will be okay for surgery this time. For me personally, the medical history, the medicines that the patient takes is very important, because sometimes the patient forgets to tell you a clinical history. And when you look at the list of the medications, you suddenly realize, oh, there's an anti-epileptic drug that he's taking. So he's forgotten to tell you about epilepsy. So it's very important. Particularly, you look for the blood clotting factors. So, you look for aspirin, clopidogrel, stuff like that, which will affect your surgical management. So for me, the medical history, what medicines he's taking on a regular basis is extremely important. Social history is quite important, particularly in social history, you're looking for history of smoking, you're looking for the occupational history of the patient. All of this will guide you towards the diagnosis. For me, the functional capacity is quite important. I do want to ask, can you go up a flight of stairs? Can you do one round of shopping across the local marketplace? All of this help me to assess whether the patient is fit for surgery or not. I mean, if he's huffing and puffing coming into my clinic, that's a bad sign. This patient is a high risk for surgery. So the functional capacity assessment is quite important. Don't forget to ask for family history, particularly looking for cancers and, of course, associated tuberculosis. And allergies are very important, because you're going to operate on this patient, so you don't want to be stuck with some clinical problems. This is a standard general examination that you do, TPR, BP, JVP, and a JACCOL, which is jaundice, anemia, cyanosis, clubbing, edema feet, and lymphadenopathy. Any clinical case, you have to do these basic things, and I won't go into detail of this. Let's go into further details of the examination. If you're going to do an inspection, you've got to look for chest shape and size, breathing pattern, respiratory rate, use of accessory muscles, cyanosis, and chest wall deformities. I am surprised the number of times candidates who come for exams are unable to tell us a good inspection. So please focus on inspection, focus on palpation, percussion, and osculation. It's quite important to get the clinical examination right. In the inspection, also look for other signs that you see on a chest wall. In palpation, what you're looking for is chest expansion, vocal fremitus, trachea positions, and more importantly, diminished sounds. That is quite, these are the few things that you really need to tell the examiner in your palpation. In percussion, what you're looking for is hyperresonance or dullness, both of which give you a clue. If there's hyperresonance, you think of emphysema or pneumothorax. If there's dullness, you think of effusion or consolidation. So percussion is quite a good tool to give you an idea of what's going on inside the chest. And of course, not to talk about auscultation. Auscultation is very important. Breath sounds both in a full inspiration and a full expiration. So listen for at least 3 or 4 cycles of inspiration and expiration before you start talking. Look for wheeze, crackles, rhonchi, diminished sounds, but most importantly, don't forget to talk about cardiac, because when you auscultate the chest, you're also supposed to auscultate for cardiac sounds. Look for murmurs and stuff like that. Okay? Dr. Hirimat just said, don't reach one diagnosis. If in the exam, if you say one diagnosis, probably the registrar has told you what the diagnosis of the patient was. Always try to reach a differential diagnosis. In the exam, it's better to say 2 or 3 differential diagnoses, and then using investigations, you try to cut down the diagnosis to 1. So it's important to reach a differential diagnosis. Routine bloods are quite important. CBC, ESR for inflammatory markers, liver functions for coagulation profiles and things like that. A renal profile is very important because you do want to send the patient for a contrast-enhanced CT scan. You want to make sure their U's and E's are okay. So in an exam, if I ask you investigation, start with this. And then go to specific investigation. Depending on what is the pathology that you're thinking in your mind, you can ask for the various, tumor markers and things like that. So you can look for beta HCG, alpha fetoprotein, CEA, aspergillus if you're thinking aspergillus, or if you're thinking of a carcinoid, then you can look for specific markers. So specific blood investigations will probably come after you have looked at the CT scan. But keep these in mind. Radiology is standard. You start with a chest X-ray, always start with a chest X-ray and a CT. And most of us will ask for a contrast-enhanced CT. The important thing to remember is when you're discussing radiology, ask the examiner, are there any previous X-rays or CT scans for me to see? Because very often, the previous X-ray will give you a clue whether the mass has changed in size or whether there has been some other changes that have happened. So don't forget in radiology to ask for previous X-rays. In terms of CT, you can also look at, you have to know the differences between the various types of CTs. What is a CECT, what is an HRCT. Sometimes we talk about CT-guided biopsies, particularly in lung masses, but don't forget PET scan. PET scan is part of the NICE guidelines. If you're dealing with a lung cancer, you should not be operating or giving chemotherapy before having done PET scan. And it is a routine investigation. The CT-guided biopsy actually comes after the PET scan. If you do it before the PET scan, then it will alter the findings of the PET scan. So the order is reversed. It's not first, it's after the PET scan. Once you've done these things, you have an idea of what you're dealing with. You've looked at at all the imaging. So you come to one final diagnosis. Now, the important thing is to assess for fitness for surgery. That is extremely important. You cannot put a patient through surgical management without knowing fitness for surgery. The 2 guidelines that you have to look at is ESTS and ESTS ERS or ACCP guidelines. These are the standard ones available in the market, and this is the pathway that it follows. But the most important point that you have to remember is that there is always cardiac assessment before lung assessment, okay? So that is the most important thing. The heart is always first. If the patient's got a cardiac disease, you sort the cardiac disease before you operate on for lung cancer. And I'll go through each one of this in a bit more detail. The 2 guidelines have slight differences in terms of numbers, but more or less the philosophy is the same, okay? Sorry. The BTS guideline talks about a tripartite assessment. So what you do is you look for operative mortality, you assess the patient for operative mortality, you assess the patient for perioperative cardiovascular risk, and you do what is called as a predictive post-operative pulmonary function. And that is how a patient becomes fit for thoracic surgery. And I'll go through that in a minute. So cardiac evaluation is important. You must do a cardiac evaluation before you do a thoracic evaluation. For cardiovascular fitness, the preoperative ECG is quite important. If there's an audible cardiac murmur, then move on to an echocardiogram. Few principles: MI less than 6 weeks, not for lung resection. MI less than 6 months, cardiology opinion is mandatory. Now, this is part of the ESTS guidelines that I'm quoting to you. A CABG should not preclude from lung resection, but cardiac should be sorted out first, not thoracic, because if you put a patient with coronary disease through a general anesthesia for a lung surgery, unfortunately, he will get a cardiac event that will not give you a good outcome. Okay, how do you assess the respiratory function? Besides the routine things, you also look for oxygen saturation, arterial blood gas, spirometry, and flow volume loops. And I'm not going to go through all of these in details, but I'll just tell you what are the main tests that you do. A peak expiratory flow rate works very well, particularly when you're dealing with myasthenia. Static gas transfer diffusion coefficient, shuttle test, a 6-minute walk test, and a CPEX. And I'll talk of each one of this in more detail. So the most important thing out of all of this is that you want to estimate the post-operative FEV1. You want to make sure that this guy is going to tolerate the lobectomy, pneumonectomy that you're offering to this patient. And the way to predict post-operative FEV1 is pre-operative FEV1 into 19 minus segments to be removed divided by 19, which essentially you also got to look out for obstructed segments. So if any segments are obstructed, then you use predicted post-operative FEV1 is pre-operative FEV1 into 19 minus A minus B divided by 19 minus A, where A is number of obstructed segments and B is number of unobstructed segments. That's why in lung surgery, it's very important to know the segmental anatomy, not the lobar anatomy, but the segmental anatomy, because that is what decides how you calculate a predicted post-operative FEV1. The same thing can be done for FEV1, the same thing can be done for DLCO. Both of these, the gas transfers are also quite important to be predicted. The same formula applies whether you're using for FEV1 or DLCO. So once you have predicted that, if the patient has got more than 80% numbers for all of them, you go ahead straight for surgery all the way up to pneumonectomy. If there is a lesser number, like less than 60% in the ACCP guidelines or more than 30%, you go for a shuttle walk or a stair climbing test. The level of evidence for this is 1C, so which is quite a high grade of evidence. In a shuttle walk test, what you do is you put two cones 9 centimeter apart and look for the best distance or less than 25 shuttles. What you're really looking for is not the distance covered, but the desaturation of the patient. And so an oxygen probe on the hand is quite important, and a desaturation of greater than 4% is an indicator that you might get trouble with this patient in the post-operative period. That's how you do the shuttle walk. Stair climbing is again a very good and a good sensitive indicator. It's a cheap indicator. You don't have to do anything more. The ESTS guideline says the height of ascent should be more than 22 meters. Sometimes it's difficult to know what is the height of the stairs, but a rough ballpark is 2 flights of stairs is always a good indicator that the patient will tolerate surgery. This is a cost-effective method which predicts morbidity and mortality, and actually it's better than spirometry and first-line tests. And the level of evidence is 2++ or B. So it's quite a sensitive test with good level of evidence, and it predicts the needs for further tests. If you can't climb 2 flights of stairs, then you should be worried. You should look for further testing. What you're looking for again is oxygen drop of more than 4%. If that happens, then there is going to be higher morbidity or mortality, and then you have to go for a formal test. A lot of us talk about 6-minute walk test, but actually the ESTS guidelines says that 6-minute walk test should not be used to select patients for surgery. It's better to use a stair climbing test rather than a 6-minute walk test. If the predicted post-operative FEV1 or DLC is less than 30%, we're now heading into danger territory. This patient may be high risk for surgery. Let's do a CPET and determine VO2 max. So this is how you do a CPET, and what you're looking for is peak oxygen consumption. If the VO2 max is more than 20 ml, the patient is low risk for surgery. If it is more than 12 ml, he's an average risk. And if he's less than 10 ml, he's a very high risk for surgery. Most of the times, if the VO2 max is less than 10, I will actually send the patient for other therapies rather than surgery because they will have post-operative morbidity. So again, you can use the same formula to predict a post-operative VO2 max in a patient. It is quite important to understand the WHO performance scale, and very often my surgical activity is in scale of 0 and 1. Anybody who goes into 2, 3 or 4 is not the candidate for surgery. So usually I operate on patients who are 0 to 1. As I said, you've got to worry for people whose performance status is more than WHO 2. Also, you have to calculate the risk factors, and the multiple risk factors, if you've got a single risk factor, then the risk of major complications 1.1, 4.6, 9.7, depending on how the numbers go up. And this is where we use AI and predictive score models like Thoracic to predict adverse outcomes of patients. So we in our clinical practice, all of us have an app on the phone, and we fill in the patient's details on the app, and it gives us a complication rate or a risk of morbidity and mortality. Okay, thank you very much. This is the examination part of thoracic surgery. Let's see how you should go for the exam. A lot of people don't realize that the examination is all about performance. It is, knowledge is there, everybody has the same level of knowledge, but outcome depends on performance on that day. So the night before, make sure you sleep well, at least at 9 p.m. the night before. Get a good 8 hours sleep. Make sure you don't eat spicy food the day before. Please do not drink the day before because next morning it will show on your breath. In the morning, don't read the day before. Make sure your hair is cut nice and trim. Make sure you get a good shower, and important to shave. I have seen people coming into the exam looking really ruffled, wearing dirty slippers. That's not a good impression for the examiner. Make sure your personal hygiene is clean. Nails are cut because when you examine the patient, the examiner can see your hand. If you've got tattoos, then cover it, please. Make sure your clothes are ironed. If you're going to another city, carry a travel iron so that you can iron your shirts well. It's always a good idea to wear a white shirt and black trousers or a blue shirt and a black trouser. Don't try to wear fancy shirts to the exam. Always take a white coat with you and fresh undergarments, and most important, shoes should be polished. You'll be surprised, the senior examiners look at your shoes and they determine your personality. So please, please, please make sure your shoes are well polished before you enter into the exam. If you are suffering from anything, make sure you take your medication so that you don't get any of these complications during the exam. You want to perform well on the day. Nothing below the elbows is the standard rule. Don't wear watches, don't wear any threads, half sleeves. Wear half sleeves and take off your jacket if you're wearing anything. At the venue, make sure you're early, make sure you've got your stuff, bring your own stethoscope, and for God's sake, please switch off your phone. The last thing you want is for your mother to call you in the middle of the examination. That is not okay. When you go to an examination center, please look for the specialty of that hospital. Please look for what type of surgeries they do normally. Look for what is endemic to that area, because that is what the case will come. If there's a surgeon who does esophageal surgery as his major practice, then you will get an esophageal surgery case. So always look for the examination center. It gives you a very good clue of what type of cases you might get. Don't forget to read your thesis well. Don't forget to read your CV and your interest, because sometimes these are icebreaker questions. When we come in and we are trying to set you at ease, we might ask you something about yourself before we get on to the case. Thank you very much, ladies and gentlemen. I'm very happy to take questions, and I will stay for the thoracic case presentations.
Thank you, Zamir.
Mic not working.
We appreciate that you got up at 5 a.m. to talk to us. Thanks for that. And as usual, the excellent presentation. If there are any questions from the students.
I'm sorry I made it very basic, but it is all tips and tricks for passing an exam.
True. May I add a few more
Please do, please do.
points onto this, because after the presentation of your case and this thing, we will probably go on to the management and what is the surgical procedure that you are going to be doing. And in the present time, you must also know what approach you're going to use, whether you're going to do an open approach, a minimal invasive approach, or a robotic approach, and why. So that is something that you have to add in the present day and time. And of
Can
course,
I just comment on that, Sri?
yeah,
My comment on that would be that what we expect you to say is what you as a consultant surgeon would do.
Very true.
So don't talk about a robotic surgery if you've never seen a robotic surgery.
Very true. And what is being done in your particular institution?
Absolutely.
What you have seen and what you can deliver. Ali, you made it very simple up to the personal etiquette of the students, man. Thank you. Thank you very much.
Thank you so much, sir, for joining us. So with this background, we shall now move on to our thoracic clinical case presentation. I request our examiners to join us. We have Professor S.V. Krishna, Professor and Senior Consultant Thoracic Surgeon from Narayan Hridayalaya, joining us in person. Dr. Ravindra K. Divan, Retired Professor, Head of Department, Chest Disease, New Delhi, joining us online. And Dr. H.V. Rajashekar Reddy, Senior Professor and Thoracic Surgeon from Bengaluru, and he visits us too. Dr. Ali will join us online. And Dr. T.S. Shivkumar Swami, Professor, Thoracic Surgery from Institute of Chest Disease, Bengaluru, joining us. So we have Dr. Vikas, Dr. Ashraf, and Dr. Shrijit presenting the case. We have two presentations, so the time allotted for this session is 50 minutes. The first resident will present the history clinical examination components, while the second resident will present the investigation and the operative management aspects. Both will thereafter contribute to the discussion on management. Please note the buzzer will be sounded at 20 minutes, 40 minutes, and 50 minutes. Thank you so much.
Good morning, everyone. I'm presenting a case of a 52-year-old male, a pleasant gentleman, presented to us with complaints of cough, with productive cough since 20 years of age, associated with hemoptysis occasionally. The complaints were insidious in onset, gradually progressive, and these complaints are associated with disturbed routine activities, and all his symptoms aggravated since 1 year, and he has disturbed sleep due to these symptoms. Patient also complains that he can't sleep on the left lateral side, and he assumes right lateral position whenever he wants to sleep. And the sputum is thick in consistency and copious in amount, and associated with blood occasionally. And all these symptoms aggravates during winter season, and it relieves during summer season. There is no history of fever, there is no history of sweating, there is no history of significant weight loss, no history of dyspnea on exertion, and he was diagnosed as a case of pulmonary tuberculosis 30 years back, and he completed his TB regimen. And he's a known case of type 2 diabetes mellitus and systemic hypertension since 3 years, and he's on medication. And he was recently diagnosed as a case of coronary artery disease with single vessel disease since 2 years. And there is no any surgical history. There is no similar complaints in the family, and he has good appetite, and his sleep is disturbed, and he's a chronic tobacco chewer. And coming to general physical examination.
What about the medicines? You heard Zamir talking.
Sir, it is the mic, sir.
What medication is he on, considering his coronary symptoms, coronary disease since 2 years?
Sir, he is on ecospirin, atorvastatin, and metoprolol also.
Any other medication that he takes regularly on a daily basis?
Sir, he is on oral hypoglycemia for diabetic medications.
Okay, continue.
Was he treated for his coronary disease?
No, sir, he has not treated.
Still is having this
Yes,
disease
sir.
and other problems, lung problem also.
Coming to general physical examination.
Sometimes the examiner will ask you, whether you can sort of think and what lines, what do you think that this patient is having at the moment? Do you think it is an infective process? Do you think it is a malignant process? And what? It's a long-standing history, right?
Yes, sir.
So, and then there are a few things that you have mentioned. There is postural variation, there is seasonal variation, and so what do you think is the differential diagnosis? When you know that, you will look for particular signs and symptoms in your examination as well as your investigations. So you have to start thinking, right from talking to the patient, from getting his name, you have to start thinking what could be the problem in him, right? So what do you think this patient has?
Sir,
from the history.
Sir, because he's having a history of diagnosed pulmonary TB, and he has completed his regimen, I think there may be like post-TB sequelae,
That's correct.
bronchiectasis.
30 years of symptoms, what brought him to hospital now? And one question is, where do you think the lesion is, considering it is aggravated in the left lateral position? You said it aggravates, he avoids sleeping on the left lateral. So where is the likely lesion? Which side of the lung?
On the left side.
Left side. If he's sleeping on the left side, it gets aggravated.
Yes, but from this history, sir, the lesion should be on the right side.
He's got
productive cough.
And gets aggravated on the left lateral.
Yes, sir.
Meaning to say, when he lies down on the left lateral side, the secretions from the lung on the upper side spill over into the airway and aggravate his symptoms.
Yes, sir.
So where is the lesion?
Left. Right side.
Okay, continue.
Right side up, he's coughing, so right side lesion only, no?
Which is higher.
Which is, yeah.
Which is higher and it
When he
trickles
lies down on the left lateral position, which is the downside, which is upside?
Left is lower side.
Left
and right
is downside, right is up. If the secretions are on the right lung, they spill over into his airway, aggravating his symptoms. So he avoids sleeping on the left lateral position. So the most likely lesion or the post-tubercular sequelae is in the right lung.
Yes.
Which part of the lung is commonly affected by TB is the upper part. So most likely the lesion in the right upper lobe. Simple. Continue.
Can I make a comment on this, please?
Sir?
Mike, sir, yeah, Elizabeth Khan, you want to tell something?
Yeah, actually, I just want to tell all the candidates in the room that when you are doing an examination, the examiner is there to help you. He is not quizzing you. He is not trying to make your life difficult. Rajashekar Reddy gave such a good clue to the candidate, and you failed to pick it up because you thought he was trying to quiz you and make life difficult. So listen to the examiner. He is actually giving you clues to come to the right answer. Okay, it's very important to listen to the examiner very clearly. He gave you an excellent clue of where is the lesion, what is the side down, and he even told you, secretions coming to the other side. And you still went and said the left side. So listen to the examiner. This is my advice to all candidates. Don't get stressed by the examiner. They are not trying to make life difficult. They are trying to help you to come to the right diagnosis.
We don't want to know what you don't know.
Absolutely.
We want to know what you know and how you are going to treat this patient. That is the basics of any examination. Okay?
Continue.
Patient is conscious, oriented to time, place, person, and is cooperative. His pulse is 70 beats per minute and normal sinus rhythm. And his respiratory rate is 20 cycles per minute, and his BP is 130 by 70 mmHg in supine position in right upper limb, and he is maintaining a saturation of 98% on room air. There is no pallor, icterus, sinus clubbing, or lymphadenopathy or edema. Coming to systemic examination, coming to respiratory system examination, on inspection, chest is bilaterally symmetrical, and and there is no scars, sinuses present, no visible pulsation, and there are no skin rashes. Trachea is central, spine is normal. On palpation, inspectory findings are confirmed, and on ocal femmitus examination, there was dullness noted on the left side in supraclavicular, in left supraclavicular, infraclavicular, and supramammary and inframammary regions, and left interscapular region. Coming to percussion, liver dullness was noted in the right sixth intercostal space, and on right side there was a resonant note was present, and left side the note was dull, and coming to auscultation, there was bilateral non-muscular breath sounds was present, but left side there was the breath sounds was dull, and ocal resonance was decreased on the left side compared to right side. Yes. And coming to CVS examination, S1 and S2 was heard, and there was no murmur present. And other systems are within normal limits.
You said trachea central and vocal resonance and 25 years history is there, but there should be some changes on your clinical examination.
Sir, I could not appreciate it, but I felt that trachea was central only, sir, on examination.
Even vesicular breath sounds are equally heard?
It was, normal vesicular breath sound was heard, sir, but left side it was dull, sir, compared to right. It was decreased.
Okay, continue, we will see here.
Yes.
Any changes in lung volume on either side? I mean, thoracic cage?
No, sir. We didn't.
No crowding, nothing?
No, sir. We didn't. Yes, sir.
Okay. You finished?
Yes, sir. Examination.
Examination is finished?
Yes, sir.
So what's your impression?
Sir,
what's your impression?
Sir, I feel this is a case of post-TB sequelae, probably bronchiectasis on the left side of the lungs, sir.
Why?
Sir, one is there is history of pulmonary TB 30 years back, and now his present symptoms are cough with productive cough, and it has been worsened since 1 year, and it has seasonal variations, sir.
Can I make a comment, please?
Go on.
So my suggestion to you, young guy, is that at the end of the clinical examination, you must make a one-line synopsis of all the positive findings, and then you should say, what is the probable diagnosis? Don't wait for the examiner to ask you what is the diagnosis, or don't give the examiner a chance to ask you a question. Just do a synopsis. You had some very good positive findings. Put the positive findings in one line and say, I think this could be a sequelae of TB, or whatever is your finding. Is that okay?
Yes, sir.
I would have appreciated if you had said, this is a patient who's got a suppurative lung disease with a long history of productive sputum wherever the lesion is, probably due to a post-tuberculous sequel.
Fantastic.
That would have been a good answer.
Should he say bronchiectasis or he should not say?
Chronic suppurative disease is fine. When you say chronic suppurative disease, and then you have, as Zamir said, you must have a differential diagnosis. So what are the chronic suppurative diseases pertaining to TB? One, it could be an infected tuberculous cavity. And second, more common, is a bronchiectasis. So commoner diagnosis first, and then rarer diagnosis rarely. Okay?
Correct.
Lung abscess is another suppurative, but that doesn't last for 30 years. So you would probably go more on to bronchiectasis.
There is no recurrent episodes of fever. It's only recurrent episodes of cough.
Yes.
Okay, continue.
You understood?
Yes, sir.
So from history, your mind starts thinking. Then during examination, you have particular areas of the chest to examine in detail, and then come to a diagnosis, and then order relevant investigations. Okay? Now you probably think that this is a bronchiectasis following tuberculosis, right? What are the investigations that you want to do? And 3 questions you always have to answer. Is surgery indicated? Is the patient fit for surgery? And is your surgery going to improve his lifestyle or not? These are the 3 things, and even if one of them is a question mark or a no, you have no business in operating them. Remember this.
Yeah, go on. What investigations do you want?
You agree, sir? Anybody?
Apart from the routine investigations, what specific investigations do you want?
So routine blood investigations, after that chest X-ray and HRCT. I would also like to look for ECG. There's a history of single vessel disease and we require cardiac fitness for that.
Okay, from the point of diagnosis, you want a chest X-ray?
Yes, sir.
Do we have X-ray? If you have X-ray, can we...
Can the board be
Oh, yeah? This board, just move it away.
Wow.
Okay, can you read this X-ray, please, one of you?
So it is well centralized, well exposed, well exposed X-ray, chest X-ray PA view, with trachea appears to shifted on the left hand side, spinous processes appears to be in the midline, and the left lung, right lung appears to be hyperinflated, left lung seems to be destroyed.
Loss of volume on the left side.
Loss of volume on the left side.
Okay.
loss of volume with a simple consolidating into a cricket ball, tennis ball, or there's something seen on the left side?
Sir, the cavitary lesions are seen on the left side.
Single, 2, 3?
Sir, multiple cavitary lesions.
Fluid level, without fluid level?
Without fluid level.
Nothing like seems, it is, no?
Yes.
So, I just want to say one thing. The examiner, when you did your clinical examination, he gave you such a valid clue. He was asking you, is the trachea central? He asked you 3 times, is the trachea central?
Yes, sir.
And he gave you such a valid clue that actually in 30 years history, the trachea cannot be central. It has to be moved. And you didn't pick on that. And look at this X-ray and you can see that the trachea is deviated. So it's very important to listen to the examiner.
The entire mediastinum shifted to the left side, the side of loss of volume. Okay. Next, what do you want?
Sir, I would like to get one HRCT done for this patient.
No, before going to HRCT, do you think this is the lobar pathology or the entire lung is involved on the left side?
Sir, entire lung is involved on the left side.
Why do you say so?
Sir, because the upper lobe, upper lobe and the lower lobe both are involved.
What is the air shadow that you are seeing in the left hemithorax? If the upper lobe is involved, what is that shadow?
Pointer.
You are seeing lung markings on the left side?
Yes, sir.
Left hemithorax?
Yes, sir.
Yes?
Yes, sir.
So if the entire lung is involved, why is that shown?
Do we have a pointer?
What happened to the opposite lung here in this?
Anybody?
Opposite lung is hyperinflated, sir.
That he said, compensated, yeah.
So it is herniated across the midline. So the entire left lung is sort of collapsed and consolidated down into the base.
Yes, sir.
Okay. And see the branching pattern of the bronchus. You don't see anything going up. All are going down. So that gives you a clue that this may be a totally destroyed lung. Okay. Yes. Then you go on to the next CT scan.
That's what he was telling it, yeah, correct. If left main bronchus going down to the destroyed cavitary lesion.
We'll come to that particular point later on when you're planning surgery. What is this now?
Echo
So 2D echo for this patient.
Let us leave the echo and proceed with the lung now.
Show us the CT
Is there
scan.
anything abnormal in the echo?
No, sir.
Okay, fine. Ejection fraction good?
Yes.
No RWMA?
No.
So you are safe. Okay. Go to the CT.
CT images, please. Lung windows, please.
No, 1 second. He didn't see that there was pulmonary hypertension on the echo.
It's so small. Go back to the echo findings. PA
No, it's okay. It was there. I saw somebody said
Mild
pulmonary.
pH with 33 ingredient.
Okay, sorry. Carry on.
Okay, CT scan.
CT images, lung windows, please. These are mediastinal windows, upside down. Next. Now CT images, we need lung windows. Do we have the CT images here with the patient?
This is the old CT, sir.
It is wrongly projected. And you don't see the lung windows for you to comment on the pathology.
This CT scan was taken 2 years back, sir. The recent CT scan is not
If
available.
you are the operating surgeon, will you operate on a CT images done 2 years back?
No, sir.
So you have to repeat it.
Yes, sir.
So from the X-ray itself, you have most of the findings. You do the CT mainly to confirm those findings.
Yes, sir.
Isn't it?
Yes, sir.
And you just want to make sure that the right lung is essentially normal before you do something to the left lung. Okay, next.
So would you operate on an HRCT or would you ask for a different type of CT? As a surgeon.
Ali, you mean to say whether HRCT alone is enough or something else you want?
Yes, that's the question I'm asking. Is HRCT alone enough to operate or do you want to see vascularity and things like that?
See, contrast enhanced CT.
CT
Simple
contrast.
question.
CCT.
CCT, yeah.
You want a CCT to see the vascularity and any
How
collateral.
bad the mediastinum is shifted, and yeah, that helps you in planning approach. Okay, if you assume that the contrast enhanced CT, the lung windows shows all of the left lung, upper and lower lobe destroyed, bronchiectatic, with the compensatory hypertrophy of the right lung across the mediastinum into the left apex and etc. What more information do you want and how do you want to proceed?
Sir, I would like to know the pulmonary fitness for this patient. I would like to get one pulmonary function test.
You want any other images or what he's asking? Do you require anything or this is good enough? A CT, contrast CT, whatever is showing you a completely destroyed left lung. The right lung, is there any relevance to see the right lung?
I only said, man.
If the right lung is also diseased then?
You want to know whether the right lung is normal or not. You are planning to do a left pneumonectomy, I hope.
Yes, sir.
Yeah? So the right lung should be fairly normal, isn't it?
Yes,
You're
sir.
going to at least remove only the segments or affected segments on the left side and leave behind at least 10 segments on the right side.
Yes, sir.
Okay. So remember that. You have to make sure that the opposite side, especially in any lung case, if the opposite side is fairly normal for him to carry on with his life. Otherwise, you'll create a respiratory cripple. Okay?
Yes.
Is Dr. Sri Krishna's question, if I put it the other way around, this patient with a completely destroyed left lung, if there is also some amount of fibrosis and bronchiectasis in the right upper lobe, will you consider him for left pneumonectomy?
No, sir.
That's all. Next, what do you want? PFT you asked for. Do we have?
PFT, we've not seen, sir.
Not
It's not
seen.
there.
Any clinical examination or questions to see whether he is fit or not? 2 flight of stairs? Exercise tolerance?
Any other investigation you want to do?
Any other invasive test you want?
Any other investigation?
Yeah,
Anybody can answer.
bronchoscopy, we can.
Bronchoscopy. Why? Why bronchoscopy in this patient? He's got a destroyed lung. You've seen it on an X-ray, CT scan. Why bronchoscopy? What are you looking for in the bronchoscopy?
What extra information you will get in bronchoscopy?
So whether there will be any adequate stump after pneumonectomy?
Adequate stump you can see there.
After pneumonectomy, no. Before, you're going to plan surgery, you're going to do a pneumonectomy. You want to see whether that area of the section of the bronchus is disease-free. There is no endobronchial disease. This is a patient with post-tuberculosis. Okay?
Yes.
Because if you cut through a diseased bronchus, then you're definitely end up with a bronchopleural fistula.
Particularly in this patient is putting a lot of sputum and is copious amount of secretions. Bronchoscopy will avoid and make the lungs dry before going for surgery. And as well as culture of this bronchial wash will help you. If there is an active tuberculosis, everything.
Lavage.
To ensure it's a healthy bronchus.
And that
Visualization, yeah.
Minimize the infection, source of infection surrounding them.
Okay.
All right, next. So PFT we don't have. Okay, what?
When you examine the patient, if you are the operating surgeon, did you feel, yes, I can go ahead with the operation, but I need the test to prove the same thing, or you go only by the test? Did you ask him whether he climbed 2 flights of stairs, or what is his exercise tolerance, what is the day-to-day routine work style, what work does he do, what job does he do? Does it give you a clue whether he is fit for surgery or not?
So he is a daily wage worker. He's able to carry out his daily day-to-day activities.
What work does he do as a daily wager?
So like he is a shopkeeper.
If he is walking around 2-3 kilometers carrying loads on his head and climbing, constructor worker climbing 4-5 floors of with the construction material, he is obviously physically fit, isn't it?
So he works in a shop.
Works in a shop.
It's like a daily wage worker.
If you ask him directly whether he can climb 2 flights of stairs without stopping, without being breathless, he will give you the answer.
So he is able to do that, sir.
So he is reasonably fit for surgery. But you need the numbers to...
Another thing, the numbers are all for Caucasian, Western patients who are 70 kgs or so. So that may not be feasible in our country. So all these surrogate markers like stair climbing, breath holding, and then 6-minute walk test may be also a better indicator for you whether this patient is fit for surgery. Okay?
Yes.
Don't go only by the numbers. That's what I'm saying.
Like Ali Zamir Khan said, if you are sitting in your clinic and if the patient walks in struggling to take breath with accessory muscles working, then you have made your decision. It should not be in your clinic as a surgeon, at least at this stage.
Yes.
So that clinical assessment is done as soon as within 1 or 2 minutes of your consultation with the patient, whether he can give you the history without holding his breath or without gasping and etc. It is that clinical examination. Then you want to prove the same thing with the numbers, with the echo, with PFT, etc., etc. So you clinically is fit for surgery, fit for pneumonectomy, you say.
Yes.
What else do you want? Bronchoscopy.
I just want to make a comment here that when you do PFTs in this patient, you got to remember that all of the numbers are coming from the right side.
Yeah.
The left side is completely non-functional. So I would actually accept lower numbers because that is the predicted post-operative FEV1. Yeah. So that is the predicted post-operative FEV1. You know, all the numbers that come are all from the right side. The left is not ventilated. So there is no oxygenation happening from the left side. So that is the way you assess a patient's fitness.
Any other important investigation you would like to know in this patient? In this patient?
Because the patient has a history.
Sorry?
So because the patient has a history of coronary artery disease, I would
Very good.
repeat the angiography.
You have to assess the coronary artery disease. Make sure that he is fit to undergo He doesn't have any critical left main disease or critical this thing which can cause problems to you on the table, right?
Yes, sir.
At this stage, when he was 2 years back diagnosed with coronary artery disease, what were his symptoms? What did the cardiologist say, and why did they not do any intervention? Diagnosed. Yeah, that's what I'm asking.
With a history of chest, angina.
It is the same left lung disease with left side chest pain with some infection, you would have gone, isn't it?
Yes, sir.
So that being misinterpreted as coronary disease, or is there a real coronary artery disease that is diagnosed by an angiogram?
He said single vessel disease, probably
Single
they might have
vessel
undergone
disease,
angiogram.
Can this patient without coronary artery disease cause chest pain?
I have already answered.
So because of that left lung disease.
Destroyed cavitary lung, prone to recurrent infections, pleuritic pain.
And
If he goes to the cardiologist, he will diagnose cardiac pain.
Because of the left side pain.
Pulmonary hypertension is there, a minimal this thing. So some 35 you said, right?
Yes, sir.
Yeah. So that could be the cause of chest pain.
52-year-old gentleman, 30 years of history. Yeah. Okay, angio was done. It was a single vessel disease.
And they have opted for the medical management, sir.
So it was not a stenosis, severe stenosis.
Yes, sir.
Okay. 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 So now you have taken the cardiologist opinion, and he says is well cardiologically is fit to go ahead with your planned management. What do you want to do next?
I would plan for the left pneumonectomy, sir.
Anything else you would like to do before surgery?
For the preoperative optimization.
You have done bronchoscopy lavage, there are minimal secretions. Culture was E. coli, you have treated appropriately. How long will you treat?
2 weeks, sir.
And also while he is waiting for surgery, what type of respiratory rehabilitation will you do?
We will give the incentive, we will ask him to do the incentive spirometry.
All this matters for the final outcome when you operate.
You were here during Pradeep Narayan's class, I hope. You were listening to him? Huh?
They were taking the history, I think, yeah. They missed that. Yeah.
Okay. So, this patient is on anticoagulants, right?
Yes, sir,
Antiplatelets.
ecosprin.
So, you have to make sure that he has stopped his antiplatelets, right? Diabetic control. He can't have uncontrolled diabetes, right? For your wound healing and bronchial stump healing. And then, as Sir said, you have to stop smoking. Is he a smoker right now?
He's a tobacco chewer, you said, isn't it? Yeah. This is respiratory rehabilitation where he has to stop the tobacco. He has to see the chest physio, continue doing it, appropriate antibiotics, make sure that it is as dry as possible when you go to do it, because the left lung will be at the upper end when you do put into position for surgery. And what approach will you take?
But one question before that, in your pre-op preparation, what else is important for you? Anything you have been, sputum volume chart, the auscultatory findings on the normal lung, those things you will have to do before you take him up for a pneumonectomy. What are those things?
I think the boys are clueless. Why don't you tell them?
The sputum volume chart has got to be maintained so that you know that this much is the sputum. It has to be below 70 ml in 24 hours. Then you know that the left lung is not producing so much secretions. And you have got to auscultate the right side because the spillover will come to the right side. You take him up for surgery only when the right side is clear. You take up a patient coughing with crepitation on the right side, you'll have problems on the table.
In essence, you take 3 or 4 days or maybe at least a week to prepare this patient before surgery. Don't take him from this thing just because your load is high or something. He comes yesterday, tomorrow you do your pneumonectomy.
We will take some time for the prehabilitation.
Yeah. So that is the thing. Right?
Can I ask you a question, please? The youngster. Put the camera on the youngster, please.
Yeah, can you turn that side?
Yeah, why are you, my question to you is why are you operating on this patient? What is the benefit of surgery to the patient? What do you aim to achieve?
If you don't operate, what will you get?
So the patient has a long-standing history with troubling symptoms.
Speak in the mic. He's survived 20 years.
30 years,
30
no hemoptysis. Would you like to make non-operative management? That's what Zami's question.
What is the outcome of surgery? Why do you want to operate on this patient?
So
It's a very simple question.
if you are not operating the disease, if you are not operating, the disease can spread to the right lung also.
How?
We do the spillover of the secretions or the spillover from the infective material from the left lung.
That is one.
So what are you hoping to achieve? Two things you will achieve in this by taking out the left lung. What are the two things that you will achieve?
Removal of the disease.
Yeah, so you will prevent recurrent infections, correct? That's number one. And number two?
So improve the quality of life. Like he's having disturbed sleep or his routine activities is compromised.
Yeah, so symptom control and more importantly, a risk of hemoptysis, okay? So you have to tell the examiner why are you operating on the patient, and all of these are valid reasons to operate, okay?
If you really want to go by the guidelines for surgery for bronchiectasis, 2 or more admissions in a year because of the lower respiratory tract infections. This guy is still pretty well managing without getting infected because of the infection. But the symptoms are getting more for the last 1 year, and he has a coronary artery disease on the background, and is probably more fit now than 1 or 2 years down the line. You need to know why, what are the indications and why you are suggesting surgery for this given patient. Yes. Okay.
How much time we have? Pooja's gone.
Okay, continued. Why not? Yeah.
Okay.
These recurrent infection bronchiectasis, I have not seen a patient and over that developing a malignancy. Maybe literature, but in practice I have not seen. I don't think Krishna has.
Usually it is for a solitary cavitary lesion which can progress into a malignant lesion, but bronchiectasis generally doesn't go on to malignancy. Scar cancers are usually solitary lesions that progresses into malignancy. Because there is a scar there. Here this is a suppurative disease. Zamir, you have any?
Should we stop or should we ask them what approach to take and what steps do they do, or should we?
I think
this
we
is
should
enough.
talk about operative. Please ask him how to do the surgery.
Yeah. Have you seen a lung surgery in your institute?
Pneumonectomy, no, sir.
Any other lung form surgery?
Sir, decortication.
Okay. If you are the surgeon, you have passed your DNB or MCH, and if this is in your consultation room, what approach do you give them? What are you comfortable or confident?
Sir, I would offer him a thoracotomy approach, sir. Left thoracotomy approach.
That's fair enough. Why thoracotomy? Why are you thinking in
Left
terms of
anterolateral, lateral or posterolateral thoracotomy? Which space?
Left anterolateral thoracotomy.
Very good. So that means you will injure the solitary lung that is herniating from the opposite side. Yeah?
Did he say anterolateral? Did he say anterolateral?
Yes. He doesn't know, you have to forgive him.
So, yeah, probably it's okay. No, in this patient, the reason why I'm asking you is, you remember I told you that there is something about the CT scan that we saw and that the lung was herniating?
Yes, sir.
So when you do this patient, you are doing a posterolateral thoracotomy. You are going to open in the posterior portion first, make sure that you don't create a pneumothorax on the opposite side, and then go into the left hemithorax. It's important to do that because you have to safeguard that solitary right lung.
Yes, sir.
So why are you thinking in terms of thoracotomy rather than thoracoscopy? You have all the instruments in your institute. Patient as insurance, there is no cost limitation for you to use the staplers, but still you are talking about thoracotomy in this patient. Why? Whatever the risk complications I said, like patient can't afford, as a result you can't use too much of endostaplers, then also you go for thoracotomy. But in this patient you want to do thoracotomy. Why?
First thing you say, I don't have experience to do VATS or robotics. Okay.
Experience to do
Web surgery, video assisted.
Second, in this patient, the left hemithorax is of small volume with most of the right lung coming across. So manipulation of your instruments and then trying to get hold of the hilum of the left lung is going to be difficult in minimal invasive technique, right? Yes. So you are safer and to do under direct vision, 30-year-old lesion, 30-year-old disease will have a lot of additions. So it is much better to do it under vision carefully in an open method. These are the three things that you have to know in this patient, right?
I'm sure Zamir would prefer a minimal invasive. I would prefer a minimal invasive. There is no limitation onto the use of staplers. But adhesions, dense vascular adhesions, that's what will take time to release. And magnified view in thoracoscopy or robotic looks more bleeding than what it actually is. Go back to the chest X-ray, first chest X-ray that you showed.
Apart from small chest, anything else in the chest that will give you trouble? Yeah, X-ray.
Yeah.
What happens to
Small
media
chest, one. Anything else as compared to right?
Crowding of the ribs.
Crowding of ribs. So what you'll have to do?
Anybody in the boys?
We may
Any
have
of the boys?
Sir, rib resection, sir. Resection of...
Rib resection, correct. Yeah,
So I want
This is
I
what
want to ask,
Krishna was saying, that if you follow the trachea, right and left main bronchus goes all the way down. This is the left lung, that's all. This is the only left lung. Yeah, deviated to the left there. This is probably what you are seeing is compensated right lung. This one.
so can I ask them a question, please?
Please,
Intraoperatively,
Yeah.
what are your strategies to prevent a bronchopleural fistula in a pneumonectomy?
If you have come to this stage and this question is asked, you have more or less passed. But his question, did you understand his question? Yeah, go ahead, answer it.
Sir, adequate stump has to be left after pneumonectomy.
Long stump being left behind is a recipe for disasters. You should not leave behind a long stump in any lung surgery.
It's the other way around. You should try to go right up to the carina so that you don't leave a long stump.
that is why the bronchoscopy findings are very important.
Yeah. What else? What are the other strategies? How will you prevent a bronchopleural fistula in an infected case like this?
There will be multiple lymph nodes around the bronchus, sometimes calcified in this 30-year-old infection. Carefully take them all out and don't do too much of cautery, too much of dissection around the stump where you are going to staple. I prefer to staple, maybe Krishna may prefer to suture, but make sure the adequate vascularity is maintained and you go as close proximally as possible. Don't leave behind a long stump.
Do you want to cover the stump?
It's a left main bronchus. Once you staple it, it gets retracted under the arch of aorta and it gets buried by itself. So you do, and it's not a malignancy post radiotherapy. So I don't do any muzzle flap to cover it. Is that okay for you, Ali? Or do you want
I
to
am happy. I wanted him to answer that question.
They are clueless and they are lost. Leave
No,
them alone.
no. I wanted him to answer the question because on the left side, as he said, it retracts back into the mediastinum and the aorta and PA stop onto it. So you don't need to cover it with a muscle stump.
Maximum they have seen apparently is the decortication. They have not seen a lung resection, so they don't have an imagination.
No, so I want to give a feedback to CS.
Yeah.
My question is how much percentage of the exam is thoracic surgery?
Yeah.
And I really think CS you have to restart thoracic surgery education on the IX platform so that we teach these young boys simple things like how to do a thoracotomy, how to do a pneumonectomy. If somebody tells me anterolateral approach for a pneumonectomy, I'm very concerned. So I think there's an urgent need to restart thoracic surgery teaching. for our Indian residents?
Well, Zamir, we have only 3 centers offering DNB thoracic surgery.
No, but these guys are
Cardiothoracic
still going
residents
for
also
exam,
have
isn't
the
it?
case, thoracic case.
When they are with us, they go rotate through the thoracic surgery in our institution, where there is cardiothoracic unit. But in many institutions, it is purely thoracic, cardiac, or purely thoracic.
Ali's suggestion is, can we restart the monthly teaching program through the ISTSD online program, where they get, even whenever they are post those recorded videos into the website, if not on the live presentation and discussion, at least at the time of exam going, they can go back and visit those case discussions.
I think,
and
Zamir,
don't make
we have to-
basic blunders like this in the exam.
Zamir, we have to revive the thoracic gurus.
Yes, we have to, I think. I realize that now.
Yeah.
And I'm all of us in the room are very happy to contribute. I think we need to revise the thoracic gurus and
All
restart.
these discussions should be recorded and posted in a website, so that when you go back home and then revisit your own presentation, you realize a lot more than what you are realizing now.
I'm very sorry, it's not a
Yeah.
criticism of the candidates.
Yeah.
What about the intercostal drain management in this case?
Correct, very good
You
question.
would like to place a drain? If at all, how many drains?
Will you place a drain? Advantage, disadvantage. Advantage,
You can know any bleeding or any.
you can know any bleeding.
Correct.
Is there any need for drain?
Yes.
Why? Mediastinum is already shifted and fixed. The right lung is already herniated. The left lung is already shrunken. Okay? So these are the questions which I'm sure, Shri Krishna, any definite answer to this?
Yes. Why we put in a drain? We put in a drain to see whether there is any post-op bleeding. And the drain management is exceedingly important. We don't keep the drain open because of one single thing. Because as the patient is breathing, there is something called pendulum movement of the mediastinum, which may not actually occur in this patient because this is post-tuberculosis fixed. But many a time when you do a pneumonectomy, it can go up. One, because of that pendulum movement, it kinks the SVC and the IVC from the heart, as it enters the heart. So the venous return gets affected. There is low venous return, low preload, and subsequent low cardiac output. One. Second, the movement of this thing itself can trigger arrhythmias. All right? So to prevent pendulum movement, you clamp the tube and release it every 2 hours, so that you know whether there is any ongoing bleeding and whether you have to take him back for exploration. And lastly, you don't keep this tube too long, because in our system, it can never be very sterile. So there is ascending infection. So after making sure that there is no ongoing bleeding, please take it out. All right?
You said how many drains? Two.
One.
Post-pneumonectomy,
Post-pneumonectomy,
one
only
drain.
one.
It has to be clamped. Don't.
Why you require 2 drains? There's nothing over there.
Okay, for the sake of clarity, conventionally after thoracotomy in the good olden days, one apex, one to the base. One to the apex to drain the air, one to the base to blood. Basal for blood, apex for the air. In the air, as of today, when we do thoracoscopic surgery, whatever you do, decortication, pneumonectomy, lobectomy, we usually practice one drain. But if your examiners are good old examiners, and if you are giving the answer, I do thoracotomy, decortication, or thoracotomy, upper lobectomy, and if you say I place 2 drains, you are safe.
Even
Patient, one
even
drain.
after pneumonectomy,
This patient, pneumonectomy, only one drain.
only one drain.
Suppose you are operating, patient developed desaturation. So what would be the cause at that time? Particularly in this patient.
So it can be trauma to the right lung, causing pneumothorax.
Patient is under positive pressure breathing. So what are you worried about pneumothorax?
but it will aggravate the pneumothorax, sir.
Patient is positively ventilated by anesthetist. The pneumothorax is open pneumothorax, and not tension pneumothorax.
No, their question was, he has
Desaturation, but
desaturated, so he's saying because
pneumothorax, correct, but I am telling him this open pneumothorax, lung is ventilated.
Opposite lung, probably pneumothorax in the herniated lung.
That's a question for distinction actually. When you are operating, say, left upper lobectomy and sudden desaturation, one possibility, because most of them are smokers, emphysematus, pneumothorax on the opposite side. Moment you realize it, you turn the patient, put a drain on the opposite side, and then only go ahead. It's not always cardiac or something else.
Not
It can be a
secretions?
pneumothorax on the
Secretions?
secretion spillover is also possibility that we will avoid by using a double human endotracheal tube and etc. I think it's time out. Ali, are there any final words of wisdom from you?
I've got
No,
one
I
question.
just want to tell everybody, there are 88 people on this group at the moment, that every Saturday morning at 9 o'clock, I do a 2-hour session for exam going students. I will share the link on Thoracic Gurus. Please, if you have not joined it, please join it. We teach very basic stuff all the way to advanced surgery. So please join it. You will learn. I just want to make sure that our boys learn thoracic surgery. It is part of the exam.
That's dedication, Ali. Good luck. And I'm
Every
sure it will
Saturday
help.
morning, 9 o'clock UK time, 2 hours I do a teaching. So please, everybody, 88 people, everybody log into the teaching. Join the Thoracic Guru's WhatsApp or send me a WhatsApp message. I'll log you onto the teaching.
What day you will suspect bronchopleural fistula?
She will enter. Okay, thank you very much. We will
Oh, sir,
conclude.
only one question.
Yeah, please, sir.
Which day you suspect bronchopleural fistula? Auspicious day. Post-op. First day, second day,
After
third day.
pneumonectomy, you put a drain and you have taken the drain out on the day 2 because there is no surgical bleeding. And then what do you expect when you see the X-ray in a post-pneumonectomy patient? It's not like the other
These
patients
are
where the lung is
homework
fully
for all of
expanded
you.
because entire lung is removed.
And what is the sign and symptom of bronchopleural fistula?
First, they need to know what to expect in a post-operative X-ray in a patient after pneumonectomy. Then you can answer this question.
How frequently do you do the X-ray in the post-pneumonectomy? And what do you see in that X-ray? Other two questions are, how does this patient go to the theatre and how does he come out of the theatre?
Sir, second
And the
question.
double lumen tube, both, all these questions you have to know for your exams.
Sir, for the second question, can I attempt, sir?
How do you shift him to theatre? How do you shift him out of theatre? Which side goes up, which side goes down? That's what I'm asking.
Sir, the side to be operated on, the disease side will be down. Will be down. When he's going in, sir.
We'll do a session on pneumonectomy. Guys, this is urgent.
I think it's time out. You, in the post-operative X-ray, you expect a air fluid level after pneumonectomy. Okay, it fills up to the mid-chest level, generally. Don't think that is a complication. That's how a post-pneumonectomy space looks like on the X-ray. In the immediate post-operative period, usually around day 10 or day 14, if there is a sudden increase in the cough and there is sudden decrease in the air fluid level, that's when you suspect a bronchopleural fistula. Okay? Thank you.
Okay, thanks, Zamir.
Good luck. Good luck. Thank you, Zamir.
Thank you very much.
Yeah, thank you, Dr. Ali Zamir Khan. Just based on the performance, just a few comments as we close.
The one comment I want to make is that you lead the examiner. Don't let the examiner lead you. Yeah, you lead the examiner. You tell him whatever, if the examiner is talking, that means you're not doing well. So you lead the examiner.
Dr. Hiremat and Dr. Sri Krishna are the actual examiners.
No, thank you. Thank you, sir. Thank you, Dr. Ali Zamir Khan, for sparing
Thank
your
you,
time
Ali.
on a
Nice
Sunday.
meeting you. Nice talking
Thank
to
you
you.
very much.
Bye, guys. Take care. Bye-bye.
Yes. Thank you, sir. Thank you, sir. Just I would like to felicitate our examiners. Dr. Sri Krishna, Dr. Rajshekar Reddy and Dr. Shivswamy.
Welcome back, everyone. We will now move on to the session that explains the art of history taking and examination in patients who have been operated earlier. This patient population is a growing base for our upcoming generations of surgeons. Speaking to us on the art of history taking and examination of redo cases is Dr. O.P. Yadav. Dr. Yadav is CEO and Chief Cardiac Surgeon at National Heart Institute, New Delhi. He's former editor-in-chief in Indian Journal of Thoracic Surgery. Over to you, sir.
Good afternoon to you, ladies and gentlemen, and dear students. Your chance of getting a redo case has lately gone up. And that's because of the trends that in valvular heart disease, there is increasing volume of percutaneous procedures. Also, in previous surgeries, we might have used bioprosthesis. There is some suggestion that there is increased incidence of prosthetic valve endocarditis. The longevity has increased, and affordability and coverage also has increased, with Ayushman Bharat providing coverage for open heart surgeries. In coronary artery disease, however, even though there is some suggestion that the incidence may be decreasing because increased use of arterial grafts during primary surgery, because of improved pharmacotherapy, and if the patient has any issues, quite often it is handled with PCI. However, even if the relative numbers are decreasing, the absolute numbers are increasing because overall the volumes have increased phenomenally and more patients are undergoing percutaneous intervention and stenting. Now, redo surgery is not a simple procedure. Roselli et al. Has published that reoperation is not an independent predictor of mortality. Well, it may be for mavericks at the Texas Heart, but for an average surgeon, redo is challenging. It's technically demanding because there are mediastinal and pericardial adhesions, there is damage to surrounding structures, and there is increased risk of all kinds of complications after an open heart surgery. In fact, lesser the time to reoperation and more the number of reoperations, this risk increases pari passu. Also, these patients undergoing redo surgery have more advanced heart pathology, they have reduced physiological reserves, and their clinical profile is quite deteriorated from the primary surgery with increased comorbidities. It's been shown in a number of surgeries: elderly age, presence of heart failure, urgent surgery, patent coronary graft, prosthetic valve endocarditis, hepatic, renal, or peripheral vascular disease all increase the risk of redo surgery. So please don't go away with the idea that redo surgery is another primary surgery. Now, in history taking, some of the tenets of history taking are the same as those of the primary surgery. For example, when you visit the patient first, you must sanitize your hands, greet and introduce yourself, also confirm patient's identity, clear terms explain the patient why you are examining him or her, and gain their consent. Also, when you are finishing your consultation, you must recapitulate what you have extracted from the patient and make sure that that's the correct thing. You must thank the patient and ensure that all the furniture that you have disturbed or any other, like you have unbuttoned the patient, then you must button them back. Or if you have removed a sheet from the patient's legs, you must restore the sheet, so that you must restore that area to the shape that it was before your consultation. Make sure that during your consultation you are an active listener. You can signpost the patient if he is or she is wandering about, but by far and large, allow the patient to express in clarity and give them sufficient time, and then summarize within your own self what you have extracted out of the patient to have clarity of thoughts. Rest of the basic examination remains the same. The same symptoms have to be asked from the patient as primary surgery. Any history of pain, any history of breathing difficulty, palpitation, loss of consciousness, and so on and so forth. So all those relevant symptoms have to be asked. So I'm going to talk now only what is little that is different in a redo history. So to understand that, first let's understand what are the objects of taking a history in a redo case. First is that we not only want to diagnose the present problem, but we also want to diagnose what was the primary procedure. You know that a mitral valve replacement was done, but was it for an stenosis or for MR? That also has to be diagnosed. Secondly, you need to quantify what is the severity of the problem. Then you must know what are the reasons and mechanisms of failure, and they would be different. Maybe technical, maybe disease progression, and I will come to that a little later. Ask the question, does the patient really need redo, or are there any alternative therapies available? Has the patient taken adequate medical treatment, optimum medical or guideline-directed medical therapy? Can he be handled with a percutaneous option? All this you must bring out from your redo history. And then your history must help plan the second surgery. You must identify and then mitigate those risk factors. So you need to have, a quantification of what is the outcome that I am expecting from this procedure, and what are the risks involved in this procedure, and what is the risk reward of this procedure. And ultimately, you want to get a good long-term success. So how is the primary history? In a primary different. In the primary history, you always, arbitrarily say that patient was well for last 10 years, he has been having these symptoms. But here you have to anchor the symptoms to primary surgery and not just arbitrarily put a figure that the patient is sick from so-and-so date. And this duration is not just arbitrary, this helps you mechanistically decide what is the failure mode of this primary surgery. For example, in a valvular heart disease, if you have an early failure within 6 months or so, then you know that it was probably technical. Either the stitch that you took cut through, or there was white spacing and there is paravalvular leak. So early failure is pointing to a technical reason. Also, if a patient has early onset of fever with paravalvular leak, you know it may be prostatic valve endocarditis. However, if the same problem occurs, say 5 to 10 years later, it may be a pannus, a thrombus, or it may be a bioprosthetic valve structural degeneration, or it may be a progression of the native disease. You did an aortic valve replacement, but today he needs a mitral valve replacement. Similarly, in a post-CABG patients, there are classical 3 temporal time frame types of failure. Less than 30 days very early could be thrombotic because of poor anastomosis, raw areas. It may be iatrogenic that you caught the back wall. It may be because of incomplete revascularization. Similarly, patients failing early between 30 days and 1 year is usually because of the physiological fibroendothelial hyperplasia not stopping and continuing unabated and leading to stenosis. And late, more than 1 year, is usually atherosclerotic. Also, you must critically evaluate the functional status of the patient. For example, if the patient is NYHA class 1, then the mortality for surgery is only 1.6%, while in class 4, the mortality is 21%. So knowing functional status is extremely important for prognosticating the patient's chances of going through that surgery uneventfully. Then you must look for subtle signs and symptoms of heart failure. For example, a patient may just complain of fatigue, not really breathlessness on exertion. He may not complain of anything, but he may have restriction of activities. He may say, I'm totally asymptomatic. But when you ask him in detail, then you'll find that till 6 months back, he was walking 5 kilometers, but now he's walking only 3 kilometers. So this could be a sign of heart failure. So look for those certain signs of heart failure, that classical pedal edema, raised JVP may be absent in these patients. Similarly, for CAD, atypical symptoms may be present in half to 3/4 of patients, and they can be misled. You can be misled by musculoskeletal symptoms also in a patient of CAD, which usually occurs in 5 to 10% of patients, that they keep complaining of niggling pain in the chest, sternal dehiscence related, or even when the sternum is stable, those symptoms may be present. So you have to be very careful in analyzing these symptoms. Are they inguinal or not? Also check always on any recent change of signs symptoms. This question should be proactively asked, and that would give you a lot of valuable information regarding progression of the disease. Then you must look for any new risk factors that might have developed over a period of time from the last surgery. Patient may be non-diabetic then, but he may become diabetic over a period of time. Hypertension, chronic kidney disease, hypothyroidism, tobacco intake, all these risk factors must be looked into. Also, you must take history of any concomitant illness. They are elderly patients. They may have n number of other illnesses for which they may be taking drugs. Medication history, especially of antiplatelet, oral anticoagulants, is very important. They may need to be stopped before surgery. You may have to take a decision for bridging, and you have to start them post-operatively, so those histories are important. Also, the patient may be taking other drugs of concomitant illness which cannot be stopped during surgery and may have to be continued. Take history of any drug reaction or allergies. What was the experience of the previous anesthesia? And does the patient have any dentures or any loose teeth? Those histories should be proactively asked. Patient will not give these histories. You have to ask them and extract them out of the patient. Then it's extremely important, the most pithy, that we must get all the details of the primary surgery and what were the surgeon's experience then. And the mnemonic I suggest for this is WAH. There are 5 W's and a single H. The 5 W's are, what was the procedure? Why was it done? Was it mitral valve replacement? Okay. But why? Is it for stenosis or regurgitation? Implications are different. When was it done? Where was it done? By whom was it done? And lastly, the H, how was it done? What was the routing of conduits? What was the conduit used? For example, patient's rima might have been taken and grafted to the LAD. So you're crossing the midline and there are serious issues for a reduced sternotomy. These findings should be brought out during the history taking and from the old operation notes. What was the cannulation strategy? Was the pericardium closed or not? Any mishaps or difficulties during the last surgery? What was the post-operative course? Were there any complications? What was the hospital and ICU stay? All these are extremely important in finding out whether there was an uneventful period or were there any complications which can recur this time round. Also, one must find out, was there any indication for oral anticoagulant other than the present pathology, because then your choice may change. For example, patient has got atrial fibrillation. Now that's an indication for oral anticoagulation. So you will not like to give a bioprosthesis to this patient. You may like to give a mechanical prosthesis. In your clinical examination, you must look at the telltale signs of the previous surgery. Look and document all the scars, the sternotomy scar, or if the patient has a thoracotomy, the saphenous vein, the radial artery, intercostal tubes, femoral cannulation. Maybe there was an open cannulation and there may be a scar there. Look at the chest cage for any deformities, spines and joints. Elderly age group, these are very important. In a patient for CABG, look for any alternative conduits. What are their status? Look for radial artery, the Allen's test, the Long saphenous vein, is there some portion left which you can use this time round or not? Short saphenous vein, cephalic vein, they should all be evaluated. Look for signs of heart decompensation and heart failure. And I told you they may be subtle. If the patient is lying, there may be no pedal edema, there may be only sacral edema. Always examine groin, because you may need the groin for an emergency cannulation. You may need it for IBP insertion or just arterial or venous access for just monitoring. So always examine the groin, look at femoral artery and vein and any local infections and those kind of things. Always look for rhythm of the heart and if in atrial fibrillation, the pulse deficit. It's very important. Feel all peripheral pulsations. Important that you assess the patients for frailty, for body mass index, malnutrition, anemia. And they're much more important in the redo case than in the primary case. Does the patient have any cognitive dysfunction? Can he be relied upon for taking medication in the post-operative period? Or can his history that he's provided be relied upon? Look for any dental and ENT infections. In a cardiovascular examination, the standard auscultation, palpation, percussion, all those things will be the same. But important thing here, look for cardiomegaly, ventricular hypertrophy, the type of apex beat. These are very important. Look for prosthetic valve sound. Is there any muffling or are they absent? If they are totally crisp sound. Is there any murmur? Quantify that murmur. Degree of pulmonary arterial hypertension. Look for bruit in the carotid artery, in the subclavian artery, in the femoral artery. Look for abdominal bruit. These are all very important and they may give you very subtle indication to a disease process. In a coronary artery disease, always evaluate for alternative conduit, and one of the most important conduit is the radial artery. So palpate for calcification, do the Allen's test, and also always risk stratify this patient. Patient may have frailty. Look for the effort tolerance. Does the patient have any patent grafts? Does he have any clots if you have got an access to the echo report? Does the patient have any history of CVA in the past? All these are very important and they can be used to risk stratify the patient. There are multiple scores available, but the two most important are the STS and the European score. The STS-PROM is the Society of Thoracic Surgeon predicted rate of operative mortality, and the European Society Cardiac Operating Risk Evaluation Score 2. Both of them are good scores, but STS-PROM is dynamic. It looks or takes care of the evolving risk profile of the patient. It takes into account the type of the procedure, the mitral, the tricuspid, or the aortic, and also it tells about the outcomes. So STS-PROM probably takes a lead over Euroscore. Then you have to look and judge the level of the cognition of the patient. I just told you that can he be relied for medication? Is he capable of independent living? And look at, does he have a family support? So you may have to talk to the relatives to decipher all this and to understand what are their expectations from this procedure. So always talk to the relative if available, especially if the patient you think is not that reliable in his or her history. Always evaluate the cardiorespiratory fitness, as I've just told, from degree of frailty, from the handshake grip, how strong the handshake he gives you. You can walk with the patient, take them on the stairs, or put them through a 6-minute walk test and the breath holding test. These are some of the ways by which you can judge the cardiorespiratory fitness of this patient. Also, you must make sure that the patient has exhausted the optimum and the guideline-directed medical treatment. He's getting class 3 angina not just because he's taking only one anti-anginal or not any anti-anginal, but all the options available have been tried, and only then redo procedure should be offered to the patient. Also, in some of these end-stage patients, we must look at what is called futility assessment. That is this procedure that you are contemplating, is it worth doing? What are the survival chances of the patient? What is the expected longevity of the patient? And will he be functionally active after this surgery? And then look at what are the risks of the surgery and what are the what you are achieving from this surgery, and then do this risk-reward analysis, and then decide. Sometime you may feel that the surgery is futile, especially if you have got a wall-to-wall heart with a papery thin ventricular muscles, then you may not like to proceed with this surgery. But in all this, most important thing is that you have to keep the patient central, and the ESC 2025 guidelines have said that all decisions should be shared decision with the patient's consent. Ladies and gentlemen, it's very important that you think like a surgeon. Remember that redo is a re-entry problem first and a pathology later. So look at what are those issues which will create problem for you in a redo. Also present the story as a well-oiled structured story, relevant, presented in a chronological order. When was the first surgery done and how it was done? Then how was the recovery phase? Come to the hiatus of no symptoms till the present symptom. And each statement should be relevant, coherent, and must have a bearing on the treatment of the surgery. Don't give, ad hoc statements which have no bearing, and the examiner will then go on a tangent and you will be in trouble. A model presentation to start with could be in a coronary patient, a 60-year-old male, 8 years post-CABG with Lima to LAD and cephalosporin graft to OM and RCA, now presenting with progressive external dyspnea for 6 months, currently in NYHA class 2 functional status. For a valve, the same history. 10 years post mitral valve replacement, now presenting with progressive breathlessness on exertion or NYHA class 3, and the history continues. So present it in a flowing fashion rather than in a staccato manner, and bring out relevant histories in your presentation. For example, in a valve, always bring out history of anticoagulation and their compliance. What was the INR range? Did the patient have any bleeding episodes? Look at dental, oral, ENT hygiene, any contraindication to oral anticoagulation. That must always be found out. Any CVA, any piles which is uncontrolled, any history of infective endocarditis and thromboembolic episodes, all should be proactively asked for. These are not what patient will give you. You will have to ask this history. Also in coronary artery disease, lifestyle examination should be done, especially tobacco intake, the attitude to exercise, medicine compliance, any previous cerebral vascular accidents and peripheral vascular disease, renal issues, eye disease, means any subsystem involvement in the atherosclerotic process should be ruled out. Then when you present it to the examiner, your history and the examination, you should be crisp and pithy, and you must leave sufficient time for viva and question. Don't keep beating about the bush with your presentation of family history and personal history and start taking his vegetarian and eats with so many rotis and so many. No, nothing doing. Be very pithy and leave at least, if it's a 40-minute session, at least 15 minutes for question answer. If it's a 30-minute session, leave at least 10 minutes for question answer. So you must rehearse your presentation before you come to the examiner. Then you have to present the diagnosis. That's where you always falter. And the classical presentation for a valve heart disease should be a case of rheumatic heart disease, post-mitral valve replacement with a bioprosthesis 10 years back, now presenting with severe MR, probably due to structural failure. What is the NYHA class? Pulmonary hypertension, atrial fibrillation, heart failure absent, yes. LV function, RV function, evidence or no evidence of infective endocarditis, thromboembolic episode, CV or TIA, on or not anticoagulation, and if relevant, on penicillin prophylaxis or not. So the entire thing has to be presented. All these elements have to be presented in the history. In coronary artery disease, a triple vessel coronary artery disease with status 10-year post-CABG, 3 grafts, what is the NYHA class status, the ventricular function, pulmonary arterial hypertension, heart failure, yes, no, all coronary risk factors, history of TIA or CVA, on single or dual antiplatelet, all conduits are suitable, alternative conduits, Allen test, positive or negative if you are contemplating taking a radial artery, and whether there are any carotid or subclavian groove, because if you are taking right IMA, then if there is a subclavian groove, you may not like to, or you may like to investigate further. So these are constituents of a proper diagnosis, and they must be presented to the author, the examiner. Apart from that, ladies and gentlemen, there are few of my random, you can call them rantings or musings. Always try to present extempore. Don't read from the paper. So whenever you finish the examination of the patient, rehearse there only what I'm going to present, and anticipate common questions that an examiner may ask, and what are the answers that you are going to give. Rehearse them. And try to explain all signs and symptoms with a single diagnosis. Don't confuse by offering multiple diagnoses. Remember, findings are not as important as your logical reasoning. So always have a clinico-pathological reasoning and correlation of all your findings. Lead the examiners rather than be led by them. So do not commit to numerical numbers. He asks, suppose the examiner asks, what are the causes of chest pain? Don't say there are 5 causes. Just start with the numbers. Just start with the causes. You may say 2, 3, and the examiner may not ask the rest of them. Also, cheating is par for the course. So sensible cheating is smartness. Do that. Don't be stupid. If you have a finding which you cannot explain, try and quietly brush it under the carpet rather than bring it right in the fore in the beginning and be caught in that discussion which you are not able to take it forward. Also, you should never use slang in your language. You should not use abbreviations, and your body language must be confident. Your soft skills of etiquettes and manners are extremely important. Dress elegantly but simply. The shoes should be well polished, no frayed jeans, and ladies should be well clad. You may call me a maid chauvinist, but that's how the patients really respect the doctors when they walk the talk and are elegantly clad. Be always clean shaved, or if you sport a beard, it should be well-groomed beard, but don't present a disheveled looks, and be relaxed. Examiners are not your enemies, they are your friends. Don't be overawed with them, and don't smell a rat in every question that is asked out of you. So, ladies and gentlemen, stay calm and confident. That's my take-home message for you. Use common sense. Stay basic and analytical in your presentation. Risk stratify the patient, and always assess that is my outcome from this procedure worth the risk that you are telling the patient to take. And make sure that all options are exhausted before the redo is prescribed. All these are questions which have to be answered by your history and examination. And always don the sergeant's hat. Remember the mnemonic that I told you. WA, the 5 W's and 1 H. Why, what, when, where, and by whom, and how of the previous surgery. So, with that, ladies and gentlemen, I leave you with my best wishes for your examinations, and I hope you do well. Thank you very much.
Thank you so much, sir. So we shall now move on to our 5th case, clinical case presentation. This case presentation shall be for redo case. So I invite Dr. Sharath, Dr. Rachita, and Dr. Sejal to present. We have Professor V.V. Bashi, senior most aortic surgeon of our country and director of Institute of Cardiac and Advanced Aortic Disease at SRM Hospital, Chennai, online. Dr. Prasanna Simha sir won't be joining us.
Yeah.
Dr. Shiv Kumar Chaudhary sir from All India Institute of Medical Science online, and Dr. Rakesh Naik, Associate Professor of CTVS from Jaideva Hospital. we all request you to be on stage.
Yeah, I request Dr. Tendulkar and Sitaram also to be on stage. But please,
So the same rules apply, two residents
all three of you, please sit, sir.
Yeah, two residents present and, yeah.
So in Delhi, spearheaded by Dr. Jugal Mishra, half an hour discussion out of 45 minutes on operative notes in coronary. So operative notes, what sir told, in the redo case, going through them and understanding the implication of that note and knowing what is not mentioned and knowing what is mentioned is extremely important. Also a small exercise, if you operation notes not available, what stories from the patient will tell you about the operative findings. And another small, you go ahead, another small homework, midline scar, 25-year-old male, cyanosis.
Good morning everyone, we are presenting a redo case today. Our patient is...
Stop talking all that, just now doctor.
Our patient is... Yes sir.
How do you know redo case? Yes, go on
Our
talking.
patient is 56-year male Oma Shankar, farmer by occupation, coming from Anandpur district of Andhra Pradesh. He's a case
So
of...
why are you telling me Andhra Pradesh, Anandpur district? Yesterday I told you.
Yes sir.
Proximity to the center. Okay? So if the farmer, obviously is an adult patient, farmer, so unlikely to be cyanotic,
Yes,
if the active farmer, okay?
Yes, sir.
So likely to be a valve or a coronary patient. So importance is proximity to the center. So he has any trouble, how long he will take to reach the hospital. That should change your decision about the case management. Okay? Go ahead.
He's a case of...
woman or a lady or a boy or a girl instead of male and female.
Okay. Good suggestion.
He's a case of post-mitral valve replacement for...
How do you know?
History sir. I asked him history.
How do you know is a post-mitral valve replacement?
The OT note.
Why not mitral valve surgery?
He has given history of valve being replaced, hearing of the valve clip after surgery, and also patient was taking anticoagulants for prolonged duration for which he required to test.
Anticoagulation could be also for
AF.
AF. Also could be for clot found
Clot
at the time of first surgery.
Yes, sir.
Patient is also educated and he knows the valve also and the surgery also.
Okay. How do you say mitral valve? Patient says.
Patient said.
No, this is all you should know.
Yes sir, patient said.
It could be aortic valve.
Yes sir.
Sorry? Okay.
Yes sir.
Yes, sir.
TTK Chitra.
Okay. How will you find out whether it was TTK Chitra?
On X-ray, we can.
No. Before X-ray.
How
From by
can they-
asking questions.
Money and the
How
scheme
much
which
money
was-
is spent? So this is what I was telling you. If operation notes not available, these are the things you must ask the patient to elicit what kind of valve. Okay? If patient is blind, can the patient is deaf, can the patient hear operation, the valve clicks?
Yes sir.
How?
He can feel the
Anybody?
transmitter.
Bone
He can
conduction.
feel the conduction.
He hears, patient hears, not he hears, patient hears through bone conduction. So just be aware.
Yes sir.
Okay.
So he had undergone mitral valve replacement in 2007. In 2007 for rheumatic etiology of severe mitral regurgitation. He was on...
So rheumatic etiology also he told you?
Yes, sir. He told that, and he was saying that he was taking Panadol.
Anantapur, I think, which president? President Reddy, na? President Reddy. No, President of India. Sanjeev Reddy. Neelam Sanjeev Reddy, Anantapur district of
He
Andhra
was
Pradesh.
also taking injections
impressed.
before and after surgery.
Many of the doctors educated in city will not know all these things about.
He was on Panadol prophylaxis before also. So that
Okay,
patient
acha.
was-
That's a good way of telling. Okay.
Patient was on
So
regular...
can we have Dr. Basi and Shiv Chaudhary online, please? We are unable to see them. Yeah, please go ahead.
Patient was on regular prophylaxis post-surgery and he was compliant to the medications. And till last 2 years, when patient developed the symptoms of easy fatigability.
Good evening to all my friends.
Good evening, no sir, good afternoon.
Good afternoon.
Oh,
Sorry.
good afternoon, good afternoon.
Good afternoon. Sorry.
Thank you, Dr. Bashi and Dr. Suchodit for joining us. Thanks.
Yeah, thank you.
From Chennai.
So patient developed easy fatigability and dyspnea on exertion from last 2 years, followed by he developed orthopnea from last 2 years and on and off occurrence of palpitations from last 1 year. Patient
So what these symptoms tell you hemodynamically? First is dyspnea.
Dyspnea.
Valve replacement done,
Yes, sir.
now as dyspnea. What are the possibilities?
Either patient has developed a new lesion or progression of the dyspnea.
Which new lesion he will develop?
Other
Which
valve,
will give rise to dyspnea?
valve thrombosis or valve occlusion can be the
Number one is valve
Thrombosis or
thrombosis. Anything else?
patient could have developed a clot.
That is valve thrombosis.
No, in the LA, sir, not on the valve.
Why LA clot should give rise to dyspnea? Obstructing pulmonary
Palpitation.
vein? Obstructing pulmonary vein?
He might have developed a valve thrombosis.
Anything else that can give rise to dyspnea after valve replacement 2007, that is 19 years later. Prasanna Simha. Please come. Thank God. Good. Sir. Prasanna, you want me or Prasanna?
Sir, you have to be.
They don't want you. Sorry, the small little jest over here. Patient dyspneic, 19 years after MVR, one is valve thrombosis. Extremely compliant with medicines. Okay? 19 years, what happens to valve?
Paravalvular leak he might have.
19 years. Valve is assimilated into the body, man. Endothelium has formed.
Pannus.
Pannus. Okay? So number 2 is pannus. That too particularly in a patient who is compliant. Anything else?
Yes.
Yesterday Dr. Sampath Kumar was talking. That time you were looking into your mobile.
Coronary artery.
No. What is the age today?
56.
56.
Okay, we can give that. But
Anyway,
something else.
anything else? Dr. Sampath
Something.
Kumar was categorically
And-
saying something.
And how many years back?
19.
Years back.
20 years.
20 years back. Again, famous
Mitral apparatus. Yes. LV dysfunction.
late onset LV dysfunction. And then still a very famous photograph in our what's that textbook? 20 years. What was the story? Over 20 years, something can happen. X-ray, small heart at the time of surgery, big heart 20 years later. May not even be valve replacement. In your, what is that, Glenn, there is a beautiful picture, two pictures of the same patient 20 years apart.
So what was that?
It is LV cardioplegic protection may be suboptimal.
So typically seen when patients were operated
early.
prior to 1980.
80s.
Where every day we used to change our
Change our
cardioplegia and find out, we were searching for solutions. Am I right, sir?
Yes.
Bashi, sir?
Yeah,
You are from my era. That's why.
So even now, people have used suboptimal preservation.
Okay? So remember, myocardial LV dysfunction either because of not preserving subvalvular structure, then myocardial protection, now over a period of time, fibrosis, pannus, clot, depending upon patient's compliance. Anything else?
It have developed other valve.
Other valve. Which other valve?
Aortic valve.
Aortic valve. Very good.
Any other valve?
There are only one.
Tricuspid valve.
So tricuspid valve give rise to dyspnea?
No, sir.
No. But how will it give? No, actually, the answer is it can give rise to dyspnea. What is the mechanism? Huh? No. What happens is septal shift occurs. With the RV dysfunction, mitral valve replacement, torsion, that is the importance of full subvalvular preservation. Even MVR, by itself we have shown that it has been shown that the torsional mechanism is altered compared to a repair. So over a period of time, the septal motion alters and septum shifts this side, and that's why you have late onset LV dysfunction secondary to RV dysfunction.
But usually tricuspid valve gives rise to fatigue rather than dyspnea. Patient may confuse, but this patient seems to be extremely intelligent, knowing each and everything. Okay. No, really quite surprising. Okay, first was dyspnea. What else you said?
Easy fatigability.
Easy fatigability. So that falls in the category of tricuspid valve or RV dysfunction. Third complaint.
One thing happened. What is the relationship? What is the symptomatology change with the onset of TR in a patient who is having dyspnea?
First, easy fatigability, then
No.
dyspnea.
A
Patient is having dyspnea. Now he develops, I will tell you one more lesion. He develops PRTR. What happens to dyspnea? Worsens, same, less. Less. Why?
Because the pressure will be...
Because the pulmonary circuit congestion is now communicated to far more compliant systemic venous circuit. Okay? So remember, patient tells you I felt better. Yesterday in tetralogy of Fallot, we were discussing, patient is having complaints and the mother says, sorry, not tetralogy of Fallot, VSD. We were saying patient was having LRTI. Now LRTI has disappeared. Causes. So similarly, dyspnea disappears. So things may not be good, may be bad. Okay.
Patient also has orthopnea from last 2 years and on and off palpitation from last 1 year.
So on and off palpitation suggests what?
Atrial
fibrillation. Palpitation after exertion suggests what? Aortic valve disease. Okay? Palpitations on and off, not related to exertion, is typically of atrial fibrillation. Go ahead.
Patient is apparently already to...
Look, speak into bring that mic, malleable shaft, like cardioplegia cannula I saw today morning.
Patient was apparently already 2 years before and then...
Two sirs can hear. One is in Chennai, one is in Delhi. You have to reach up to them.
Patient was apparently already 2 years before, then he developed the present symptoms, which were insidious on onset and gradually progressed from NYHA 2 to NYHA 3 class.
So if symptoms have gradually progressed, what complications are ruled out?
Acute thrombosis.
Acute thrombosis. Anything else?
Stuck valve.
That is acute thrombosis, struck valve, disc struck, all ruled out. Anything else? AF with fast rate ruled out. Infective endocarditis ruled out for worsening of these complaints. Very good.
And these symptoms...
So you knew this, that when you tell insidiously progress, these are ruled out. Okay?
Yes, and all these symptoms are relieved on medication and on rest. Patient also has occasional palpitation from 1 year. There is no history of chest pain, no history of cough, hemoptysis or dizziness, no history of loss of consciousness or any blurring of visions, which rules out cerebrovascular events, and no history of sudden pain in the limbs or change in colors, thromboembolic phenomena ruled out, and no history of anorexia, nausea, vomiting or any pedal edema or...
Just as a point, I just want to that there are two types of examiners. For some, if you just say no history suggestive of a CVA, it would be enough. Yeah. But for example, if you have Dr. O.P. Yadav as your examiner, he asks that way, that you tell it ad verbatim. Yes. But many of us say that since you're already in MCH, you can skip those things and tell history suggestive of endocarditis, suggestive these things.
But you should be ready with 3 or 4 very typical features of infective endocarditis. Okay? Yes. Just remember. Chalo, go ahead.
No history of limb ischemia, no history of...
no history of?
Failure symptoms, sir.
Okay.
And no history of...
See, no history of failure symptoms after medication, without medication.
Without medication.
No, just now you said...
He's on diet.
Just now you said he is on
Medication complex.
No, you're saying this.
This failure after medication, no symptoms.
Yes, sir.
Okay.
Previous surgery, how can he not be on any medications?
He's on medication after medication, sir. No history of finger
You
or
know
joint
the
pains.
medications?
Yes.
Then you can tell the medications.
Next.
It's coming.
No recurrent or respiratory infections or anything. From the previous surgery, patient previously he was in the hospital post surgery for 7 days. It was
So
uneventful.
normal time, not abnormal time?
Normal time,
Normal
5
time.
to 7.
Anything else about previous stay you will ask? How many days he was in
ICU, and how many days ventilated?
and how many days
On
ventilated?
Yes, sir.
So all this will tell you the post-operative course.
Whether his wound healed without any
Healed without
issues.
any issues.
Is it a value for you if the wound healed without issues?
Yes.
Very much.
Yes, sir.
Yes, sir.
Okay?
Why?
Adhesions. Okay?
Yes, sir.
Infection, additions,
Yes, sir.
or else some
Difficult-
sternectomy,
Yes.
all may have been done. Flaps may have been done.
Okay.
He was discharged after 7 days from the hospital. Wound healed normally without any complications. In the past history, no other.
Also, how quickly he got back to work.
Yes.
That is equally important.
Yes.
Incision?
Midline sternotomy. Yes. No significant past history, previous any surgeries, family history uneventful, and personal.
Not uneventful.
No, not relevant.
Family history not,
Not
relevant
relevant.
to the present illness. These are the phrases you have to use. Family history not relevant to the present illness. It's a rheumatic heart disease. So family history may be relevant. Okay?
Yes. Personal history, he is not a smoker and not alcoholic, and no history of substance abuse. Patient has been newly diagnosed
Not
with
relevant to the present illness.
Present illness.
Next.
Patient has developed a new onset of type 2 diabetes and hypertension from last 1 year, for which he is on oral medications and he is compliant.
So
patient
can
is on
hypertension give rise to dyspnea in this case?
Yes, sir.
How?
LV.
LV hypertrophy,
hypertrophy,
LV dysfunction,
diastolic.
LV EDP, again same story.
Yes, sir.
Finally you have to reach LV EDP
LV.
every time.
Yes, sir. Patient is on the following medication. He is on tablet amiodarone 100 mg.
What is that?
Cardron.
What is that?
Cardron.
No, you are. How long has he been taking amiodarone?
From the time of first surgery. Sir.
Okay, now I'm going to ask you a question. Is this relevant to to him saying that I am now having fatigue, I am having dyspnea? And how will you investigate such a patient who has been taking for 20 years? Huh?
Are you sure? 20?
Are you sure he has been taking for 20 years? He has been taking?
No.
Because
Not
if he is
asked.
taking, it is definitely a very, 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 going to have implications on your surgery.
So currently he is taking
Currently, is
amiodarone.
Why amiodarone, history of prolonged use of amiodarone is important?
he was in from the before the first surgery. He was in atrial fibrillation.
No. I'm not bothered about that. I'm telling now he is saying I have had amiodarone for 20 years or 10 years or even 5 years. What is the problem that you in relevance to your case today? I will tell you he may not need even surgery at all. He is dyspneic and may not require surgery, not conventional cardiac surgery. Amiodarone causes pulmonary fibrosis. So you may be having lung issue rather than even a cardiac issue.
Particularly if he is taking for 20
years. Then another thing that they can become hypothyroid. So you may end up with inotropic resistance. He may be having actually hypothyroidism and becoming fatigued now. LV dysfunction. All those things will happen. So please be very careful. I've had patients with amiodarone who came with moderate MR and they're telling that to come referred for surgery and not requiring surgery but withdrawal of amiodarone.
Okay.
Be careful.
Okay. So what is amiodarone? Just one sentence.
Which class of
Anticoagulant.
Anti-arrhythmic,
Class
sir.
3 antiarrhythmic.
Class
Class
3
3
anti-arrhythmic.
antiarrhythmic drug.
Anti-arrhythmic. For his atrial fibrillation. Okay. Next medicine.
He's on digoxin 0.25 mg.
Achha, all medicine you must tell the dose also, and you should be aware that this is an adequate dose or not. Digoxin.
Digoxin 0.25 mg half OD, sir.
Okay.
For 5 days a week he's taking. And he's on tablet Ditor Plus 10/25 once a day.
What
he's
is
taking.
Ditor?
Torsemide
Torsemide and spironolactone.
Tablet torsemide and spironolactone.
So torsemide is
What?
which group?
Loop diuretic.
Loop diuretic, like Lasix.
Spironolactone is potassium sparing.
Is potassium sparing. Okay. That's why called Ditor. And why it is called plus?
Addition of spironolactone is.
Sure?
Yes, sir.
Or
Plain
the concentration is more. That also can result in plus.
Plain Ditor is torsemide and Ditor Plus is with spironolactone.
This has got 3 drugs.
Two, sir. Plain Ditor is torsemide, Ditor Plus is torsemide and spironolactone.
Okay.
And he was taking warfarin 2 mg. Now it has been stopped since the present admission.
Along with warfarin, what you should report?
INR.
You should report.
Sir, in the history only I have to mention it.
If he has been, what does it tell about the
Is he doing INR testing and reporting to his doctor and following the instructions?
Yes.
This part you have to tell immediately, part and parcel of that.
If 2 months he has not been taking this thing, what can it give you a clue about?
2 months not taking
No,
what?
sir, till present admission he had taken and now it has been stopped.
It has been stopped and not replaced with anything
By the
else.
doctors.
No, sir is asking if he's a defaulter. What
Is it a defaulter or has he stopped for some time intentionally and has it been replaced by something else, or if it has not been replaced by anything at all? They have implications.
It has been stopped since his admission right now, last three days.
4 days.
And is it been replaced with something?
Heparin, sir.
If not, say no. Okay?
So with the history, my probable diagnosis is
What can happen with patient in congestive cardiac failure taking warfarin?
it may worsen
No.
Worsen because of liver congestion. So liver produces all the clotting
clotting
factors.
factors.
So this will double engine ka sarkar.
Yes.
Okay?
Cardron, effect of Cardron on INR?
See, there are two effects.
Prolonged or short?
Shorten. Keep on looking at his eye.
Prolongs.
It gets prolonged.
Very good. Sir,
Yeah, I will ask one question.
please.
What is the most important thing in a valve replacement? You are doing a valve replacement on a patient. What are the most important things you tell the patient? Very important, because if the replacement of a valve is the introduction of another disease called the prosthetic disease. So what are the things you tell the patient?
That the patient,
We should tell about the type of a valve we are replacing, bioprosthetic or mechanical, and compliance of the medication and maintenance of the INR range and regular follow-ups.
and also patient should be watchful before any other surgery, that he has to tell that he's on this medication which will
First
need
of
to
all,
be
the
stopped.
medication can result in bleeding.
Bleeding.
Which how he or she should
Watchful
detect.
Watch
watchful
for
about the signs
bleeding
and
gums or in
Bleeding gums, or I'm interested in that.
malina or hematochezia or nasal
Hematuria.
bleed
Epistax.
or hematuria, or while walking patient might get
Please
even
remember,
develop-
another very commonly missed thing is headache. It can be
In
a sign
our
of a subarachnoid hemorrhage. Okay.
In our country, the most important, because patients come from remote parts of our country where, of course, now laboratory facilities are better available now. Educating the patient is the most important. What I do is, as soon as the patient is admitted in the ward, every day when you go for rounds, you have to tell the patient, this is what valve you are going to put. What is the advantage of this valve, and what are the problems of anticoagulation? You used to write in a piece of paper, show the anticoagulant tablet to them. People who are not educated, unfortunately, the rheumatic heart disease occurs in patients who are very poor, coming from a poor background. They may not have much education. So even the milligram of the tablet, actually, I remember once, olden days, acetylone tablet was available 1 milligram, 2 and 4 milligram.
Very common.
Taking 1 milligram tablet and taking 2 tablets. Suddenly, 1 milligram is out of stock and 4 milligram only was available. Patient took 4 milligram tablet for 3 days, got with the dilated people. This happened at CMC hospital when I was there. So it's very important that as a physician or surgeon, you are operating this patient, in a prosthetic valve in our country, educate the patient more, because valve replacement is a simple operation. Anybody can do. Cutting and stitching a valve is not a very, very difficult problem. So once you put it, it is a lifelong problem for the patient. So clearly the surgeon, and you should instruct your nurses and your assistants wherever you are there. That is the most important thing in prosthetic valve with an artificial mechanical valve in our country. All of you
Even
should
the
remember.
family should be educated, whole family. Shiv Chaudhary sir, anything you like to ask the students?
Sir, when you and Prasanna Sima are there, nothing is left for me to ask.
Still,
Please.
sir, you are in Delhi. Sir, you are in Delhi. Central
Delhi
government
questions are
always
not
interferes.
Non-interfering this time.
Nothing to be asked, sir?
Nothing to do.
Okay.
With the history, my probable diagnosis is acquired valvular heart disease, probably of aortic stenosis of rheumatism.
Prosthetic valve dysfunction. Why acquired valvular heart disease? Sir has told, no?
Yes, sir.
This is prosthetic valve disease. So patient has developed prosthetic valve dysfunction. What are the types of dysfunctions of prosthetic valve? Structural dysfunction
and function
and non-structural dysfunction. What are the non-structural dysfunctions? Paravalvular leak. These are non-structural dysfunctions. Structural dysfunctions are typically in biological valve. In olden days was in mechanical valve. Star Edward valve called ball variance. The ball is to become soft. So now all these valves are single cast and there is no structural dysfunction. These are all non-structural dysfunctions. Okay? So you straight away talk that this patient has got non-structural dysfunction or structural dysfunction, whatever you feel like. Okay? From the history.
We are and not in failure.
Okay.
From the history.
Are a patient on Diator Plus. And now we are saying, this is like my brother takes oral diabetic medicine, says, I am not diabetic. So he is in failure but controlled. He is in failure but controlled. Very good. Go ahead. Another way of knowing which valve is which institute patient underwent surgery. There is dedicated, you must know this history of valve surgery in India. Dr. Bashi comes from CMC Vellore. For years together, they put only one valve, that was Star Edward valve. So if you just know patient underwent surgery at CMC Vellore, you can be sure patient had Star Edward valve. Okay? So just be, there's another way of knowing which valve was implanted, knowing from the center. And where by the way, where patient underwent surgery? Here means? This hospital. Okay. Okay, go ahead.
On general examination, the patient was examined in a well-lit room under natural light after taking proper consent. The patient is well-oriented to time, place and person.
Can you tell us the relevant? Dr. Prasanna feels that we'll go on little higher level of discussion. Is that okay, Dr. Bashi?
Yeah, fine.
Yeah, so all that taking in writing consent with two witnesses' signature with stamp of the, just go fast forward and tell us relevant findings. Relevant, huh? Relevant is not positive. Relevant means will change the diagnosis. Could be absent this, may be relevant.
So pulse rate was 68 beats per minute. It was irregularly irregular and low volume pulse with a pulse deficit of 12 beats per minute.
Suggesting?
Atrial fibrillation.
This you continue as suggesting atrial fibrillation. So I don't spend time on that.
Yes, sir.
Okay.
No radial or radiofemoral delay and all.
62 is pulse rate or heart rate?
Pulse rates.
You know difference between pulse rate and heart rate?
Yes, sir.
So this patient's heart rate is 22, what difference you found?
12.
12. So even more than that. Okay.
All peripheral pulses were palpable.
Suggesting?
No peripheral vascular
No
disease.
emboli.
No emboli.
Any particular relevance?
In a redo case, in case we need to go for a peripheral cannulation, the femoral...
Very good.
Yes, another thing that you have to always say is that the groin has no infection because many of these patients maybe...
No general examination.
in general?
Acha.
You have to tell that.
Relevant. Everything relevant to tell.
Yes, sir.
Then?
Blood pressure was measured in a sitting position in the right arm, 130 by 80.
130 by?
80. Sir.
So what is ruled out?
AR is ruled
AR
out.
ruled.
On systemic examination, inspection.
When are you going to tell the scar?
Now.
Now. Okay.
Chest is bilaterally symmetrical. Patient has gynecomastia. Previous
Cause
median
of gynecomastia?
spironolactone.
Spironolactone. All three saying together. Great. 5 more minutes.
Yes, sir. Previous median.
Redo, we'll have a little quick play.
Previous median sternotomy scar present.
Okay.
Which healed with primary intention. 2 additional drain site scars present in the epigastric region.
Any other scar you tried to?
No other scars present.
Which scar?
In the left pleural,
Specifically?
pleural or in the groin region.
Drain scars?
Bilateral
Then
pleural.
pacemaker may not be scars, but pacemaker dots, pacing wires, and CMC, closed mitral valvotomy.
Anterolateral.
Okay.
Apical impulse was not visible. On palpation, the apex beat was located in the
Since
left.
we are running out of time, summarize the history, summarize the findings in 5 lines, which have anything of consequence.
Anything special in palpation?
Apex beat was displaced laterally.
Is displaced laterally.
Yes, sir.
Suggesting?
Lateral to the cardiomegaly.
Suggesting?
LV dysfunction.
MR. This valve dysfunction is giving rise to MR. You must know whether previous was for MR or MS. Okay?
Previous was for MR.
Okay.
And there was a heaving type of apex. And palpable thrill was present in the second right intercostal space.
They are all suggesting patient has developed aortic valve disease. A new aortic valve disease. Okay.
On percussion, the right heart border. Auscultation, S1, the valve click was present. Best heard in the mitral region. On S2 was soft. Grade 3, 4 by 6 ejection systolic murmur.
S2 is not soft. S2 is normally split and the P2 component is soft. S2 is not one sound. S2 are two sounds. So S2 is, say that, S2 is normally split with P2 component soft.
Is it just that you are hearing S1, S2? In this case?
Valve clicks.
You have
afterwards.
Okay.
So natural sounds, clicks. Okay. She has told clicks are well heard.
A grade 4 by 6 ejection systolic murmur with late peaking heard in the second right intercostal space with the diaphragm of the stethoscope with radiation to the carotids.
Right side, left side.
Right
side. So if the murmur is heard on the right side, what does it suggest?
Aortic.
Aorta is dilated. Important to you or not important?
Important, yes.
Important. So diagnosis?
By
the way, you must know Chitra gives rise to how many clicks? Opening click or closing click? Closing click.
It hits the
opening click difficult to hear. Yes. Which sounds are prosthetic sounds are acceptable and which prosthetic sounds are not acceptable? Short systolic murmurs in aortic area of prosthesis are acceptable, and ideally the resident, the follow-up doctor should make a note that it is grade 1 by 6 and heard over a short period. All diastolic murmurs are abnormal, whether aortic area or mitral area of any prosthesis. Okay? Just remember. So what is your diagnosis now?
Rheumatic. It's a rheumatic heart disease, status post mitral valve replacement with a mechanical valve 20 years back with severe AS with NYHA class 3 in atrial fibrillation with controlled ventricular rate with no evidence of infective endocarditis, thromboembolic events, CVA or TIA on anticoagulation with the history of Panadiol prophylaxis.
Chalo, who is discussing operative? Just describe redo sternotomy at your center.
What is your re-entry strategy?
Patient, we will do preparation before starting the surgery.
Okay, she got quick.
Okay, we will have groin area painted drape.
Will you do a CT scan on this patient?
Yes, sir.
At your center?
Yes, sir.
So why don't you say that? CT scan for what?
For seeing the retrosternal anatomy and the
Retrosternal anatomy. What anatomy could be present?
any of the structures if they are abutting or if there are any adhesions present.
Adhesions with the sternum.
Sternum.
Aneurysm from the previous
Dilatation.
cannulation sites.
Aortic
Okay?
Yes, sir.
And if this
And this patient, I will also like to see the annulus of the. I will also like to see the dilatation of the aorta because.
Sir,
will you do a coronary angiogram in this patient before that?
Yes, sir. Coronary angiogram also I will like to do.
because the patient is 56.
And diabetic, recent diabetic, we want to do coronary angio?
Yes.
So in that case, what
Plus
sort of-
diabetic also.
Yes, sir. Yes, sir. Coronary angiogram.
Yes, sir.
Will you do a CT coronary or regular angiogram? And
Re-
why?
re- conventional angiogram, sir.
Why?
More than 40 years of age, sir.
No, more than that. What is the issue in this particular case?
You yourself have gave the answer earlier. The reason for not doing a CT coronary angiogram. It will not be, no, you won't get a good picture.
You won't get a good image, no? You have a prosthesis, number one, and the patient is in atrial fibrillation. The rate may not,
Rate
the
may
gating
be
may
there.
be an issue. Sternal wires, all those
Another
sort of
important
things.
thing is, another important thing I want to tell you is from has he got a keloid?
No, sir. Clean scar, sir, without
So
any
in patients,
hyper.
just I want to tell you one thing is from my experience. See, big keloids and all, you can, earlier I thought you should excise the keloid. It's not necessary. You can
just
go
go
through
through
the keloid. Number one. Number two is, one thing in the keloid is there may be some subclinical infection bacteria in that. So what we do normally is, tell the patient to have a very soft toothbrush, okay? And then put in that area, in that hair follicle and area, about 1 week before. Clean, because local preparation is very important to prevent infection. I must tell you that most important thing in cardiac surgery is the asepsis. Meticulous asepsis, anything you do. That is the first thing to learn as a cardiac surgeon. Everywhere, whatever, any amount of asepsis is not enough, because as you know, a patient gets infection, everything, whatever good surgery has gone, you have done is gone for a 6. So cleaning with the antibiotic and antibiotic ointment, that is this mupirocin ointment, you make the patient smear about 1 week daily before surgery is very, very helpful. Just want to tell you one important point which I follow.
I asked the patient to have painting of betadine 3 days prior, morning, evening. So the previous girl, what's your name, dear? Rajita should have said the midline sternotomy scar healed by primary
I think she said it.
She's that?
She said it.
Okay, sorry.
Then
Okay.
Femoral Doppler also I will like to
So
do for
from
the
infection point of view, groin comes under what area?
perineal and groin.
Groin comes under potentially infective. This is clean, always clean. These are potentially infective.
Then?
Okay.
Investigations.
CT scan and coronary angio. Patient on table. You will keep femoral artery cannulated or just exposed.
Cannulated. sir.
Femoral vein?
Vein also cannulated.
Vein also cannulated. Okay, done. Right side, left side?
Right side. sir.
Why right side?
Left side will have a longer course and difficulty.
Longer course?
And difficulty.
Medtronic
No,
gives
no,
you a
no.
long
Long kaddi.
right femoral vein is
goes
in line
with the
with right femoral vein
IVC.
with
IVC.
IVC.
Left will cross over and grow.
Why do you still take it is because of the tango appearance of the femoral artery, the femorals, the iliacs crossing over one another.
So left side, the iliac crosses
Crosses
the
over the
femoral
femoral.
vein. Okay, done. Expose. Next.
We'll, after we have cannulated, then we will go to sternotomy, sir. Midline sternotomy, I will be planned with oscillating saw.
With oscillating saw.
Yes, sir. And
What is typical of oscillating saw?
it will not go to the soft.
It punctures the sternum, outer table and inner
Inner
table.
table.
And I
It will
don't
not
remove
the soft
I don't remove the sternal wires.
What is done? You can describe what is
Yes,
done.
yes, sir. So we will put Langenbach, we will dissect the xiphoid area and the suprasternal notch, put the Langenbach, and the assistant will retract it and pull the sternum up. Then we will
Same
go
thing can be achieved by cutting the wires but not removing the wires and pulling
it
the
on.
wires with wire holder.
Holder.
So moment the sternal saw, redo saw, oscillating saw touches the wire, you hear a
Give way.
different sound. And plus the person doing it, so you puncture like the stapled paper of a receipt book. Okay? Next step,
When we have opened
you take a heavy scissor,
and cut the inner.
lift the lower margin and join all the holes. Anesthetist should be warned during all this time, they have to hold on with the ventilation.
Just for your information, because see, Dr. Bashiv has and Dr. Upi Yadav don't electively go on bypass for most of the cases, and they say that because of heparin and this thing. But you can always tell what is done in your institute, because, for example, I am conservative. I use one statement which sir used to tell, that it's easy to be brave with somebody else's heart, he used to tell us. So we routinely keep the cannula in position. We may choose not to go on bypass or this thing, but we drain the patient.
Yes.
But some institutes feel the other way around. But be
That was a
agile enough to tell. And I say today, with people doing mixed left, right and center with femoral cannulation, there should be no.
How do you drain the patient?
Before surgery,
How
we
do you
will
do that?
we will
perfuse?
we will take autologous blood.
Perfuse just releases the recirculation line and blood comes back from the aorta. Okay? And
Conditions where you have to go on bypass in a redo surgery.
Yeah.
When we in CT scan, we will know that the structures are adherent or very close to the sternum. Then while
no CT scan available, still you will say
chest
this
X-ray,
case.
lateral chest
No lateral chest X-ray. On table.
Hemodynamic.
High CVP.
High CVP.
Where you expect RV to be touching. Ascending aortic aneurysms suspected. Lima or Rima near the midline. So all these situations, you better go on bypass. Okay, now you are lifted the wires, and as you go on cutting with Mayo scissor, you go on removing one wire. Okay, sternum fully open. Now tell me the exactly next step.
We will put cat's paw, and we will the assistant will hold. We will put it in the marrow, and the assistant will hold and retract it with the weight, and the surgeon will
The way you are showing should not be done. Okay?
It will fall back.
The surgeon will just guide you how much to retract.
Yes, sir.
What is the danger of this step which you showed?
The structures which are closed will tear and open up and bleed.
Okay? So surgeon will guide you that retract more. And the first step,
To open the pleura.
I call it wind wiper of a car, wind glass wiper of the glass. The surgeon releases the RV from the sternum, from below up, from up to below.
I call it India
Below
file.
up, keep on doing like this, and slowly
India
you start
file.
releasing.
The Red Indians would walk one behind the other to hide the number of people there. So always go like this. And why do you use this wind wiper or India file method?
Equally, we should open. Also, retraction will be easy.
No. There is something very, very important. You go like this, and then you go like this. You go like this. You can go down in this thing, then go down like this. Why not that way?
We have to reach that we can open the pleura. If we go in one depth, we
Yes,
will miss the
agreed.
plane.
But why not? I will say, let us open only like this.
But then we cannot retract adequately.
No. Saindavas are there. Very strong fellows.
So they forgot one external paddles.
No, she told external pad. At that time, the thing went
Okay.
over. So why? Because you should not get into a deep cul-de-sac with bleeding suddenly occurring, which you cannot address. Simultaneously, another thing that we should always tell the nurse when we are opening the thing. One is you say saw, ghee, everything. Now during the dissection, something else the nurse must be keep ready always. Which I tell, they shouldn't go running around for it at that time. What do we keep? No, defib patch has been put. you always have her keep a 5-0 suture ready or this thing, because many people keep it in a dabba there and start searching and running for it.
May not keep because this is a valve case.
Yeah, but you keep it in her pocket or keep it somewhere that you should have access to a 5-0, because if you get bleeding at this stage.
Another thing, you must always keep a wire connection attached to the venous and arterial line. You may require an additional cannulation, additional venous cannulation.
And we always keep in our hospital even a Y for the artery. If there is any problem with the femoral, we can put the additional artery.
Then what is your plan for ventricular adhesiolysis? Your plan.
First, we are draining so the ventricle will be decompressed. Second,
you are released the sternum, both sterni halves, you are released. Now you put a spreader. Now next step is to release the ventricle from the pericardium. Adhesiolysis.
I will avoid that. Only whatever areas are required for the surgery, I will do dissection and use.
So you will not do any adhesiolysis.
Need may come, the part of pericardium is left on.
In a redo case, redo open heart case, I straight away open the left pleura.
Bilateral pleura.
So this may be required for air removal. If the patient has got aortic valve disease, echo may show grade 1 AR, so LV distension. So you must have control over, I'm an old style surgeon, control over LV is far more important to get. Okay?
If you, for example, find extensive adhesions, we find it very difficult. What is the approach that you can use to, in this sort of cases, to vent the LV at this, if required?
We can directly put a vent in the upper.
You have not reached the apex. I'm just saying, you open, you find adhesion, left pleura full of adhesions. Normally we try to enter into the pleura and you can put your hand and this thing, but now I can't do that. I'm finding rock. What is the other alternative for you? You're only seeing the anterior surface of the RV.
We want to cannulate.
I want to vent.
RSPV.
MPA.
You have not reached the RSPV.
You can do MPA.
Yeah, but I want directly to vent the LV. I want direct LV venting because of AR.
Through RV.
How do you do it through RV?
Not to my knowledge.
What you can do is you can take a thick cannula and put it from transeptal into the LV and you can directly vent the LV.
In such cases, I do through MPA.
Yeah.
Yes, sir.
Another thing, see if the patient has got a lot of adhesions and you find it very difficult, you can make a small incision in the fifth intercostal space also.
And dissect out.
Just you can stick into the ventricle
into the apex. You can do
it
into the apex.
We do that in a very third time or fourth time redo aortas, where the patient comes with a severe. As soon as you go on bypass, the LV will get distended. So this technique is described. Like at the apex, you can stick in a small left ventricular vent to decompress the LV. That, of course, is an advanced cases only. Routine, I don't think you should know all these things.
Yeah.
Basic thing you should have. Yeah.
Suppose you had to do aortic cannulation, this case, not done femoral. What problem, just last question, what problem you will face while doing aortic cannulation in this case? The previous site of aortic cannulation will be
adhered.
Extremely
adhered and
scirrous.
Thick,
scirrous. And the technique of scoring and insertion. Do you do by that technique?
Yes, cannot be done.
May not be successful. You have to incise nicely and insert the cannula. Same thing about cardioplegia. Of course, this is an aortic valve. You'll have to do a
higher cannula.
And another thing that I just want
cannulation.
One important thing, just one question, because she's asking to close. What are your strategies for exposure of the structures and during this thing? What are the minimum strategy? Like, how do you strategize your dissection? What are the most important things that I need to have? A, B, C. I go up progressively like that. What is the most overwhelming requirement?
Cardioplegia site and cross clamp.
Aorta. For cross clamping.
Cross clamping.
I need to have a good exposed aorta for
So
cross.
first you should go for aorta.
Aorta.
Aortic cannulation, aortic cross clamp,
Cross
aortic cardioplegia.
Cardioplegia.
Next
And the
is
most
RA.
important thing in a reoperation, the most important thing in reoperation dissection. Of course, it comes with a lot of experience. In the beginning, you may not get it. Identify the plane. When you dissect through the plane, bleeding, you won't believe me. The bleeding will be minimal. And to get inside the pericardium, most of the time pericardium will be there. The number one point you have to look is as soon as you open, you identify the pericardium and go inside that. So that always there will be, even if it's third time, second time or fourth time redo also, if you get into the pericardium is there, always there will be a plane, number one. Number two is, use a low grade diathermy always to dissect. Of course, when in the beginning you should use scissors. Sometimes it can produce arrhythmias, but make sure it is bone dry before in a reoperation. Most important thing is hemostasis. When you go in, it should be like before heparinization, the chest should be like as you are about to close the chest. If you go in like that, reoperation patients bleed less than primary operation.
Yeah,
Believe
very
me.
common.
That is slow and dry rather than wet and fast.
So which are the areas where pericardial adhesion and heart, there is a space?
In the
Over the aorta.
aorta.
And number two, diaphragmatic
Diaphragmatic
surface of the heart. So don't first go to the right atrial side. And what sir was telling, the right plane. If you see too much glistening RA,
It's
you
a wrong
are a wrong plane.
Dark
The
blue
RA should be
white.
dull, buff. Old photographs, buff printing. That kind of look of RA, you are in the correct plane. If you get too much glistening,
you are in the wrong plane and it will not
it will tear
and bleed
as
and bleed.
early as possible. And all the previous cannulation sites are badly adherent. And if the previous olden days cannulation site was through with the plastic right angle cannula, it is through RA appendage. And that is absolutely anterior. And it is absolutely adherent. So in such places, what you do?
We will cannulate the SVC, sir.
No. RA appendage is stuck.
We will not open.
We'll take
You will leave a pericardial patch over the RA. Okay? Yeah. Chalo. Thank you very much.
Thank you, sir.
Thank you.
Another question will be which valve now?
Mechanical valve.
This patient is 53. Patient is 73. Which valve now?
Mechanical valve.
No.
53-year-old.
You have to defend what you say.
Previously already has.
Sir, we are closing. Bashi sir.
Yeah.
Point over hai.
Yeah. Thank you. All
Thank
the
you.
best for you. All the students. Sorry I couldn't come, but I wish everybody the very best for your exam. Do well. Work hard.
Where is Shiv sir?
When you told him you don't want a PAVI, I think it's discontinued, I think.
Sir, discontinued?
Yeah.
Okay.
No problem. Sir, Dr. Bashi, thank you, sir, for joining us
Bashi,
online.
sir.
My pleasure.
Dr. Bashi is the senior most cardiac surgeon current in the country doing most of the aortic work. And till last 12 years, he has never missed a score program. That's the passion of teaching. Thank you, sir, for being there.
Thank you very much for calling me again and again. Thank you.
We shall move on to our final clinical case presentation. This presentation shall be of cyanotic congenital heart disease. Our examiners are requested to join us. Dr. Balram Iron from All India Institute, joining us online. Dr. Krishna from New Delhi, Dr. Sitaram Bhatt, and we have Dr. Devguru sir from All India to join us online. Dr. Ashraf, Dr. Nihal and Dr. Rajdeep, please come on stage. Are you over there?
And for one more change, the topic on function of valves by Dr. Shukla. So, know my valves, Dr. Shukla had an emergency to go back and operate. So, I have changed what valves we have explanted in our institute. I have a collection of valves. So, it will be a live demonstration on the discussion of valves by Dr. Tendulkar only. No preparation, this is a sudden allotment given. No. Okay, both of them will be there because both of them.
Good evening, sir. Balram, sir, good evening. Dr. Sitaram
Good evening,
Bhatt here.
sir.
Sitaram Bhatt here.
How are you?
I am fine. How are you?
I am good.
Good. Okay, yeah, we have got. The organizing secretary tells me that yesterday we finished the history, clinical science and all. So directly we will go to the diagnosis and then the operative steps. He wants me to concentrate more on the surgical part of it rather than the history stuff like that. So we will go that way, sir?
Okay, good, no problem.
Fine. Yeah, come on. What is the diagnosis?
Yes, a very good afternoon, sir. Respected faculty and my dear colleagues. Based on my history and clinical...
What is your diagnosis?
What is your diagnosis? Please avoid the thing in the exam.
Cyanotic congenital heart disease with fallow physiology with decreased pulmonary blood flow, most likely tetralogy of fallow.
Why did you say the tetralogy of fallow?
Age of the patient should be mentioned in the diagnosis.
Yes, so 14.
No cyanotic spells, infected endocarditis,
Normal
part of the diagnosis.
Yes.
So again you start.
What is the age of the patient?
14 years of age, yes.
14 years.
14 years.
14 years.
Yes.
Okay.
So why did you say that the patient has got TOF?
There was a delayed onset of cyanosis presentation.
History-wise, examination-wise.
First opening line, 14-year-old blue.
Yes.
Yesterday I told, no?
Yes, the age of the child.
Okay.
Based on his...
At 14 years it is tetralogy.
Yes.
Come
Based
on.
on my history, the age of the child, sir.
Okay.
The complaints of delayed onset of cyanosis. The child did give history of spells, which was elicited by the mother, not by the child.
Okay.
There was
History of squatting.
History of squatting, sir.
Okay, so patient is a cyanotic patient, delayed onset cyanosis with a history of spells and squatting relieving the spell.
Yes.
History-wise, you made a diagnosis of tetraphysiology.
Yes.
Examination-wise?
On inspection, there was a quiet precordium.
Silent precordium or quiet precordium?
Quiet precordium inspection, silent precordium on the auscultation.
Okay.
On the auscultation, there was no thrill present, there was no heave present. There was on auscultation, there was an ejection systolic murmur.
Before auscultation, can you tell me something
in the
about
percussion, there was
JVP.
It was a normal JVP, sir.
Okay.
And on percussion, there was a dull note.
Forget about it.
Smaller, yes. Normal. The apex was
smaller.
Yes. On palpation, the apex also was between inside the mid-clavicular line. It was a small. There was no cardiomegaly present based on the examination.
Sounds.
On the auscultation.
Just one more thing, you have to mention heave.
Yes.
Okay.
On auscultation, S1 was normal. S2 was loud. I could not.
S2 was loud.
S2 was loud.
And
S2 was loud and
S2 was single and formed by aortic component.
S2 was single and formed by the aortic component. Yes. There was an ejection systolic murmur heard in the third and fourth intercostal space with a grade of 3 by 6. Sir.
Okay. So you made a diagnosis of what next?
I would like to confirm my diagnosis.
Confirm your diagnosis what?
With a chest X-ray first. And
what do you expect?
In the chest X-ray, I would expect a RV kind of apex, a CT ratio of around 0.5 to 0.6. Not cardiomegaly would not be present. An RV type of apex. The pulmonary. So based on my clinical examination, where I found on percussion there was a dull knot on the third and fourth intercostal space. In this, I would expect the X-ray to have a pulmonary artery will not be concave shaped. It might be
segment will be seen.
Full will be seen. Yes.
Okay.
Yes. And RA. That's all.
Okay. How do you confirm the diagnosis?
I would like to get echocardiography done.
What in echo you will see?
I would first like to see the site of the VSD, number of VSDs that are present, the pulmonary valve, the annulus, the infundibulum, and the pulmonary arteries. If there is any RVO.
Will you see whether the heart has concordant and normal relations of the great arteries? Is it situs solitus?
Yes, I would confirm that first. Situs solitus, normal related great arteries.
What is situs solitus?
AV concordance, VA concordance,
the
relationship of the great arteries.
The right atrial appendage is normally seen on the right side.
What is the meaning of situs solitus? One sentence. The unpaired organs are on their respective,
On the respective
sides.
sides. Unpaired
In
organs
one
are on the
sentence.
respective
That is
sides.
situs solitus.
Yes.
Okay. Then,
Then the pulmonary valve would need to be assessed.
Okay.
The annulus and the pulmonary arteries also, the branch pulmonary arteries need to be assessed.
so you look for the VSD. What is describe the VSD of tetra?
Subaortic VSD. Subaortic VSD, it is a malaligned, non-restrictive subaortic VSD, large VSD.
Large VSD.
Large,
So
large malaligned subaortic, non-restrictive VSD.
Yeah, and you look for the additional VSDs and RUOT.
Obstructions.
RUOT morphology, where the obstruction, where all can be the obstruction.
Can be at the infundibular level, valvular level, subvalvular level, supravalvular level, sir.
At the valvular level, what are
Annular
the mechanism
annular
of
level.
obstruction?
Mechanism at
Because of the anteriorly deviated infundibular septum, it causes the
Bicuspid aortic valve, leaflet tethering, commissural fusion,
Yes.
annulus, narrow annulus.
Yes.
Okay, these are all the possibilities of the. Okay. Yes. What next? After that.
The CD echo report, next
the
page.
echo reports. I would like to, the echo report.
Yeah.
What is this one? What is this written?
Z-scores.
Hypoplastic right ventricle. Does it go with technology fellow? Will it go with the technology fellow?
So based on the history and the clinical examination, I came to the diagnosis of phallophysiology. So.
Some other cases echo, I think.
No, this,
Standby
this,
case echo.
This case echo.
That is the case that we totally.
So based on the history and the clinical examination, I could come to a diagnosis of only phallophysiology.
Now, but now you are seeing the echo report for the to confirm the diagnosis with hypoplastic right ventricle.
I would need to assess the RV volume and the, I would like to do a cardiac MRI to assess the RV function, RV volume.
Why you want to go for cardiac MRI? Is there any other investigation?
Transesophageal echo.
Transesophageal or the cardiac CT angio?
Yes.
Okay.
Okay, you are projecting ECG. What is the typical finding on the ECG for tetralogy of fellow?
Right axis deviation of 135 degree. There will be
tough ECG.
There will be early transition from V1 to V2 from R to
Yes,
S.
early transition. Okay.
Okay. Okay. So what do you want to do for this patient?
This patient?
You want to?
Uh,
You want to operate on this child?
You want to operate or not?
I would like to operate on the patient.
Why?
What information is missing on the echocardiography which is crucial?
The branch pulmonary arteries and the branch
Pulmonary arteries you can get on the echo. What is it? 14 years old. Tetralogy of fellow. Doesn't look like much
collaterals.
Collaterals, yes. Have you assessed collaterals?
So on clinical examination on the interscapular area there was no murmur.
Are you so good in the clinical examination that you can confirm that there is no collateral?
No, sir.
What would you like to do?
I'd like to do a CAT study to confirm.
Why CAT?
To assess the operability. To assess the operability of the. To assess the operability first.
Operability? You will do CAT?
CATs.
Or cardiac CT angio? Cardiac CT angio for the coronaries, MAPCAS, distal pulmonary artery tree.
Yes.
How do you know whether your pulmonary arteries are adequate or not?
Based on Magun's ratio and Nakata index.
What is Magun's ratio? What is Nakata's index?
The diameter of LPA plus RPA at the pre-branching level at systolic divided by the descending aorta at the level of the diaphragm.
Okay. What should be the ideal one?
More than 2, sir.
2.
More than 2, yes.
2 or more. Will be good. Okay. What about Nakata's index? What is it?
There is a square RPA plus cross-sectional area of the RPA plus the LPA divided by the body surface area of the patient.
Okay. So
why is it important?
Less than 100 value, intercardiac repair is contraindicated and we'll have to go for a palliative procedures.
Okay. So to decide what surgery?
Yes.
Okay. Now this patient, what is the Magun's ratio? Done? Echo? Where is echo?
Echo,
Excellent. Echo.
Echo of that
It's okay. We can go.
That patient, yes.
Yeah, this is the echo report of this patient. Okay.
No. There's some large osteums, right? Hypoplastic.
Yeah, it's Berene. Some other patients.
Hello, sir. You are there.
Tetralogy fellow patient.
No, this is not tetralogy. This is not tetralogy.
Okay, give
Okay, leave it. Now I will tell you, chambers, right ventricle hypertrophy, subaortic large perimembranous VSD, no additional VSDs, infundibular stenosis, low infundibular stenosis, pulmonary annulus, Z score -2, Megun's ratio 1.4, no major aortopulmonary collaterals. What next? Surgery indicated, not indicated, what surgery, and how do you do the surgery? We will discuss. Okay.
Surgery is indicated, sir.
Why surgery? What is the goal of surgery?
To alter the natural course of the disease and to improve quality and quantity of life of the child. 14 years.
Okay. So one for symptomatic relief,
Yes.
2 to alter the natural history of the disease. Yesterday we talked about the natural history, is it not? Okay. Now, so you have planned for the surgery. Next, tomorrow, patient is on the table. You tell me what will you do?
So I would plan for an intercardiac.
Your patient is on the table, lines are put in, sternotomy is done. Proceed now. Sternotomy is done. Proceed now.
So first I would like to instruct the perfusionist to also keep a higher level of hematocrit because the child has polycythemia.
All the things are taken care of. Now the patient is on the
We will
table.
not discuss about the perfusion strategies. Dr. Anil Tendulkar in the morning has only told you. Okay. You open the chest after that. Yeah.
Sternotomy done. Now it's
Sternotomy
proceed.
done.
Pericardial stays with silk 1 sutures I will take.
How do you open the pericardium?
To the right side to harvest for I'd like to harvest the pericardium.
Before you
to keep
open
for
the
a patch.
pericardium, you want to confirm something?
What do you check?
Before you open the pericardium, you will like to dissect out something and see whether it is present or not.
What? No.
You are seeing a vein
Right in
there
front
when you
of you.
open the chest there, which will tell you whether the patient may be having an LSVC or not. What is that vein? Innominate vein, you see.
Yes, innominate vein, whether it is there or not, whether it is of sufficient size or not. Sometimes there may be innominate vein, but it may be small. So in that case, there may be additional LSVC.
Yes.
Okay? Okay, now you open the pericardium where?
Towards the right side of the
To the right of the midline.
To the right
Okay.
of the midline. Once
Okay.
I will take the pericardial stays. I would like to do a bicaval cannulation for this.
No. What is obvious? Describe the external
Morphology.
morphology of a typical tetra patient.
Yes, the aorta would be anterior and would be very obvious. It would be large.
Dilated, aorta,
Anterior.
Aortas.
Transposition.
No, it is anterior
Aorta
cephalate.
is never anterior. It's
Right
rotated
angle.
posterior only, but not damn posterior. Rotated to the right.
Yes.
so dextroverted and anteriorly displaced
aorta.
and dextro-rotated.
Yes.
Clockwise rotation of the aorta, dilated. And the aorta is the prominent structure.
Yes.
Now you open the pericardium. What all you want to see now before you proceed with your bicaval cannulation?
Yeah.
You said bicaval cannulation. Before
Yes.
you do that,
So
after opening the pericardium, what do?
apart from the aorta, what are the other structures you see?
The MPA, the main pulmonary arteries. The size of the pulmonary arteries.
Size of the MPA.
Branch pulmonary.
Anomaly, any
Then-
anomaly which you will look for specifically
Something
related to MPA,
Any coronary crossing.
Coronary crossing.
RVOT, TD,
Conal branch from RCA crossing.
large conal branch. Very good.
There may be large conal branch or there may be anomalous LAD from the right. If
Suppose
you are
you
looking
see
at the anomaly, then you should see whether what is the relationship with the annulus.
whether it is.
How far down it is going, whether it is on the annulus,
Yes.
whether it is going about 1.5 centimeters below the annulus. Then you should confirm there is no LSVC.
There is
You
no
look for the
LSPC.
size of the pulmonary artery, size of the pulmonary annulus, RPA. Okay?
RPA, LPA size.
Yes,
Now, what is the weight of the patient?
34 kgs.
34 kg. What cannulas you want to take?
So for the SPC, for the aortic cannula, I'd want a 22 French EOPA cannula.
22. Why you want to go for 22? It is only 18 kg child.
18 French EOPA cannula, sir.
You can take 18. If you want, you can take 20 because the aorta will be large. What about venous cannulae?
For the, I would like to take an angled 20 French cannula for the IVC and
20 French for 36 kg child.
I would like
What?
16 French,
cannula?
16 French IVC cannula and 14
16.
French SVC.
16. Your drainage will be adequate, you think?
So
What will be the
18
size
French,
of the
18 French
What
IVC
will be the
cannula.
size of SVC cannula? What will be the size of the IVC cannula?
So IVC cannula 18 French, an angled cannula, and SVC I would like to put a 16 French angled cannula.
They are too small for 36 kg child. Patient is a pathology fellow. There will be lots of return. Okay.
Yes.
So minimum you have to take 20 French for the SVC and 22 French for the IVC. I will prefer 24 and 22. 22 for SVC and 24 for the IVC.
Okay.
Yes.
How much heparin will you give?
300 units per kgs.
Really, in a
That hepa-
tetralogy?
You don't use that. The appropriate
Yeah.
answer you are going to give in the examination. Heparin to achieve a 450 or 480. You may use whatever number of, because that's what. Supposing you don't achieve that, what will you do?
Give an additional dose of.
Still not
You do
going
that,
up.
still it is
Not-
not reaching 450.
Heparin resistance treatment. That is the answer.
What do you do?
Give plasma.
Okay, plasma. Incidentally, the answer for too high also is the same. Give plasma, because if you have too high a ACT also or too low or non-achieving target, both the answer is going to be plasma.
Yes.
You are in a city wherein you won't get any of these products. Okay. And the patient is in spell. Your heparin is not achieving the desired target value. What will you do?
IV propranolol. Okay.
No. You
have opened the chest.
You can
You
mildly
don't
clamp
have
the,
access
mildly
to
clamp
blood
the aorta.
product.
You can mildly clamp the, partially clamp the aorta.
And do what?
And then again the
This
heparin will not go up because you
But
clamp
the spell will get terminated.
Again the child gets a spell after you release the clamp.
You
What
have what surgery you can do?
Emergency BT shunts.
Go, you do a
Do
BT
BT
shunt.
shunt.
Okay. Don't say that still I will cannulate with 350 or 300. Still I will
Okay.
cannulate. Okay.
What time will you give the heparin?
I'm sorry, sir.
Heparin will you give at what time?
Just before taking the purse strings, I would give the heparin.
Which first thing?
The aortic purse strings.
Okay, you are given the heparin, you have seen the ACT and you have started taking first thing, your aorta starts bleeding because of the needle holes. Cyanotic patient.
Okay.
Never give heparin before you have put the aortic first strings.
Yes.
Okay?
Yes.
Yeah.
Okay. You have one thing. Supposing you see the LAD in this patient in the midline, what do you suspect? In a tetra patient, you will not see LAD, even it is in normal position, it goes still posteriorly. Entire thing is right ventricle. If you see LAD in midline.
It's arising from the right cusp.
No.
Corrected transposition.
In a case of TOF, if you see LAD in the midline, associated tricuspid, associated RV hypoplasia, RV hypoplasia makes LAD to be in the midline. Because I question asked because there was something like that. Okay, now leave that, sir. We will forget about it. We are forget. You take it out. Take that out.
Okay, go ahead.
Yeah. Now,
Take out the
you are
echo
on
reports
bypass.
there.
Yes.
Don't put
You are on
anything there.
bypass.
Stop the putting anything.
Sir,
Next. What
sir,
next?
Your VSD.
Yeah, next, sir. We have to open the right atrium now.
Acha, open right.
Right, after opening
You
the
have
right
to-
atrium.
Okay. So, So what next?
After going on bypass, I would like to cross clamp the heart and arrest the heart.
Hey. Listen now. You are on bypass, auto bicaval cannulae. Okay.
Yes.
Will you ask perfusionists to cool down the patient?
No, sir.
You want to operate at normothermia?
No, not normal. Just before cross clamping, I would want to check for the PDA first. I would like to dissect in the aortopulmonary groove to find if there is a PDA, associated PDA. Once I have confirmed that there is no PDA, then I would like to start cooling.
Do you expect PD?
In a 14-year-old child, no. In this
Your
patient,
echo has not shown, and it is a 14-year-old child. Why you want to unnecessarily dissect out in that area?
yes, then I would like to.
Yes, you have to separate the aorta and the pulmonary artery. That I agree.
Yes.
Okay.
Yes.
And you like to put the cardioplegia cannula?
Yes.
You like to cool down the patient?
I would start cooling the patients.
Okay,
Yes.
You like to loop the SVC and IVC?
Yes, sir. Yes, sir. Yes.
Don't miss any of these points, sir, before you open the right atrium.
Yes.
Okay. So you
Okay,
cross
now-
clamp, you give cardioplegia, you snug the SVC,
heart
IVC,
is
and
distended.
open the right atrium.
Heart
Next.
is distended already. You killed the patient already.
I would
What
like
is the
to, I would
study
like
of
to
this?
vent the heart immediately after
Yes,
opening the right atrium.
as
through
soon
the
as you
PFO.
cross clamp, went the heart to the right side of the pulmonary vein in this child. He's 14 years old. It should not be difficult.
Yes,
Why do you vent the heart?
to prevent distension of the heart.
And what else?
To keep a clear field of for surgery.
And what else?
What are the reasons for venting?
Yes, clear field of vision. Surgery, to operate. To close the VSDs. Yes.
Three.
How much cardioplegia
To
will you
prevent
give?
rewarming. To prevent rewarmings.
How much cardioplegia will you give? Which cardioplegia you will use?
I like to use a Del Nido cardioplegia, sir.
Del Nido, how much you like to give? Is 36 kg.
Okay.
One.
Yesterday
10
you
to
listened
15
to
units.
Del.
Yes.
You heard Del
Pardon?
You heard to him? What arrests the heart in Del Nido?
Potassium.
Potassium. What maintains the arrest? Lignocaine. Okay. And how much you give? 20 ml per kg. And you repeat at what time?
You can 60 to 90 minutes.
Repeat when cardiac activity reappears.
Yesterday, Del Nido, you were absent. You are asking. Where is he?
See, in this child, you can go up on the cardioplegia.
Said, moment the heart starts showing activity, give Del Nido. He said, I don't prescribe 45 minutes, 70 minutes, 80 minutes.
Yes.
He said, moment you see activity, give cardioplegia. You
Yes.
are right. He
So-
asked such a question, Del Nido could not answer.
And in this child, you can go a bit high on the cardioplegia volume because of the cyanosis and the collapse.
Cyanosis and washout.
So you can get 25
30
ml per kg.
20 to 30 ml per kg.
Okay.
Yes.
Now right atrium is open. What next? How do you open
Where
the right
will,
atrium?
no, where
Incision
will
of
you
the
open the
right
right atrium?
So the one forcep by the surgeon and the other forcep by the assistant. We'll hit the tip
Start
of the
where, end where?
Start at the tip of the RA appendage.
Not tip, base of the
Base
RA.
of the
Base of the RA.
Base of the RA appendage towards the IVC cannula. Just
In between the IVC cannula and the tricuspid annulus, lower down.
Yes.
State. Then what next?
I would like to take RAs. I'll vent the heart
You went the heart through the ASD.
through the ASD. Sir.
Through the ASD.
Through the PF. Through the PF first.
He already vented the heart through the right pulmonary vein.
Yes.
Then why you have to vent through the AST now?
Any other place you can vent in a tetralogy of Fallot? Any other place you can vent in a tetralogy of Fallot? Pulmonary artery. Okay?
Okay.
Yes.
And of course through VSD. But VSD vent will come in your way of closing VSD.
Yes.
But as such you are going to open the pulmonary artery for RVOT patching. So put a sump vent into
The
pulmonary
base.
artery. As good.
Okay. Hiremat wants me to demonstrate the VSD and how I close it. And so I am not asking you that question. How do
Very
you close
tricky
the VSD?
question. All of you start drawing. Exactly.
Because this is the
Normally this is asked in the
in
examination
the
to draw.
examination and for
Tetralogy
your
fellow,
understanding
usually exams
also.
are.
Let
and
me
for
give
this
you
also.
give you a background running commentary. Dr. Sitaram Bhatt doesn't like you to draw a circle moment you are asked structures around VSD. Yesterday you had drawn. That was okay because that was a pure inlet type of VSD. Now this is mal-aligned VSD. So this is what he feels how it should be drawn.
Yeah. The meaning of mal-aligned is the
Can't see
plane
the board.
of the...
Can't see the board.
Sir, we are showing you.
Yeah.
Nothing
Can
is
you
hidden.
focus?
It's a transparent government and transparent working.
Margin of the VSD
Can you focus the board, please? Yeah.
Yeah.
is not
Thank
in the
you.
same plane. They are in the different planes. So imagine it is like two leaves of a book.
I call it
Okay,
Davis bonnet.
like here, like this and like this. This is the upper end. This is the lower end, and I will be showing it in a single plane. So that the border is not in that plane, but plane is like this. Okay. So here, when you open the right atrium,
Sir is
you
the
see
surgeon.
the tricuspid septal leaflet and right ventricle. This is from the surgeon's side. Okay. The structure which you identify first to locate the VSD is moderator band. This is anterior, this is posterior, this is inferior, this is superior. Okay. Got the orientation? Yes. Okay. The assistant would have retracted the anterior tricuspid leaflet and you see a prominent band in the
Interventricular septum.
in the RV side of the septum. You identify this by moderator band which comes from the free wall and gets attached to the septum. This is the moderator band. This is the trabeculoseptum marginalis, which comes from the apex. Okay. This is now split into, it divides into two limbs. Yes. This is anterior limb or septal band
Or superior.
or
Superior.
superior band. This is
inferior.
limb or parietal extension of the trabeculoseptum marginalis. If you are using the word parietal extension, you have to qualify it as parietal extension of the trabeculoseptum marginalis, not the parietal extension of the conal septum. You get confused because of these things.
That's why I call it inferior division.
Okay, so call it as an inferior division or parietal extension or the right band. This is on the left side or anterior band or septal band. Now the defect is in between these two limbs. You know, yesterday I told you it is because the conal septum normally comes and gets inserted into these two limbs. This is the rightward parietal extension. This is the leftward extension, and it closes like this. In a tetra, yeah, no problem.
No, I will hold my arm like this. Okay?
Yeah.
So this is the trabeculoseptum marginalis. My elbow is apex. This is the superior and this is the inferior.
And this had to come like this and
This
beat
is
it.
a conal septum which
Okay.
coming from top and meets the
Limbs of the trabeculoseptum marginalis. This
and fills up everything. Now because of rotation,
This has come anteriorly to the left and superiorly, you have a defect underneath.
Balram
Okay.
sir, okay na?
Yes, sir.
Or we are confusing you?
No.
Okay.
I think you are too good in that.
Yeah.
Okay. Right. Now,
ಅಡ್ಡ ಬರ್ತಾ ಇದ್ದೀರಾ ಅದಕ್ಕೆ
Now from pulmonary annulus
yeah.
will be here.
Yeah. Right.
Sir?
Yeah.
So,
So-
specially for you, she brought special.
New pen.
For me, they always give old.
So your pulmonary valve is here. Okay. So she has not given a good one. Okay. Yeah. That is aorta. That is the pulmonary valve. Okay. Thank you. So, this is the inferior limb or the parietal band, which sometimes ends up only here with the tricuspid annulus, or may be located adjacent to the tricuspid annulus, gets inserted to ventriculoinfundibular fold. So, parietal extension of the trabecular septum marginalis or the right band or the inferior band extends and protects the bundle from the coming to the defect, pushes it away and gets inserted into ventriculoinfundibular fold. So, in some patients where the defect is perimembranous, this stops here. This is the ventriculoinfundibular fold. This is the tricuspid annulus. Here it ends up with the inferior extension of the lower border of the infundibular septum. This has moved anteriorly, So, this is the area of lower end of the infundibular septum. In between these two, you have the parietal extensions of septal conal septum. Okay. So, you have the inferior limb or the right limb, anterior limb or the left limb. You have the lower margin of the infundibular septum, then the parietal extensions of the infundibular septum in between the lumen of the RVOT and the aorta. Okay. That ends up with the ventriculoinfundibular fold. You understood? Now, Dr. Tendulkar was asking me the other day, the last time, where is crista supraventricularis? You see that word also in the book. Crista is well seen when you have got a RV infundibulotomy, not when you see from below. From below, what you see properly is the parietal extension. From the ventricular incision, you properly see the crista supraventricularis. So, identification of the margin of the BSD in a case of tetra is first identifying the moderator band. Moderator band gets inserted to the trabecular septum marginalis. You follow the trabecular septum marginalis, it divides into two, one to the left side, one to the right side, and your defect is there. Okay. Yeah. So, it is, the defect is in between the two. So, anteriorly and inferiorly, you have these bands of the trabecular septum marginalis. Your papillary muscle of Lanzisi is attached here. Even anatomically, in the normal heart, it is in between the, supposing this is the tricuspid leaflet, this is the septal leaflet, this is the posterior leaflet, and this is the anterior leaflet. Your trabecular septum marginalis, from the posterior limb, it goes to the anteroseptal commissure, muscle of Lanzisi. Because there is a defect, now this appears as if it has gone down. Its original position should have been somewhere here, attached to the anteroseptal commissure. But here it obscures your view of the BSD, the defect, the papillary muscle and its chordae attached to the anteroseptal commissure obscures the view of your ventricoseptal defect. Okay. So, how do you close? You start from the trabecular septum marginalis. So, at the antero-inferior margin, where it bifurcates away from the origin of the papillary muscle, a plageted suture. Then you go take stitches around the left, the septal band, then you come to the infundibular septum, parietal extensions or aortic annulus, ventriculoinfundibular fold, and go out of the septal leaflet, tricuspid. The other end goes along the inferior limb or the parietal extension of the trabeculoseptum marginalis, goes up to the, so this is posterior inferior area is where the bundle is. Remember the posterior inferior. Okay, posterior inferior is where the bundle is normally related to the VSD margin. Okay, so in that area, you take from the RV side of the septum, come out, go in, come out, go in, come out, and then that is from the base of the septal leaflet. Okay, if there is no muscle, don't take the bite. If there is no parietal extension of the trabeculoseptum marginalis getting inserted in the ventriculoinfundibular fold, if that is deficient, you go through the base of the septal leaflet and tight. This is the way you avoid conduction system. By taking the bites on the RV side of the septum and the posterior inferior border going towards the base of the septal leaflet, okay, you avoid the bundle. Understood?
Displacement ಅಲ್ಲ ನಿಮ್ಮ ಕೈ ಹಂಗೆ ಇಟ್ಕೊಂಡ್ಬಿಡಿ ಅಲ್ಲಲ್ಲ ನೀವು ಈ ಕಡೆ ಇಟ್ಕೊಂಡ್ಬಿಡಿ
No, ಈಗ
when you went like this, no, this is what formed the RVOT obstruction, like this. So you don't cut here, you have to get this to be able to see the pulmonary valve there. So
ventriculoinfundibular fold is the muscle which is in between aortic annulus and the pulmonary annulus. Tricuspid annulus, tricuspid annulus and the pulmonary annulus. And in a tetra, it is located now in between the tricuspid annulus and the aortic annulus. Because the aorta has come forward.
Compressing a three-dimensional view into a two-dimensional.
Yeah. So these two are the areas where there is the plane is changed. One where septum has deviated anteriorly, it has changed. They are not planar, they are malaligned. One here and one here. This is what I was telling about the two. Imagine two like this. In the 3 dimension, this area is here, this area is here.
Let's put it in 3D perspective, because that's why I tell it, what you see here is actually a crib.
Yeah, this.
It is a crib. The aorta is sitting here actually, the baby's bottom I call it. You start seeing more and more of the baby's bottom until you see a tri-leaflet valve. What you saw there is actually in this plane. This comes here is that which you saw, and your pulmonary valve will be somewhere in that direction, because you are talking of one like this, one plane like this, and this.
Okay, understood? Any questions? Ask me about this.
This part gets extended down. That's why I call it as
It goes in that
old baby cribs. No?
Think we'll we'll break for lunch. Thank you.
Sir, just one question.
More the papillamus of NCC is away from the VSD margin, more the bundle is protected by muscle.
Sir, just want to ask
Thank
you.
you.
Sir, one question, please.
Yeah, please go.
Sir, just want to ask you, what is it that actually we excise? If they say that it is the hypertrophied obstructing parietal extension.
The goal of a TYF surgery is to close the VSD securely without leaving behind any residual shunt, 1. 2, to clear all the obstructions in the REOT, to make the passage free of any obstruction. Now, you can achieve it in many ways, by resecting, by incising, by dividing it or by using a patch, increase the size. Generally, the parietal bands, prominent parietal bands are the ones which gets resected, not the septal bands. The septal bands contribute to the LV contraction because it belongs to the left side. I mean, septum belongs to the left side. So don't cut more on the left side. Cut the parietal extensions of the conal septum, not the parietal extension of the trabeculoseptum marginalis. The parietal extension, they are the ones which is producing the obstruction.
Yes.
Okay.
So
and then, if it is still inadequate, don't try to cut the moderator band. Don't cut anything which is not obstructing. You cut only the obstructing bands. And most of the time, the obstructing bands are parietal bands. Even if the septal band is prominent, you don't excise it, you incise it.
And just as a note, because Dr. Balram Iron is there, he has pioneered doing aortic coring. Be aware of it.
Yeah, we'll continue our discussions during lunch, 20 minutes lunch. Dr. Anderson is there online already. We need to call. Yeah, sir, Balram sir.
Balram sir.
Hello? See, in children who are small, infants, you don't cut, you just divide these bands, okay? That will be adequate. Don't cut too much of muscle there.
Yes.
In this adult, you have to cut the muscle. Okay, it should be adequate enough so that you can see, if you are doing the trans-RA repair, then you should see the pulmonary valve.
Yes, sir.
If you have seen the pulmonary valve, your resection will be adequate.
Yeah.
Okay.
Thank
and
you,
then,
sir.
of course, you assess with the Hager's dilator after doing the pulmonary valvotomy.
Thank you, Dr. Balram Iron, for joining us.
Yes.
We'll break for lunch.
Thank you. Thank you.
Be here
Thank
back within 20 minutes, please. The anatomy will be much more clear by Dr. Anderson also.
Bye. Okay, bye.
After that wonderful session, we are now here moving towards another opportunity to interact with the pioneer from our specialty. I'm privileged to welcome and introduce Professor Robert H. Anderson. Dr. Anderson is Professor of Child Health at the Newcastle University. He is former professor from the prestigious Brompton Hospital, London. Dr. Anderson once again needs no introduction to anyone in the cardiothoracic community. Professor Robert Anderson is a doyen in cardiac morphology and anatomy who has been instrumental in the understanding of the modern cardiac surgeons when it comes to the department of heart, structural as well as the congenital malformations. His pioneering work over the last 60 years has shaped how we see, understand, diagnose and treat cardiovascular lesions. Sir, we are privileged to have you on board with us. We eagerly look forward to your insights on cardiac morphology.
Well, good afternoon to you all, ladies and gentlemen. It's a great privilege for me to have the opportunity to discuss with you the anatomy of the heart, specifically for you as surgeons. So what is it that you need to know about the anatomy of the heart? Well, the basic answer to that question, of course, is sufficient to keep yourselves out of trouble. So in the next half hour or so, I'm going to summarize what I think are the basics of cardiac anatomy that should be providing the necessary information. I'm going to start off by emphasizing the need these days to describe the heart as it lies in the body. So that will be the starting point of our presentation. Then I'm going to move on. I'm going to show you briefly the different parts of what we call the cardiac segments. And it's an appreciation of the segments that sets the scene for understanding the heart when it is congenitally malformed. Then we'll move on to the features that reflect more what is necessary to understand the normal heart. So I'll review with you what we know about septal morphology. I'll introduce you briefly to the anatomy of the valves, and then I'm going to finish up by emphasizing the real important part that keeps you out of trouble, knowing how you avoid the conduction tissues. But to start off with, what in fact you should already know, because you will all have done basic anatomy, you will have been in the dissecting room, and in the dissecting room you should have been told the first rule of human anatomy, and that is that all structures within the body are described relative to what we call the anatomical position. And that means that the parts of the heart should also be described relative to the anatomical position. But unfortunately, that is not the case, and I'm as guilty, or at least I was as guilty as anybody else in describing the heart in this fashion. This is what we now call the Valentine approach. You can see that in this heart we've cast the right-sided chambers in blue, the left-sided chambers in red. And we've taken our cast and we've placed it on its apex. And in reality, it is only when we look at the Valentine arrangement that the right atrium is truly to the right of the left atrium, and the right ventricle is truly to the right of the left ventricle. But what happens when we try to put the heart in Valentine position back into the body, shown here on the basis of the chest radiograph? And as you will immediately see, the heart in Valentine position does not fit into the cardiac silhouette when we think of it in the Valentine arrangement. What we have to do so as to fit the heart properly into its pericardial coverings is to rotate it and twist it. And then we see the cardiac chambers as they should be described. And this is now what we call the attitudinal approach. And for years, I described the heart incorrectly in that Valentine approach. Now, and for the remainder of this presentation, I'm going to describe the heart in attitudinally appropriate fashion. And I hope I can persuade all of you to follow this approach, because now, as I'm also going to show you, you can see the components of the heart as well, using the techniques at your disposal in the clinical setting, as I can when I show you dissections of the heart. So let's build up the heart and let's put it back into the body. And to do this, I am indebted to my friend and colleague, Shunpei Mori. Shunpei came to me from Japan now many years ago. He now works in the University College, the University of California in Los Angeles. And Shunpei has made these segmentations of a living data set prepared by computed tomography. And what you can see is he's shown the esophagus in green, he's reconstructed the trachea and the bronchuses, and in pink he is showing you the left atrium with the pulmonary veins. And the left atrium is the most posterior of the cardiac chambers, and it is more or less in the midline, with the pulmonary veins running to right and left to enter the hilums of the two lungs. And using Shunpei's segmentation, we can put in the left ventricle. And you see the left ventricle is coming towards us from the left atrioventricular junction, and it projects slightly leftwards until it reaches the cardiac apex. The next thing we can put in is the aorta. And the aorta is centrally located within the cardiac silhouette. And if you understand the relationships of the aortic root, then essentially you understand cardiac anatomy. And we'll come back to the arrangement of the aortic root. So this essentially gives us the left-sided heart chambers, but in reality, they're not really left-sided. They are the posterior chambers of the heart. And when we put in the right ventricle, the pulmonary trunk, you see it sits on top of the left ventricle, it is in front of the left ventricle, and it wraps itself around the aortic root from the inferiorly positioned tricuspid valve orifice to the anterior and leftwardly pulmonary root, which then continues as the pulmonary trunk to the margins of the pericardial cavity. And then we complete the cardiac silhouette by putting in the right atrium. And it is indeed right-sided, but basically it is anterior to its left-sided counterpart. And we can see very nicely now that coming into the top of the left atrium, we have the superior caval vein. Coming in at the bottom, we have the inferior caval vein. And the relationships of the two caval veins are very useful to we as anatomists when we take the heart out, because when we position the heart with the caval veins superiorly and inferiorly, then basically we have the heart in the attitudinal approach, which is how we should now be describing it. So this, in essence, is how I now describe the heart and its component parts. And you will follow that we use these coordinates of the body itself. So we describe right or left relative to the right and left sides of the body. What is superior, the parts of the heart towards the head, and significantly, what is inferior are the parts of the heart that are towards the feet, and these are the parts that sit on the diaphragm. And then, what is posterior is the part that is towards the spine, and what is anterior is the part that is towards the sternum and the ribs. And so these are the coordinates we should now be using when we describe the different parts of the heart. So with that as an introduction, let's get into the heart itself. And to appreciate, to differentiate the right and left sides, we need to understand the cardiac components. And this has been another contentious issue. How should we best describe what is morphologically right, what is morphologically left? But there has been an important principle established that is called the morphological method. And that tells us we should not use one feature that is itself variable to define another variable feature. So when we recognize what is morphologically right as opposed to what is morphologically left, we should use the most constant component. And this principle was established by my good friend and colleague, Richard van Praag. Sadly, Richard died relatively recently, but at the handsome age of 95. And it's interesting that this article in which Richard emphasized the morphological method was done to criticize one of our own papers, but he was entirely correct. So ever since Richard published this paper in 1980, we have used the morphological method so as to distinguish what is morphologically right as opposed to what is morphologically left when the heart is congenitally malformed. But if we are to do this, we need to know what are the component parts. So let's consider the atrial chambers. These are the components that you might find within the atrial chambers. There is a body, that is the remnant of the original atrial component in the primary heart tube. The venous component is relatively obvious. We're going to discuss the septum. The vestibule may be new to you. That is the part that inserts into the atrioventricular junctions. But most important is the appendage, because we know when we look at congenitally malformed hearts that it is the appendage that is the most constant of these various components. So when I open the morphologically right atrium and spread out the anterior wall, this is what you see. And I hope you will immediately recognize the pectinate muscles. and it is the extent of the pectinate muscles that identifies the appendage. And this is the major feature of the morphologically right ventricle, the fact that the pectinate muscles, as you see here, extend all the way around the vestibule. You will see that the vestibule is smooth-walled, and this is the part of the atrial walls that insert into the leaflets of the tricuspid valve. So the feature that tells us that this is a morphologically right atrium is that these pectinate muscles encircle the vestibule of the tricuspid valve. Of course, when the heart is normal, we don't ignore the fact that entering the morphologically right atrium, we have the superior caval vein at the top, we have the inferior caval vein at the bottom, and then also we have the coronary sinus. And although the coronary sinus occupies the morphologically left atrioventricular groove, it opens into the morphologically right atrium. And together, these are the three tributaries that make up the systemic venous sinus. If we then look at the posterior wall of the atrium, we can recognize the septum. I'm going to discuss this with you in a little more detail shortly. But then if you look very carefully, you can see that the inferior caval vein is opening into the atrium through the venous valves. And there is a slit between the leftward of those venous valves and the septal area. And this is the small part of the primary component of the heart tube, the body that remains in the morphologically right atrium. We can now compare that in the same heart to the morphologically left atrium. And again, the most characteristic feature is the appendage. And you see that you don't see the pectinate muscles on the left side in this particular dissection because they are within the appendage. And it is the fact that the appendages, the pectinate muscles, are confined to the appendage, which has a very narrow junction to the remainder of the atrium, that tells us that this is morphologically left. It has a vestibule, it has a pulmonary venous component, and it has the larger part of the primary atrial component of the initial heart tube, and they are all smooth-walled. And this is the major difference that tells us that this chamber is morphologically left. And if you look very carefully, you can then see the horns of the flap valve of the atrial septum, which we're going to discuss in a little more detail. But let's move on and let's consider the ventricular segment. It extends from two well-formed anatomical boundaries. One is the atrioventricular junction. You may be surprised to see that the second one I've nominated as the sinutubular junction. This is where the sinuses of the arterial roots give way to the tubular components of the arterial trunks. And that is because not all of the ventricular segment is myocardial. And I'll discuss this with you when we consider the anatomy of the arterial valves. But within the ventricular segment, we have two chambers, and we distinguish them by having inlet, apical, and outlet components. So which of these components is most constant? Which do we use when the heart is congenitally malformed to distinguish what is morphologically right as opposed to what is morphologically left? We look at the apical component. So let's look at some dissections. You will recognize, I hope, that I'm showing you here the morphologically right ventricle. You can immediately see the atrioventricular junction. You can't see the sinutubular junction terribly well, but I'll show it to you when we consider the arterial valves. But what I hope you can see is that the right ventricle has an inlet which surrounds and supports the tricuspid valve, and then it has the apical component. But look again at that apical component, because the apical component in the morphologically right ventricle is very coarse. And it is these coarse trabeculations that tell us that this is the morphologically right ventricle. And it then has an outlet. And in the right ventricle, as we're also going to discuss, this is a complete muscular tube or sleeve that supports the pulmonary route, and it is the presence of the freestanding infundibular sleeve that permits you as surgeons to remove the pulmonary valve and to use it as an autograft in the Ross procedure. So this is the morphologically right ventricle. When we turn the heart around and we look at the morphologically left ventricle, again we can see that it extends from the atrioventricular to the sinutubular junction. This time the inlet supports the mitral valve, and then we have the apical component. But now when we look again at the apical component, you see it is fine and crisscrossing. And it is these differences in the apical component that distinguish morphologically right from morphologically left ventricles. The outlet component, left ventricle, is not a complete sleeve because one of the features of the morphologically left ventricle is fibrous continuity between the leaflets of the aortic and mitral valves. And we'll discuss that on several subsequent occasions, but still we have the basic arrangement of ventricles that they possess an inlet, an apical component, and an outlet, and it is the difference in the apical trabeculations that tells us what is morphologically left and what is morphologically right. So let us not forget the final segment, the arterial segment, and this extends from those sinutubular junctions to the margins of the pericardial cavity. Within the arterial segment, we have the intrapericardial aorta and the pulmonary trunk. And it is at the margins of the pericardial cavity that the pulmonary trunk bifurcates into the right and left pulmonary arteries. It is the spiraling of the trunks within the pericardial cavity that produces the so-called normal relations that are so important in recognizing normality as opposed to abnormal arrangements when the heart is congenitally malformed. So this is what the arterial segment looks like when it's removed at the level of the sinutubular junction, and it's looked at from the apex of the heart looking towards the base. And you will recognize the pericardial reflections. And on the basis of the pericardial reflections, we can see the intrapericardial versus the extrapericardial aorta. And as the extrapericardial aorta continues to the aortic arch, we have the brachiocephalic trunk, left common carotid artery, left subclavian artery. We're looking down the barrel of the pulmonary trunk, but what we can see is that it is at the margins of the pericardial cavity that the pulmonary trunk becomes extrapericardial, and there we have the right and left pulmonary arteries. So those are the basic segments that make up the normal heart. So let's look at some of the details of cardiac anatomy. We cannot go into all of the details, we simply do not have time. But I'm going to emphasize what I think are the important points to you as surgeons: the septal components, the arterial valves, and the cardiac valves, and then the conduction tissue. But let's start with these septal components. And as you see, I've emphasized that they're not nearly as extensive as often shown in some textbooks. But there are three septal components we need to consider. First, the atrial septum, then the atrioventricular septum, and finally, the ventricular septum. So let's start with looking again at the right atrium. I've taken away the parietal wall and I'm looking at the posterior surface. And at first sight, there is an extensive septal area. You will recognize, I hope, the coronary sinus, the inferior caval vein. But the key to understanding the extent of the septum is to look at the oval fossa. And it's when we take sections across the heart that we can see what is truly septal as opposed to the infoldings that produce the margins of the oval fossa. So to start, I've taken a horizontal section through this particular heart. And then you see beautifully the margins of the oval fossa. Its floor is the major septal component. This is what we call the flap valve. This is the primary atrial septum. But look at the margins, and you see posteriorly we have a fold filled with extra cavitary adipose tissue, as we do anteriorly. And note in particular the relationship of the anterior rim to the aortic root. So the margins of the oval fossa for the larger part are folds. And this is particularly the case when we cut across the septum from top to bottom. And I've done that in this adult heart. And this makes a particularly important point. Again, I hope you'll recognize the margins of the oval fossa, and you'll see that the larger part is the floor, which is the flap valve. And this now, in this adult heart, is largely fibrous tissue. But you will see that superiorly, we have this extensive fold. This is what for years people have called the septum secundum. It's not a septum at all. It is a deep fold. And surgeons have recognized that for years. So this is the fold that is called Waterston's groove or Sondergaard's groove. And you as surgeons can dissect into this fold. You do this in congenital procedures such as the Senning procedure or the Mustard procedure, Mustard less so now. But in the old days, this was unfolded to create extra tissue for atrial redirection so as to correct transposition. So it's a fold. It is not a septum. But there is a second septum, and this is the antero-inferior buttress. And it is the buttress that anchors the flap valve against the atrioventricular junctions, and that is the true second atrial septum. It also significantly harbors the atrioventricular node. So we'll look at that when finally we discuss the conduction tissues. So what of the atrioventricular septum? Now this is the area that is not nearly as large as I thought it used to be. And in fact, the only true atrioventricular septal structure is part of the membranous septum. I used to think that the floor of the triangle of Koch was part of an atrioventricular septum, but I now know that that is one of the walls of the inferior pyramidal space, as I'll show you very shortly. Now we can see the location of the membranous septum in another of the virtual dissections that have been made by Shumpei-Mori. So this again is a computed data set that Shumpei has colored and made a virtual dissection so that we can look at the septal surface of the right atrium, the right ventricle. And in green, Shumpei has covered the membranous part of the septum. If you look carefully, you see it's continuous with the little part that is between two of the sinuses of the aortic root. And I'll come back to that eventually. But what I'd also like you to notice, is how a continuation of the eustachian valve comes forward from the orifice of the inferior caval vein and inserts into the membranous septum. And the membranous septum itself is also related to the hinge of the septal leaflet of the tricuspid valve. Now, when you look at the orifice of the coronary sinus, I hope you will be aware that, together with the tendon of Todaro, the hinge of the septal leaflet, this makes up the triangle of Koch. And I'll show you this very shortly. And I used to think that this area was also an atrioventricular septal structure, but I know now that is not the case. The only true atrioventricular septum is this atrioventricular part, the membranous septum, that is on the atrial aspect of the hinge of the septal leaflet of the tricuspid valve. The remainder of the membranous septum is then interventricular, and we'll also look at that. So this is what it looks like when we take a section across that center point of the heart in four-chamber fashion. I've cut away the leaflet of the non-coronary sinus to show you this. So you're looking at the non-coronary aortic sinus there, along with the aortic leaflet of the mitral valve. And you very nicely see the fibrous continuity between these two parts. There, inferiorly, you see the muscular septum. But here is our focus, the membranous part of the septum. And look how it is separated by the hinge, the septal leaflet, the tricuspid valve, into the atrioventricular membranous septum, which interposes between the cavities of the right atrium and the infraseptal recess of the left ventricle. That is why it is atrioventricular. But beneath the septal leaflet, the hinge, we have the interventricular part of the membranous septum, and we'll also look at that very shortly. But I'd like to show you the cut that is made more inferiorly through the triangle of Koch, because I used to think this was also an atrioventricular septal structure. So what are we looking at here? You can see the offsetting of the hinge of the tricuspid valve relative to the mitral valve. And there is the septal vestibule of the tricuspid valve, and you can also see those pectinate muscles showing that they go all the way to the crux. There is the diverging inferior margins of the ventricular walls. And if we take a cut across that area, we can indeed get from right atrium into the infraseptal recess of the left ventricle. But look what is in the middle of this area. There is extracavitary adipose tissue. In other words, fat, because this is part of the inferior pyramidal space, and we now know it is not a septum at all. It is part of what we call the pyramid of Koch. So let's move on and look at the ventricular septum, and that includes the interventricular component of the membranous septum, but its larger part, of course, is muscular. But the muscular part of the septum also has nuances, because its inferior part separates the right ventricular inlet from that infraseptal recess of the left ventricle. And when we look at the outlet component, there is no outlet septum because of the freestanding infundibular sleeve. To show you that, I can revert to another of these exquisite virtual dissections made by Schumpe. And there now you see the membranous septum. It is tiny compared to the extent of the muscular septum. But the infrasuperior part of the septum interposes between the right ventricular inlet, the left ventricular outlet. The apical part does indeed separate the two apical components, but when we take another virtual dissection made by Schumpe and we look at the outlet, there is the medial papillary muscle, the infundibulum of the right ventricle, we see that the wall of the infundibulum does not separate the right ventricle from the left ventricle. Instead, it interposes between the infundibulum and the aortic root. And it is the presence of this freestanding infundibular sleeve, as I've already commented, that permits you as surgeons to remove the pulmonary root and to use it as an autograft in the Russ procedure. So let's move on now. We don't have that much longer left, so I'm very rapidly going to go through you the cardiac valves. And for all the valves, we need to think of them as complexes. And we're going to start off with the atrioventricular valves. So they are hinged within the atrioventricular junction, and I'm sure you all still call that an annulus. But supported by the junction, we have the leaflets, which in turn are supported by tendinous cords and papillary muscles, and then the whole valvar complex must work in harmony with the ventricular walls so as to achieve valvar competence. And this is the same in the tricuspid valve as it is in the mitral valve, but I can show it to you particularly nicely in a heart that I've cut in simulated parasternal long axis echocardiographic section to show you the valvar complex of the mitral valve. And what you see there are the components of the junction. Superiorly, the atrioventricular junction has the vestibular component of the left atrium inserted into the area of fibrous continuity between the leaflets of the aortic valve and the mitral valve. Whereas inferiorly, we see there is a mural atrioventricular junction, and within that we see the coronary sinus. Hinged from the junction, we have the leaflets. And I prefer to distinguish the leaflets as to being on the one hand aortic and on the other hand mural. The leaflets are supported by the tendinous cords. For the tendinous cords, I simply recognize those attached to the free edge, the strut cords attached to the ventricular surface, and then beneath the mural leaflet we find the basal cords. The tendinous cords then are supported by the papillary muscles, of which there are two in the left ventricle, positioned inferoseptally and superolaterally. But look how those papillary muscles themselves are supported by trabeculations within the left ventricle, and it is those trabeculations that act as a supporting mechanism so that the whole thing will work in harmony to ensure that when the leaflets are closed, we get a beautiful arrangement such as you see here, looking down on the leaflets from their atrial aspect. So there you see the junction. The aortic leaflet is fitting snugly against the mural leaflet, and to achieve that, we have these slits in the mural leaflet producing what you recognize as the scallops. And of course, the two leaflets fit snugly together along a solitary zone of apposition. But note, the zone of apposition does not reach to the junction, so we also need to take into account the commissural areas of the valve. And this is, if you like, the perfect mitral valve, but there's marked variability depending on the number of slits that we need in the mural leaflet to permit it to fit snugly against the aortic leaflet. Now, we can look at that again in one of Shumpai's virtual dissections, this time showing you the base of the heart viewed in attitudinal fashion from the apex, looking towards the base. And then, if we look in the mitral valve, we can see very nicely the curved nature of the zone of apposition, showing us that the mural leaflet is guarding 2/3 of the overall circumference and is relatively shallow, whereas the aortic leaflet guards only 1/3 but is much deeper, so that taken together, the surface area of the two leaflets is comparable. And then if you look in the right ventricle, you can see that the leaflets of the atrioventricular valve come together in trifoliate fashion. So it's entirely justifiable to describe this as being a tricuspid valve. Its major component is positioned anterosuperiorly. There is a part that hugs the septum, and we all call this the septal leaflet, but what of the third leaflet? Is this really a posterior leaflet, as it is so often described? Well, when you look at the heart in attitudinally appropriate fashion, as I'm showing it to you at the moment, you will immediately recognize that this third leaflet is guarding the diaphragmatic surface of the ventricular mass, and it is inferior. It is a mistake to describe this as the posterior leaflet. It is properly described as the inferior leaflet. And that is one of the problems we still have to grapple with if we are to get a sensible nomenclature to describe the cardiac valves. But it's much worse when we come to the arterial valves. A group of German surgeons in 2012 issued a questionnaire all around the world to a large number of cardiac surgeons and asked them how they described the arterial valves. And the result, as you see, was a Tower of Babel, because there was no real consensus. And that is because the leaflets of the arterial valves are attached in semi-lunar fashion. It is those remnants of the leaflets, when removed, that half of the surgeons, when asked what they defined as the annulus, nominated the semilunar hinges. They are supported by valvar sinuses, and to me, the key to understanding is to distinguish between leaflets and sinuses. The leaflets come together at the sinutubular junction, but one of the problems is that as they move towards the distal sinutubular junction, they cross the myocardial arterial junction. And that is why, when describing the ventricular segments to you, I told you that not the entirety of the ventricles were myocardial. But the real problem is that when we join together the nadirs of the leaflets, we can create a circle, and that is what the echocardiographers call the annulus. But there's nothing there. It's a virtual ring. But half of the surgeons who answered the questionnaire producing the Tower of Babel nominated, as did the echocardiographers, this ring joining together the nadirs of the leaflets as the valvar annulus. So this is the problem. What I've done here is to open out the pulmonary route, and I've then removed the valvar leaflets. And here you see the essence of the pulmonary valve, the semilunar nature of its hinges. Now the top of the screen is distal, and that is where the leaflets come together at the sinutubular junction. If we join together their nadirs, we produce what the echocardiographers call the annulus. But you will immediately appreciate there's nothing there. It is a virtual basal ring. But there is a proper ring there, and that is where the myocardium gives way to the arterial walls of the valvar sinuses. And this is the myocardial arterial junction. But look what has resulted from this complex arrangement. We have three crescents of myocardium that are incorporated at the bases of the sinuses. This is ventricular wall, but in terms of hemodynamics, it is part of the valvar sinuses. But then, at the distal margins of the ventricular cavity, we have arterial wall that is part of the ventricle. So this is the complexity that, in 3 dimensions, makes up the basis of the pulmonary route. So there are the drawn semilunar hinges. And to me, they make a crown or a coronet rather than a ring. There are some rings. There is the sinutubular junction, which is a real ring. There is the virtual basal ring. And then, over and above that, there is the circular myocardial arterial junction. Which of these is the annulus? You pays your money, you takes your choice. But it's much more subtle when we look at the aortic route. Again, the major feature, the semilunar hinge lines of the leaflets, which come together at the sinutubular junction. You'll note that when we remove the leaflets, as I've done in this dissection, then the hinges are much more robust than they were in the pulmonary route. And that is why many of you as surgeons will still call these semilunar remnants the valvar annulus, because those are the remnants that you use to secure your stitches when you are replacing the aortic valve. But the basics of the arrangement anatomically are just as you saw in the pulmonary route. So we have a virtual basal ring. There is an added subtlety because the myocardial arterial junction is now found only in the two valvar sinuses that support the coronary arteries. And those are the only sinuses in the aortic route that have myocardium at their bases. And these are the crescents that are often ablated by the electrophysiologists as they cure ventricular outflow tract arrhythmias. But then we have the prominent interleaflet triangles now, arterial wall within the ventricle, with the added addition now in the left ventricle, that we have the membranous septum filling that gap between the right coronary and the non-coronary sinus of the aortic root. So a complex arrangement again that makes up the arterial route, comparable in the aortic route as in the pulmonary route. But now we can see particularly what's going on by making virtual dissections of computed tomographic data sets. This one has been made by my other good friend, Justin Tretter, who now works in the Cleveland Clinic, and Justin has emphasized the location of those interleaflet triangles. He's also marked in sinutubular junction, the virtual basal ring, and in orangey pink, you can see very nicely those myocardial crescents found at the base of the two sinuses giving rise to the coronary arteries. But now, for you as surgeons, you can make important measurements of the route, as shown here in one of Shumpei's sections across a virtual data set. We can recognize in the aortic route, the sinutubular junction, the virtual plane, and now, prior to valvar repair, the interventionist or the cardiologist will measure the height of the interleaflet triangle, permitting you to calculate the free margin of the leaflets, the effective height, and the coaptation length. And all of these metrics are now key to surgeons who wish to undertake valvar repair. But let me now finish by introducing you to the conducting tissues. If you are to be safe in the operating room, you need to avoid these tissues. The hooker here, of course, is they cannot be seen with the naked eye. But now we have sufficient knowledge to provide you with reliable anatomic landmarks to avoid them. So, to avoid the sinus node, you should be avoided the entirety of the superior cavoatrial junction. To avoid the atrioventricular node, you respect the apex of the triangle of Koch that I've mentioned now on several occasions. And then, within the right ventricle, if we take a line from the apex of the triangle of Koch to the medial papillary muscle, that tells us where we find the branching part of the conduction axis. But pictures, of course, are worth thousands of words. So let me finish with 3 more pictures. For the first time, I'm showing you a picture drawn in surgical orientation. And hopefully you will all now recognize when you open the pericardium and you look in the right atrial appendage, separating it from the systemic venous sinus, we have the terminal groove. And lying there at the superior cavoatrial junction, within the terminal groove, we have the sinus node. In most individuals, it is lateral, as I've drawn it here, but it can straddle the crest of the atrial appendage. Equally importantly, it can the artery supplying the node can run in front of the cavo-atrial junction, behind the cavo-atrial junction, or in certain circumstances form an arterial circle. So to avoid the sinus node, avoid the entirety of the superior cavo-atrial junction. What about the atrioventricular node? Well, I show you here this beautiful picture, again taken in the operating room. This is in surgical orientation once more. This was taken by my late lamented colleague and very good friend, Benson Wilcox. Ben has put a little instrument into the coronary sinus and has put a bit of tension onto the opening of the coronary sinus. And that has brought into prominence the tendon of Todaro. You also see the hinge line, the septal leaflet of the tricuspid valve, and you note that the two, the tendon and the hinge line, come together at the membranous septum, as we've already discussed. And so now you can define the triangle of Koch, and you know that if you respect the apex of the triangle of Koch, you will not damage the atrioventricular node. But let me revert to anatomical orientation in attitudinally appropriate fashion. I've opened the right side of the heart. I've reflected the superior wall of the right ventricle to show you, again, the tendon of Todaro, the hinge, the tricuspid valve, and the medial papillary muscle. And then, if we take a line from the apex of the triangle of Koch to the medial papillary muscle, that tells us where we will find the conduction axis. So, ladies and gentlemen, in the time available to me, I've tried to provide you with the keys to understanding. And let me emphasize again, the first key is to describe now cardiac components relative to the heart within the chest. That is how you see the heart when you operate upon it. And now the cardiologists all the time are showing you in ever increasing detail cardiac anatomy in the living patient. And that permits you to describe what you see and to ignore the multiple previous misconceptions. Because now clinical imaging can show you cardiac anatomy with huge precision. But what I hope I've shown you, if you have the necessary basic knowledge, it will greatly improve your interpretation of the images that you are now seeing all the time. They are particularly valuable in showing you the coronary arteries. I haven't mentioned the coronary arteries because of the constraints of time, but you can see that, and with appropriate segmentation, as I've shown you, you can see all the features that I've demonstrated with cardiac anatomy. So hopefully that has given you the basics that you as surgeons need to understand so as to conduct safe cardiac surgery. Thank you for letting me spend the time with you, and I wish you all the very best.
Thank you, sir. That was a very detailed and pristine presentation. I'm sure our residents will benefit from your valuable insights. Yeah. I would like to open the forum for questions.
As he could not join, I had a discussion with a few of the residents. They want the diagram to be redrawn by Dr. Sitaram, but in explanation for 5 minutes again. Sir, if you don't mind, can you help us?
This, you imagine that this is, we have opened the anterior wall of the right ventricle. This is right ventricle. This is outflow or pulmonary artery. This is
focus on only the diagram camera, please.
Okay. Inflow or the tricuspid valve. So this is the inlet septum, trabecular septum, outflow septum. Understood? 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 Everybody understood? Okay. Clear. Okay. Now, in the theater, during the surgery, your assistant retracts the ATL. You see the moderator band. Okay. So now I am describing you how to locate the VSD. Okay. The VSD is not, VSD in TOF is not because of deficiency of tissues. It is because the outlet septum failed to fuse with the limbs of the trabeculoseptum marginalis. It failed to fuse with the limbs of the trabeculoseptum marginalis. I am trying to show you a three-dimensional thing in a flat, in two dimension. So to identify these margins, which will enable you to locate the VSD, because VSD of TOF is determined, it is located by identifying its margins. So now I am telling you how to identify the margin of that VSD. So that is the outlet, this is. Now this is posterior, this is anterior. Okay. This is inferior, this is superior. Okay. For your orientation. Here is the tricuspid valve. Okay. Now when you, okay, there is some muscle there, okay. Now when you retract the anterior leaflet, look into the cavity of the RV, you see a moderator band. Moderator band is the one which is helping you to locate the trabeculoseptum marginalis. Moderator band is a constant structure. So the one which is crossing the cavity of RV is the moderator band. So identify the moderator band. That will take you to the trabeculoseptum marginalis. This is a big band which is seen on the RV side of the septum as a one which is running from the apex towards the outflow of the RV. Okay. Now, so you trace it and you see as you come nearer to you, to the surgeon, that it divides into two limbs. One is called inferior limb, other is called superior limb. Superior limb is the left sided limb, this is right sided limb. So rightward extension of the trabeculoseptum marginalis, that is the word that is used. So rightward extension of trabeculoseptum marginalis, this is the leftward extension of the trabeculoseptum marginalis. This is also called as septal extension or septal band. This is also called as parietal extension or parietal band. You may think that this is parietal and this is septal. No, this is parietal and this is septal because this is attached to the interventricular septum, and this is parietal because in the normal heart this is into this area and ends up with the ventricular infundibular fold. In a TOF, it has not reached here, so you, though it does not go to the parietis, but still retains its name as parietal band. Now, parietal band generally stops at the tricuspid annulus. Now, this is, in some of the patients, this parietal band continues to its original destination of ventriculoinfundibular fold, VIF. Ventriculoinfundibular fold in a normal heart is a muscle mass which separates the tricuspid leaflet from the pulmonary annulus. That is the one which lifts, moves it away from the tricuspid valve. Pulmonary valve is not in continuity with the tricuspid valve, and it is This is the one normally when it is anterior, when this defect is not there, when it gets inserted here, when this limb gets inserted here. This ventricular-infundibular fold is the one which lifts the pulmonary valve away from the tricuspid valve. Now in a TOF, because this is smaller, narrower, this area is filled with the aorta. Okay, aortic leaflets. Now septal band, anterior to it, you see the insertion of the lower end of the anteriorly displaced, leftward displaced, cephalad displaced conal septum. So conal septum is in front of this. So you see the conal septum. Now conal septum gives parietal extensions and septal extensions. So these are parietal bands of the conal septum, septal bands of the conal septum. These parietal bands, the prominent parietal band is the one which causes the obstruction in this plane. It causes obstruction in this plane. Got it? So now the structures related to the margin of the VSD. Okay? Tricuspid leaflet or its annulus, or septal leaflet. What did I say? The septal leaflet of the tricuspid valve, posteriorly, then or it could be a muscle band which is the extension of this parietal extension of the tricuspid, the trabecular septum marginalis to the VIF. So this parietal extension gets inserted into the ventricular-infundibular fold normally. So it may be persisting. So that muscle is the one which is in between the defect and the tricuspid annulus. This is inferior. So inferiorly bounded by the parietal extension of the trabecular septum marginalis, or the rightward extension of the parietal septum marginalis, or the inferior limb of the trabecular septum marginalis, whatever word you use. Which yeah, that is a problem that has happened for the students. I'm telling because the problem is this parietal extension and the yeah, that is the problem. When the book describes
superior limb goes up, meets the conal septum.
Yeah, correct. Now, supposing I use the word rightward extension of the TSM and use the word parietal extension only here, so much of superior limb also may be appropriate. So inferior limb, but in the book when you read it is written as parietal extension of the septal trabecular septum marginalis. To reduce, okay.
Anderson just now said, describe what you see.
Yes. So you understood now. So you have the posteriorly a muscle band from the parietal extension to the VIF or the tricuspid annulus. Inferiorly, the parietal extension of the TSM. Then superiorly, where is it? Superior. This is inferior. Superiorly, you have the septal extension of the trabecular septum marginalis. Then you have the conal septum. Then you have got the parietal extension. The parietal extension, the parietal extension of the conal septum is in between aorta and the pulmonary outflow tract. So the examiner, some centers have got cath with them and they will show you one view, ask you to identify which is the parietal extension, which is the septal extension. Nowadays I am not seeing in the exam because nobody does the catheterization. So the negative shadows between the aorta, this is the aorta, and the RUOT is the parietal extension. The negative shadow on the other side is the parietal bands, the septal bands. The one between aortic lumen and the RUOT is the parietal bands. You understood? So now, here is attached to the posterior or attached to the parietal extension of the TSM is the muscle of Lancesi, which gives chordae to the tricuspid anteroseptal commissures. So here you start taking the bites here, come like this. In this area, the plane changes. The plane is anterior. You take the bites through the lower margin of the infundibular septum. Then you take bites in the aortic annulus. Then you come up to the ventricular infundibular fold. You take bites in the ventricular infundibular fold. You understand? Go to the tricuspid leaflet out. Come here, right side of the IVS, you take the bites on the right side of the interventricular septum. When you go to the posterior inferior angle, that is where you are worried about the bundle. You come out and then go in and out and tie it here to avoid the bundle. Understood? This figure is understood in this area. If you see in a RVOT, this area is written as crista supraventricularis. So these parietal extensions you can see easily through the RA approach when you go through the right ventricle. The crista is prominent when you see from the RVOT incision. Got it? So tricuspid annulus, TSM one limb, TSM other limb, conal septum, parietal extensions, ventricular infundibular fold. This is the this aortic sinuses. This is right coronary sinus. What is this? Non-coronary sinus. What is underneath the ventricular infundibular fold is the non-coronary sinus. What is underneath parietal extensions is RCA.
Actual annulus is RCC.
Yeah. Okay. So, clear now? Want me to talk again? Everybody understood what it is? Huh? Okay. You will not ask me to talk again.
Because RCC forms the margin, it is called subaortic. Because it is in different planes, it is called malar.
All right. So this is in one plane, this is in another. These are in two different planes. Prasanna was telling bum, this is the bum. Where is the bum? Okay. Like this. Okay. So, okay. Okay. So if I put the bum like this is the posterior limb, this is the TSM, anterior limb, posterior limb, conal septum, parietal extension, ventricular infundibular fold, and the tricuspid valve. Got it? Got it? Now this is in one plane, this much is in one plane, this much is in another plane. So this is the area where the sutures, if the retraction is not adequate, it jumps from one plane to another plane here. The suture goes from here to here directly, leaving behind a gap here. So that is one of the areas of residual VSD. The other areas exactly opposite here. Posterior inferior angle, you have taken superficial bites. The plane changes here and in the ventricular infundibular fold. So even while you are using a continuous suture technique, these are the areas you put additional sutures, additional simple sutures to see, one, to verify that you have gone through the entire margin, because there is a likely to skip the bite there. You take additional sutures. Even in the continuous suture technique, you have to mention additional sutures where the plane changes. Got it? Hiramat?
Yes, sir. Yes, sir. Yeah, thank you, sir. We have on the same diagram on Anderson's paper. I think our colleague Dr. Sumant from All India Institute of Medical Sciences wanted to just display that. Sumant, can you show where it is?
So this was a wonderful explanation by sir, but I just wanted to show you on the diagrams, which I found in Anderson's paper.
Where is the diagram? This is the article. I think everybody can go read this article. The anatomy of tetralogy fellow, yeah.
Yeah, you can magnify this. Okay. So this is the normal right ventricular septum. Okay. Whenever this is a normal patient's RV. So here they have specifically mentioned, you can see that the structure which is colored in orange, this is your trabecular septum marginalis, right? These are the two limbs, and in between is our outlet septum. So in a normal RV septum, you will not be able to visualize all these different parts, but Anderson, because of our, to understand it, he has mentioned it like this. So what happens in a case of tetralogy of fellow, this outlet septum has displaced above and anteriorly, right? So it moves up and anteriorly. So that is what we see in the next. Here you can see the same structure. This is the trabecular septum marginalis, colored in the orange. Can everybody make out? And whatever was supposed to be here has moved up and anteriorly. So here is our outlet septum. So because this part is deficient, there is a VSD there. Okay. So the same thing in a, I think, normal anatomical specimen. Here you can see these are the two limbs of the TSM, trabecular septum marginalis. Here is your outlet septum, and here is the, this is the parietal extension, and this is the septal extension. So here you can see that it is actually a cut part, so you cannot see the three-dimensional part. This whole outlet septum is one continuous muscle, but because we have cut it here, you can see this whole outlet septum which is divided like this. So this is one continuous muscle septum which we usually see from the tricuspid valve, right?
Yeah. Thanks. Now we have, I hope the anatomy is clear for all students. You had a pictorial diagram, you had the anatomy by Anderson and his published article way back in 2008. This is how we correlate and see that we make you understand. Because when tomorrow when you are doing cases independently, you should not end up messing up. I have seen my own seniors who end up closing the right ventricular outflow tract and patient is not able to come off bypass. Mistakes have been done by somebody else. It doesn't mean that it will not occur to you. Okay, learn what not to do also is a part of learning in cardiac surgery.
For the question, what bands are cut, the answer is obstructing bands are cut. Okay. Most of the time, obstructing bands are parietal bands. Try to retain the septal bands because it contributes to the left ventricular contraction.
The crista, the septal and the parietal. In tetralogy, normally they are like this. This is crista and this is septal and this is parietal. In tetralogy fallow, they meet each other like this to create obstruction.
Thank you, Sumant, for adding that little extra through that article. It really made much clear. No, sir. Breakfast is after the next talk.
Angiology.
Angiology by, yeah.
We will now commence the program that was highly anticipated by the residents. It's on angiography and interpretation of CT.
What are the components of a cath? If I ask you a cath report, what are the components? Quick. See, quickly. It starts with the thing called as a cath course. See, I have given all the data. I expected you to be able to read. The first thing is the cath course. The second thing is oximetry. Third is the hemodynamic data. And the last thing is the angiogram. Angiogram is the last portion of a cath. A cath study. Understood? So there are 4 components to the thing. Now, why do we do cath course? It is to reduce the amount of contrast. There are certain diagnostic cath courses.
One collection of blood also.
Yeah.
No collection of blood, no contrast
Just
injected.
everything, nothing is
Just
required.
by the course of the catheter, you come to know many
What is
things.
the thing? You don't
Remember, this is pre-echo area or peri-echo area. Era, not area. Era. So when people did not know what is seen.
CPB accidents hakidiralappa.
So all that you see on fluoroscopy,
WhatsApp, what we had shared, Adi.
Cardiac cath anta
Cardiac cath studies.
So what you see is bone and air. Radio densities, radio opacities.
So you see cardiothorax, heart seal out, lung, abdomen, diaphragm, and most important,
Trachea and spine. 1 minute. Clavicle.
most important,
Spine.
that's all.
Yeah.
Now we have not spent anything. The baby is on cath table and fluoroscopy is this is seen.
Now,
Prasanna, you have got slides?
there is a slides, he's put the wrong slides. He's put CPB accident. I think we'll be talking till that time, sir. We'll not waste time. They'll tell us.
First is a venous cath. So venous cath is passed from femoral vein axis
Now remember one thing.
and a cath comes like this. So what is the conclusion? IVC is to the right of spine. Write it down. This is the format it should be described.
Can you put a personal slide?
So if the IVC is to the right of spine, conclusion, situs solitus. Understood? So you should speak like that.
Yeah. And
This is absolutely formatted speaking.
Yeah, see, remember one thing, they will ask you how, why is it a venous catheter or an arterial catheter? Remember, we never put an end hole catheter in the arterial system. Why? Because if you have a thing with the end hole, it can go poke the vessel, especially if you are giving a pressure injection. Or
Preferably
anything,
red.
And it can go into the
You have got red, this is all blue.
artery, and it can dissect the artery. If it goes into the ventricle, it can cause intraventricular injection and the patient can fibrillate because contrast is a highly irritant thing. Okay, so an end hole catheter is venous, whereas a catheter with a side hole is a side hole catheter is this. And remember that in cath you can also have a thing called as balloon catheters. So you have to see the catheters. Today you will not see so many balloon catheters of late because of CT, GT and other things where you can get the information.
And
But be
arterial
aware.
catheter, left heart catheters are pigtail. Sure.
Yeah, so it is
One end hole and multiple side
holes so that it doesn't cause intra-aortic or intraventricular injection.
Myocardial injection.
Myocardial injection. ಇದೆಲ್ಲಮ್ಮ ನಾನು ಬೇರೆ ಕಳಿಸಿದ್ದೆ.
Okay? And the first view is the most important view. Remember. So where the person stops, that's the most important thing the person wants to diagnose. So let us take a very common case.
This is right.
You have got some whiskey or alcohol, then it's clear. अच्छा, CHD बताएगा?
So we'll start with normal. Okay, first student come
Chalo.
here. Chal.
Start talking.
Come.
Format.
One person comes.
Carry the note in with your hand. So what is this?
Next one. Come up.
Straight catheter. So
it's a straight venous catheter.
very good. Pass from
right
femoral vein, catheter
crossing
to the right of the spine, situs solitus. Now,
through the IVC, crossing the diaphragm into the RA.
We didn't even start. No, I told
we
you.
have not started only.
From the time we started.
No, all three sessions of Tendulkar and Prasanna.
So
Till we leave. Huh? Kidhar gaya?
So then.
Till they leave or we leave?
Crossing the interatrial septum into the LA.
Crossing the midline.
Midline.
Don't talk interatrial
How do you
septum.
know it is interatrial? You are seeing smoke and mirrors. Nothing is seen.
Radiology, they don't say mass, shadow. So use those words. Crossing the midline.
Then what did it do?
Going outside the pericardium.
Outside the cardiac seal out.
Do you know it is pericardium? No.
Cardiac seal out.
Cardiac seal out.
We are discussing radiology. We are discussing shadows. So catheter is crossing the midline and going outside cardiac seal out. Now at what level? At mid level, isn't it?
Yes, sir.
Not here, not here.
Yes.
Going outside cardiac seal out.
Yes.
So first question, now stop looking there.
So that is observation.
Now, occipital lobe job is over. Now temporoparietal, the calculation and interpretation starts. What is that part which is outside cardiac silhouette? A venous catheter can go into
Communicating to the heart.
in this
Something
this is our field.
outside communicating. What are the structures that can communicate from
with
here
the heart,
to here?
but outside cardiac silhouette. Pulmonary vein. And now if you want to be very specific, pulmonary vein, look there and talk. Left superior pulmonary vein. Now same sentence you again write down, format. That venous catheter to right of the spine, situs soleus, crosses the midline at midpoint in the cardiac silhouette, correct? Yes or no? So what is that structure midpoint in the cardiac silhouette? Interatrial septum. That is you say in your mind. Okay? Crosses the cardiac silhouette and a catheter is placed in RSPV. You don't have a single girlfriend?
He is
LSPV, sorry.
Married.
LSPV. Understood? This is the proof. This is the proof that catheter has gone to the left side. Understood? That's very important. Catheter going up to here, it can still remain in some part of the heart. We want 100% proofs. Cardiac catheter is invasion, is a puncture, loss of blood. Special anesthesiologists are posted at KEM exclusively for cardiac catheterization. That to pediatric cardiac catheterization.
Because blood will be lost. 3
Understood?
kg child, 5 kg child.
Understood this? Okay? Now suppose I collect blood. What will be the saturation? 100%. Now I start collecting blood by pull back technique. That means pull back technique. That is one technique of collecting blood. Pull back technique. One catheter required. Very simple technique. Correct? And go on collecting sample and keep on doing saturations. So it comes here. What will be the saturation?
98 to 99.
98 to 99. It comes here. And still it is, say, not 98 to 99, 89. Understood? So like this, you keep on collecting samples.
Yes.
Chalo. Thank you. Prasanna, next, what you
Ray,
want?
put the PDF on, please.
Actually, I put a full set.
Okay.
Okay. Take. PDF.
Close, please. Otherwise, come up. It's not working. Put the mic on. It's not on.
Venous catheter passing from the right of the spine, crossing the midline at the midpoint, not crossing the cardiac silhouette and coming.
Inside the, by the way, this is inside cardiac.
Yes, sir. Not crossing the cardiac silhouette.
Homework.
Inside
the cardiac silhouette. Sorry.
Not
Other
outside.
than
It has gone down. Forget this part. Forget this part. Where this is? Right of spine.
Right of
this
the
is
spine.
IVC.
IVC.
This is left of spine. So this is descending thoracic aorta. This is actually entire abdominal aorta. That's why this is descending thoracic aorta. Differential diagnosis. If this part was absent, where this catheter could be? Left lower pulmonary artery.
You didn't understand?
Left lower pulmonary
artery.
Yes, sir.
It can go into
it has gone below the diaphragm.
Aorta.
It is aorta. Otherwise, DD is that.
Yes, sir.
Okay. Now he has drawn it little higher, but this catheter like this, that what sir was talking about in the commissure between anteroseptal and septal, also anterior tricuspid leaflet and the septal tricuspid leaflet, this commissure it enters, it flushes with the ventriculo-infundibular fold and goes into pulmonary
arteries.
What we feel, catheter from RA will go into RV body, then we'll go to RV apex, do high
Sir, we'll take the aside, we
and
won't talk on
nicely
that.
turn and go to pulmonary artery, doesn't happen. Catheter from RA in that septo anterior commissure, ventricular infundibular fold directly into pulmonary artery. So can you imagine where must be the pulmonary artery?
Here this is
Very good. This part is pulmonary artery. Then it enters ductus and turns.
coming at
And it goes
This turn is called anti-clockwise turn.
closed hairpin.
Okay? Anti-clockwise turn. And this alphabet, which is Devanagari T, Tamilians T. Devanagari Tiryada. At least T, Tendolkar, you must know. Oh, is it? So this is classic book picture PDA.
So incidentally, this is called as a closed hairpin bend. So you can see the closed hairpin bend in 6, and the thing by the side is called as an open hairpin bend. Now we were just talking that the anterior septal commissure, then you have the pulmonary artery here. Now if you are going like that, can you see there? That is, if the aorta is in an abnormal position, and so it is that is an open hairpin bend. Remember, our open hairpin bend is when the aorta is malposed and there is a VSD and it is going through the aorta. Now if you can take the, sir,
Is this non-erasable?
so what was the first picture there? No, the first is a normal course. It has gone into the, it has crossed the midline into the ventricle, which is on the, but what is the difference with the second one? It has got a high takeoff.
The mandatory
Spine is not there.
it should touch diaphragm.
Diaphragm,
Then only you say it has entered
the ventricle.
RV.
And if it goes below the diaphragm, high up and goes below the diaphragm?
This is okay. Now, very common thing. What a cardiologist is going to do? Collect sample, measure pressure, and do injection. Okay? So, you are a student?
Yes, yes.
You for the first time.
No, he was there.
You are here? First year, so not anatomy you know, no? So which part of the RV you think it is? Just now, Bob talked.
What would it be?
Give the mic to him, hello, take the mic
What
please.
part of RV? Reaching the apex? Apex.
Apex.
Now if I do contrast injection, where the contrast will go? RV? Don't go to the destination here. That
Blood, where does it flow first?
Kidneys for filtration. Don't straight away go there. We are studying anatomy. So where it will go first? RV outflow. RV apex. RV body. RV outflow. Then MPA. And then branch. Understood this?
Sir, will you go with
When
the
you
slides?
require this? Sitaram Bhatt first day. RVOT
Components.
Okay. Now what are the components of RVOT? Let me see whether end of the 2 day. Beta. Os infundibular. Then infundibular. 3 pulmonary annulus. 4 pulmonary valve. 5 main pulmonary artery. 6 see, you know everything, man. What happened? This is what the internal examiner tells. Sir, good student. Today you came and he is answering like this. That means who is problem? The external examiner is the problem. Always they say like that. Sir, otherwise very good student. Enapa, all this that you were talking, pa. Sir, only you came and this. Okay? So remember, look, this view you see, and contrast is going to be started. That is, this is going to be finding out the levels of RV, OT, or such. Now, second thing, Dr. Sitaram Bhatt told you on first day of tetralogy of fallow is what? One is RVOT obstruction. Number two, VSD. So what is going to happen because of VSD? Contrast goes into left ventricle. So what is the problem of RV and LV in tetralogy of fallow? No. From positioning point of view. I told you that day. Very good. Excellent. The interventricular septum normally is 60 degrees. Tetralogy of fallow, it is in coronal plane. That's why he was telling in the morning that LAD in tetralogy of fallow is
Never
not
seen.
seen.
Sir,
Everything people talk about importance. RV is bang anterior and LV is bang posterior. So something which is bang anterior and bang posterior in a PA view, can you make out it has gone from RV into LV? No. Then how are you going to come to make out? No. Same position. From LV where it will go? Ascending aorta. So, along with RVOT, you see ascending aorta simultaneously. That means two things. What are those? VSD and overriding of aorta. Now you use little your common sense. Everything cardiac medicine, certainly cardiac surgery is 1% knowledge, 99% common sense.
okay. Sir, we'll take.
Tell me what is the timing of contrast? It will be entering RVOT first or aorta first? If RVOT is obstructed,
so there
aorta will come first. So this is how you should be prepared to see. Chalo. Third.
What is the third one? Tell quickly the course. We have to quickly do it. It's there upstairs.
Situs solitus. The catheter is entering the cardiac silhouette from the right side, looping over, crossing the midline, not exiting.
Where does it go? It goes up.
It is not entering cardiac silhouette. It is entering heart. What you are seeing is
within the cardiac silhouette. Then it goes up.
Loops back in a clockwise manner and exits the cardiac silhouette.
It crosses again the midline. It has gone up, crossed over the midline, then it has come down again, and then it has come out of the cardiac silhouette.
Cross the midline at what level?
At midline.
Talk about structures which are seen. Medial end of clavicle. That means it has crossed at what level? From anatomy point of view, left innominate vein. Then it has come down on left side of the spine. So what is that structure?
Vertical vein.
Left vertical vein. It is right, left. You are supposed to speak. Then where it has gone?
Right up. Right up.
Common chamber. And to show 100%, it has gone outside cardiac silhouette on right side. So what is the diagnosis?
Supracardiac type of TAP.
Supracardiac TAPVC into left vertical vein. There are two types of supracardiac TAPVC. One opens into SVC and one opens into left vertical vein. Understand? Examination asks you to draw the various components of supracardiac TAPVC. Okay? So SVC, left innominate vein, vertical vein, common chamber, right middle lobe pulmonary vein. Chalo.
Yeah, sir, we'll take the next one. There's no time there, telling.
No time?
Yeah, so we'll go to the next one. The saturation, oximetry. So the next one we'll take the oximetry exercises. If you have a pulmonary vein saturation of 90%, a lung pathology. If all intracardiac
I personally feel tetralogy of fallow angio.
Yeah, we have got it, sir.
You have discussed so much part of tetralogy of
We've got it there. We've got the angio. Last, ideal CD? Sejal. You given the CD? No. I had told you so clearly to do it. You forgot?
I have got
Okay.
on my pen drive.
If all intracardiac chambers 88%, as a TAPAC. If
So
PAC,
what will you do if you see a high saturation? What is a high saturation on venous side?
right,
More than 80.
80.
So if you see more than 80, your job is to go one chamber proximal, one chamber upstream. Correct word is upstream.
Yeah.
Pranav was telling me, correct word is upstream. So if you find in SVC 88% saturation, you are mandatory to go even
Higher.
upstream in the right brachiocephalic vein or jugular vein, mandatory. Okay, and that saturation is 60.
Yeah.
So understand?
If PA saturation is 92 and aortic saturation is 84, it's a TGA because you are having the aorta and this thing. If a patient is waiting on the table for cath and the pulse oximetry is 99%, but the RA sample is 56%. I'm saying high RA is 56%. None of you got this? Low cardiac output. See, the patient is extracting everything. The patient is going to go into shock because it's something the anesthesiologists have to be wary of. If the SVC saturation is 90%, again it's a supracardiac TAPVC.
Or
PV.
right partial pulmonary vein drainage into SVC.
SVC.
So what Dr. I think OP Yadav was saying, avoid short forms. Tell full forms.
Then
By the way, SVC saturation is high or IVC saturation is high?
just check.
Because
Check if it happens.
just now, if we find out your brain extraction will be no extraction.
Okay, now,
The reason is renal blood flow.
yeah,
Renal blood flow of 1.2 liters
Is
is
that
not for
massive
oxygen,
AV shunt?
is for glomerular filtration. And similar hepatic, all intestinal blood flow is
Portal.
for other purpose. Liver blood flow, other purpose. So IVC saturation is very high.
so you all should know FLAM's formula. They may ask you. See, we gave you this exercise. Did you people do the homework? What is the diagnosis? Now, describe this.
So, chalo.
Describe it.
Number 3,
Come here. Describe it.
develop that format of describing oximetry.
I have given you FLAM's
Prepare
formula. I have given
a format for
Yeah.
describing oximetry.
RA is 85%.
No, no.
Don't read.
Conclude.
Interpret.
Ideally,
Start off with one
SVC
line.
given, IVC given.
What do you start off with? What are the broad groups of any congenital heart disease? Cyanotic, acyanotic. So start first with the aortic saturation. You first determine whether I am having a blue baby or a red baby. So there is, when do you say there is systemic desaturation? All of you did COVID duty. What do you say systemic desaturation means what? Below?
9.
You sent them to the district level this thing at 94, that is below 95. You sent them to the higher this thing when it went below 92. Everything has a reason. Na? So 95, there is no systemic desaturation. Then next, what do you say?
What is the formula for deciding the baseline venous saturation?
Saturation.
2 of SVC, 1 of IVC divided by 3.
3 or 3
So
SVC.
2 of
1.
SVC is 130 plus 75. That is 205 divided by 3. That comes to approximately 70. Okay.
So now what happened?
So now how much is the jump in oxygen saturation?
From the
75 to 85.
85.
85. Okay. So 10%. Significant or not significant? Significant. So what the first sentence is, there is a significant jump at the level of
RA.
Now, ideally speaking, he must tell you high RA, mid RA, low RA. So let us say this is high RA.
Because put the mic on.
Okay.
On
Next
close,
word
close.
is the same saturation carried forward?
Carried forward.
So you will say that jump is carried forward. That means there is no accidental jump. Okay? It is carried forward to.
Pranav came
Where is it carried forward
Pranav
to?
has come. I was remembering you.
Up to the great arteries,
Upstream,
no? It has
downstream.
gone up to the PA. So it has been carried forward up to the PA. So now what is your, now as homework, if you had done your homework, which we are not going to this thing, you are supposed to have calculated the shunt.
No, first of all, diagnosis.
Diagnosis. A shunt.
High RA, jump. Left to right shunt at.
The level of the atrium.
Left to right shunt at atrial level. It could be opening of coronary artery into RA also. It could be rupture sinus of aneurysm sinus of valsalva into RA also. We don't know on oximetry. Okay?
Yes, sir.
Understood?
Yes.
So remember these sentences. Number one, significant jump 10, 7,
5, 7,
10,
5,
7,
3.
5, multiple runs, 10,
7, 5, 3.
7, 5, 3. Okay? So minimum jump required is 10 in RA. Okay?
They may ask you why repeated runs, because if you keep getting a difference, it is truth. If I see first time I get 10, second time I get 7, above 7, and if I get the third time also 5, I am getting repeatedly cock crowed, sun rose.
So that
second
is-
day cock crowed, sun rose.
That is
Third
the
day,
principle of
cock
statistics.
crowed.
That a small change, if seen
Repeated.
persistently, it is significant.
Significant. This
Okay?
is Bayes' theorem. All of you should know about it.
Chalo.
Okay.
Sir,
Now-
only 10 minutes more for this
Now
angiogram.
pressures.
What do you see in this pressure?
RA pressure, LA pressure. You are thinking of ASD, na?
Yes, sir.
So RA pressure, LA pressures. Identical? Correct?
Yes.
So there
What is the peculiarity? Both phasic and the mean
different are same.
Same.
So
A wave, V wave, mean, same. Anything else?
equalization of phasic
Phasic
and mean pressures. Yedidu.
Then anything
Write
else?
it down.
Then next what can you say? What you see the RV pressure. What is your comment on the RV pressure? 60 by 9. Elevated what? No, not full. See carefully. 60 bar 9. RV pressure. 60 bar 9. There is raise in the systolic pressure, but the RV, what is the normal RVDP maximum? 8. So it is already 9. So there is there is pulmonary hypertension. Probably, we don't know yet. We have to see the next, the PA. RV pressure is raised and there is raised RV EDP in this patient. You missed that, right? Okay, that's important.
Is there a tricuspid stenosis?
Is there a tricuspid stenosis?
No, sir.
No.
Because
Pressure in it, yeah.
RV, EDP and RA pressures are equal.
Equal.
Okay?
Next.
Next.
Next. Is there pulmonary stenosis or RVOT obstruction?
No, sir.
No. But the mean pulmonary artery pressure is high. So there is pulmonary hypertension. Now, is that enough? Anything else you want to say? 110 by 6?
Normal, no?
Normal, no? Isn't it?
So
What
is
is
there
the, is the LVEDP higher than the RVEDP normally, or the RVEDP higher than the LVEDP?
LVDP is higher.
Higher. So normally muscle killer, no? So 10, anything above 10 is LVEDP is raised. But there is a hitch in all of this. Can you see something? Carefully see.
There is a gradient across the mitral valve of
How much is the gradient across the mitral?
3.
3. Now the thing here is that what is there? There is a ASD. Normally, if you have 3 gradient with the
insignificant.
it's insignificant.
But in ASD, if you see a gradient,
1 millimeter is also
significant.
So this patient has actually got mitral stenosis
In addition,
in addition to an ASD and has got PH and
Don't
has
write
got
it down.
RV dysfunction.
okay, anything can be changed.
Huh?
So
Has got-
compare RALA and that chamber and ventricular. That chamber and ventricular. This is how you should go on comparing, constantly comparing. So what is the full diagnosis?
ASD with
ASD with
MS.
very good.
Mitral stenosis with pulmonary hypertension with RV dysfunction.
Sinus rhythm, not sinus rhythm. Shh, don't answer.
Sinus rhythm was done.
Cannot say.
Cannot
What
say?
is the cannula?
You think to vacuum people.
If he has told you A wave,
Sinus rhythm. Now,
he must immediately start converting, man. If he has written down the A wave, he did not show you a tracing. He has written down A wave. So what is to wait for is sinus rhythm. So what do you think cardiomegaly? This patient? One of the biggest hearts in ASD are ASD
biggest
with
pulmonary
luteal
arteries and biggest hearts are in
ASD with luteal
Lutein
Becker. ASD with multiple shunts. That is the importance of not just saying cardiomegaly. You should say how much cardiomegaly. ASD RV dilates. RV dilates anteriorly. In the PA view, you won't be able to appreciate. But if you have got additional shunt, RF starts becoming fuller and fuller. LV starts dilating. Okay? So these hearts are large hearts. If you see a large heart on ASD, suspect this.
See, that we'll just give this. In angiography, you all have dealing daily with coronary. Yes, sir. If you hold it and see why. Basically, see, there are multiple views we can show, but what I want to show is how the spider view is specifically generated.
Lights off, please. Lights off.
Great innovation by Prasanna. Since he was a student, he is absolutely innovative throughout. So great innovative. Give him a big hand. First day I thought it is his exercise gadget. He has developed a lot of exercise gadgets. You know or don't know? Big, huge industry. Half of the house is exercise gadgets. Really.
So now what I want to actually show is, see, most of you have a difficulty in understanding how the spider view is. It's a little oblique. I'll keep it like that. So now this is the model of the heart. So when
Video telecast is happening, no live telecast.
Just for you to diagnose, what is this?
left
main. LAD, reaching the apex. Okay? PD. Septal. Correct? Diagonal. Left circumflex. Right circumflex. OA. PLV
not put
dot.
here because it will
And
confuse.
marginal not done. For us. Otherwise he would have easily brought. This is from water pipes and etc.
This is irrigation, drip irrigation pipe. Drip irrigation pipe.
Yeah. Now what should I do? First of all, what is spider view? He's saying spider view, spider view, spider view.
What is the view?
What is in description? What is in description? What is spider view? LAO cranial. Okay, how much cranial?
Caudal.
Caudal.
LAO caudal.
Spider is LAO caudal. Not
Okay. Why you require a caudal view? All the coronary arteries in the initial part run horizontally. Horizontally. So left main, initial LAD, initial circumflex, initial RCA for first 3-4 centimeters run in a horizontal or transverse plane. So if you see in the PA view, they won't be appreciated.
This is what you
so
see
somehow,
in PA view.
Somehow.
If we'll just show it. So if you see, if you keep it like this, this is the PA view. Now I will keep coming like this. This is the, as I come down, can you see? So, sir, you'll have to get it down close by, otherwise. I will go down, you'll have to get it. Now, sir, 1 minute, sir. I think we'll have to go up here because the thing is, now what do you see? No, you're obstructing.
Yeah, in the center, the online people cannot see, man.
Even the in-house people also.
It's very difficult because
the person standing next to him also can't see.
Wait a minute, because that it has to be on a high wall, sir. Because I do it in this college.
You want to do it on this wall?
On the wall, it will be better.
This wall? So this is convex wall.
Convex wall. Anyway, what you are going to see now, sir, if you hold it, can you hold it from that end? Now, I'll try to get it. Okay, so what is the structure you are seeing there? Hiramata yaradru ee kade banni. So what is the structure you are seeing now down here? Tap here. I'll keep. If I go far away, it becomes smaller. Sir.
My hand is coming in.
If I go far away, it is better. Sir.
Yes.
Yeah. No, I have to go far away. You stay there, sir. Down. Okay, now it has started forming. What is the structure which you are seeing down left main? Can you show the left main? This is the left main. Can you see? So the left main will be the structure which you are going to see down. Then what do you see going up? Actually, it is going above into to the roof. This is the LAD. Can you see there? As I go.
This is not caudal. Caudal should
It should go still down, sir. This way. Now it has come. Eleo. Here. My hand is coming. Now it is forming. Can you see it has gone to the roof, the LAD? It has actually gone to the roof. What is this structure? Diagonal. What is this structure? Circumflex. Okay. So you are going to see the left main down here. You will see the LAD going up. Can you see the LAD going to the roof? And then after that will be so you can remember it as LAD dock. LAD, the left main, then the LAD, the diagonal, and then the circumflex are all forming. Now can you see it started forming here? Okay, LAD went going up. This is the LAD. This is the LAD. This is the diagonal. Can you see the circumflex has come here? I mean the OM and the circumflex. Okay, so that's how it forms actually. Now if you take RCA, this is the RCA and all will be easy to see. You see, how does the RCA is seen? If you were to take like this, what has this become? You can see this vessel is foreshortened. You can see the entire length. But if I want to show the RCA, I'll hold it now. Can you see here? If I go obliquely, the mid portion of the RCA is seen. But as I go like this, I can see the PD. Understood? Can you see there? The PD is seen here. It becomes foreshortened here. So you can't see the PD. So as I move from here to here, you can see. Similarly, the opposite happens here. Here I can see the mid portion of the RCA. And here I can see the PD very well. Take the opposite side. Because the heart is like this. If I put PA, you'll see the circumflex, I can see the OM portion well as I go in. If I go cranially, can you see here now? When I go cranially, what do you see in the LAD? Which portion of the LAD do you see well? Mid, and you can go down to the apex, you can see. You can see the diagonal. Whereas if I go like this, I cannot, everything starts overlapping. So the important thing is each view you have to try to see which is the important thing that you can see. So how do you say LAD is LAD? What? Apex, then what happens? Something which is there in men that is not there in women. That is there in men that is not there in women. Mustache. Okay.
Which is apex and forms
mustache.
Okay, and septal branches.
Okay, how do you how are you sure that a OM is OM? How do you know for sure that an OM is a OM? You actually have to see the venous face and you can see the coronary sinus, and that shows that it is the circumflex and the vessel coming out from that is the OM. It can be confusing at times, so you have to demonstrate the circumflex in the venous face to show that it is the OM. That's the correct way of doing it, okay? Please remember that. Done. Okay. That's enough for now. Anyway, you'll have, and if you are asked about a cath anytime, you have to tell the way the blood flows. the way the blood flows. So if you are saying, I see contrast going from the left main, from there I go see it going to the LAD, this thing. Go in the path of blood. If it is a congenital cath also, follow the path of blood and keep telling. Okay. I think that's all we can manage in this.
Yes, sir. Thank you so much, sir. It's now my pleasure to invite for a lecture integrated with practical demonstration with real mechanical valve specimens. I invite Dr. Anil Tendulkar to demonstrate that.
For you, we have prepared one educational agenda about prosthetic heart valves. So we'll start with parts of mechanical prosthesis. So first is housing. So what is a housing? The part which houses the valve closing and opening mechanism is called housing. So this one what you see inside, see this like a ring-like structure inside is called housing. Okay? What is sewing ring? Attached to housing outside is the sewing ring through which you pass sutures. So what is the difference between mitral valve sewing ring and aortic valve sewing ring? Simple logic. Morning cannula. Bicuspid.
Bicuspid.
This is shit. Now that subsidy you have come to bottom. I give you one same company mitral valve, same company aortic valve. No. Mitral valve is always big annulus and aortic valve is always small annulus. So to optimize ID-OD ratio, what we talked in the morning, the sewing rim of aortic valve is always compact, non-padded, while a sewing ring of mitral valve is padded. Feel that. Feel that. All soft structure. That of the aortic valve is just a cloth. Moment you pad it, the outer diameter is going to increase, not the inner diameter. Okay? And the sewing rim is always covered with a cloth. This cloth should not be too much thrombogenic, should not invite too much of clot. Many of my students have a habit of passing the needle, taking it out. And again passing the needle and taking it out. So they try to do triple valve replacement in single valve. So I started charging them 1 rupee those days per pass. If you remove that pass, you have to take out 1 rupee. Immediately the student improved and started, the student is from Bangalore only.
Not me.
So remember, so what is the problem of passing the needle and taking it out? That sewing rim results in raising tuft of...
You can see it here.
Tuft, see this, beautiful. Tuft of cloth, which will be extremely thrombogenic. Understand?
What is it, valve?
Ball and cage. Okay. Any other valve? If you say ball and cage, apart from Star Edward? Maki.
This
Maki.
mostly is a
Okay.
Whenever that is given, always answer should be ball and cage valve. Don't mention the company's name.
We'll come back to that afterwards.
Then when the next question asks, two are there, Star Edwards and Mackey.
Okay. And now, what is the problem of sewing ring in aortic position? It can occlude aortic position. Immediately you must think of opening of the coronary arteries. So all these days we are implanting the valve at annular level. Now we started implanting the valve at supra-annular level. After Bob Anderson's lecture, you understood? Companies have been trying to fool us by telling us this is supra-annular. Actually the valve is annular,
and
intra-annular, subannular, supra-annular.
And this
Annular, subannular, supra-annular. So it is never supra-annular because aortic annulus is like a coronal shape.
Please remember that it crumples And that is why if you
So the-
oversize in the
so the-
aortic position,
so
the
the-
coronaries can get
Okay, well, how come it has become black in color?
No, we have turned it back. Get it,
It
get
becomes
it.
white also.
Oh my God, got shocked.
We burnt it with our light.
Ayo. So the supraannular ring is vertical like this and then flat, like a hat. Understand? While the standard annular ring is C-shaped. The edge of the sewing ring will be C. Any pen which is working? Working?
Yes, sir, yes, sir.
Working, I too? So this is supraannular ring. You, girl, what's your name? Shikha. What kind of suturing you are supposed to do for supraannular placement of valve? Inside out ऐसा नहीं बोलने का. Non-everting mattress
Who has the valve?
suturing.
Who was the valve?
Always the
valve
plaget will be towards, plaget if used towards LV. Needle pass is away from LV towards the surgeon, whether MVR or AVR. The correct word is non-everting mattress suture. And a valve sits over it. It is like keeping your bag under your chair and sitting in the chair. Well, valve level is keeping the bag next to you and sitting in the chair. Okay?
Who was the valve? TD Chitra valve?
Then
Where is the valve?
Then is the leaflet. So this is leaflet. This is leaflet. And what you see, what you think they will steal and use it again? Possible. Olden days they used to do it.
No, these are kept only for
Is
teaching.
to remove the valve at night from the autopsy and implant next day morning. So one valve used to work for some 10-15 patients. So this is a leaflet and it has opened. This is the opening angle of the leaflet. Understand? So the valve which you want to implant, you must know what is the opening angle of the leaflet. By rule of physics, it can't be 90. Because with closing pressure of aorta, if it runs parallel to the leaflet shall not close.
It will be permanently open.
Only,
Excepting for
only, कौन सा तुम्हारा वाला?
Onyx.
Onyx claims that their opening angle is 90 degrees.
It's a bilateral.
Does anyone know how onyx closes after it is at 90? Huh? So what happens is that at the level of the pivot, the blood actually swirls around and hits it on the opposite way to be able to close. That's why it's called as an open pivot.
Okay. Now all leaflets except olden type of valve called Cannulae Connectors valve, all leaflets close by non-overlapping manner. Tam ti tam tai ti tai. So there is no noise while closing. Tam ti tam tai ti tai tai ti tai tam. There is no noise. It is not tam ti tam tai ti tai tai ti tai. This is
There is a microscopic gap.
So there is always will be a gap. Hold it and see the gap.
You can shine light.
Okay, hold it against the light. You will see the gap. Always the leaflet and the surrounding housing, there will be a gap.
Why?
That's why I'm inviting you to come and sit over here. But you are at far away Maldives, beyond Sri Lanka. You are trying to sit as away from
Why is it made
us.
non-overlapping?
So what is the advantage of non-overlapping? No hemolysis.
Hemolysis.
That is to produce massive hemolysis. Modern valves don't produce clinical hemolysis. Clinical. Okay? So by, not even clinical, by standard tests of liver functions, no evidence of hemolysis. Reticulocyte count, absolutely normal. No clinical anemia. Okay? So remember, so you must know that. So when these valves open, they produce two orifices. See that? Two orifices. Two orifices. Larger orifice and smaller orifice. Okay? Now in mitral valve, I am the surgeon. This is the larger orifice. This looks like as if the AML is opening and closing, isn't it? See this? AML is opening and closing. So this is called anatomic position of the valve. If you keep this leaflet opening like this, it is called anti-anatomic closing, opening and closing of the valve. What is the danger of anatomic closing and opening of the valve? Yesterday, Dr. Sampath Kumar was talking about caudal preservation. So this leaflet
can touch.
likely to touch this valve while opening and closing. So remember, many companies prescribe that for their valve, the should be anatomic or anti-anatomic. So most of the companies nowadays prescribe anti-anatomic. Next is rotation. So we try to rotate this housing within the cage. So it should rotate easily.
In fact,
Chitra as such is not easy to rotate. Okay?
But you need to always rotate before implanting. Why? Always rotate the valve, put it in water and rotate and check. Why? Because what is the danger when you want to rotate any valve after implanting? If you don't stabilize the annulus, you can shear off the entire annulus. So if you want to rotate the valve, don't cut the sutures, check and then hold it up, and suppose you have cut the sutures. You cut the sutures and now you find, somebody has called me, sir, leaflet is not moving. What will I do? Huh? You take artery forceps, hold the suture and at 3 points, stabilize the annulus and then place, and how do you, with what do you rotate it? There may be dedicated
official rotator.
Or the holder in some.
Is a separate rotator provided by Medtronic, St. Jude, etc.? No. Same holder is the rotator.
Some companies provide this thing, especially for bileaflet valves.
Olden days, a valve could be rotated only clockwise. Nowadays, a valve can be rotated clockwise as well as anti-clockwise. So
what is annular rupture? When they are rotation, annular rupture can occur, the leaflet fracture can occur. In fact, one rotations during one of my good old days, one of the leaflet broke off. We had to replace the valve itself. So we have to be very careful.
So, olden days, Medtronic valve, if I want to, now valve is opening like this, I want to come here, I have to go all the way to 12 o'clock, 3 o'clock, and then come to 5 o'clock. Okay? So, disc is not moving, you want to rotate. How do you rotate? Always rotate little bit and test. Test with a valve tester or frustrator. Okay? What is the tester made up of? Same material or ebonite or some plastic not available on table. Fallen down.
Stilletta.
Some sucker.
No, you should use a rubber. Cover a thing with a shard.
Rubber with the shard like Charlie Chaplin beyond the hand. At no time your metal should be touching the housing.
So you don't use a sucker, anchor.
So this has got two inlet struts and one outlet strut. You must know your valve, which is the inlet one and which is the outlet one. So you prepare, those who are exam goers, decide what valve you are going to say. And what Dr. Ali Zaman was talking in the morning, I keep on telling for last so many years, whole practical exam should be I shall, not I can. Oh, well, I can. No, I shall use this valve. Don't feel shy. They know you are using that valve because at your center, you implant.
And always talk about what valve you use. I've had students telling some valve which they have just heard
This
of,
cannot be rotated.
never
It must be
seen,
old.
and then we keep asking them
Old
details
valve,
of the
not
valve. Your bosses may have used that valve. You may think that they have not used. They may have used, and then they will be aware of also, even if they have not used. So you should know your valve in your hospital.
Olden days, Chitra valve was without holder, integral holder. So we had to hold on artery and implant. So many times surgeons held it other way, and they had a double valve replacement in single valve position. No jokes. So
It has happened earlier. Whenever
frustrating.
if you load upside down,
It has happened to everyone. Don't, when you laugh at others,
Yeah.
remember 3 fingers are laughing at you. And 1 finger is remaining
In US,
neutral,
court cases have
saying,
occurred. Huh?
God's, understand? So remember, so nowadays all valves come with integral holder. Chalo. Valve number 2, sir was asking this valve. Sorry?
give the mic to him, please.
It looks like
In
the
a,
mitral valve.
in a monoleaflet valve, very easy to understand. Bileaflet valve also, if they are opening like this,
Like
I am
the-
the surgeon,
like the mitral
this is the mitral valve, this is the aortic root. If the leaflets are opening like this,
That's anatomic.
this is anatomical. Because this is normal, anatomical leaflets open like this. If they open like this, it is antenatal.
And St. Jude is supposed to be placed always anti-anatomical.
St.
because
Jude
it was
very
leaflet.
specifically
It
says
causes leaflet
our
lag.
leaflet should be anti-anatomical.
It causes leaflet
Why
lag
I
and
held it?
thrombosis.
Again, I wanted to.
No, anatomical and
और
anti-anatomical.
कुछ था मेरा नहीं हाँ I had taken this. This is Star Edward valve, okay, or ball and cage valve. You are very lucky generation. In our generation, every alternate year, Star
New
is to
model
come
would come.
with a new type of Star Edward valve, and is to call it 2130, 2140, 2147, 2178, like that. And someone examiner used to ask her, tell me 3162, what are the features?
Carbase.
So it's absolutely scary. Understand? Thankfully that examiner has gone, and so has Star Edward valve gone. What
This
is
valve is no
historical-
more available in the market. This is
What
one
is
which we had
the-
explanted and then implanted a different valve.
Historical importance of this valve? First valve to be implanted. And cardiologist nicely gave him Star, an old lady was undergoing 4th or 5th operation. Understand? So they gave him a good case to operate. Hi, Albert, we are giving you a good case to do. So Albert used this one. Mitral position or aortic position? Because cage
Cage
is
is
like
up.
this.
Now
Now if I
down.
hold it like this, mitral. Was it?
No, it's
See
not
the way
like
he
that.
laughed?
It's not
See the
mitral
way he
and
laughed? That tells you the marks you will get.
Okay, it's not that.
Have you well anytime? No.
When you
You've
have
not
got
seen this
4
valve.
cages,
Four struts.
4 cages, 4 struts to the cage, it is mitral. It is 3,
aortic.
it is aortic.
Because
Why?
you heard?
Why?
They don't
Because while passing the sutures, every time this ball was scratched by the needle. A joke hai yaar, haso na. So people are scared of laughing here.
No, they were seriously
Now
thinking
he has
about it.
understood. Now he started laughing. Now you stop laughing. So what officially,
We were
through the
supposed
3 cages, the ball was taken out.
And then you could pop it back.
You finish the suture and the nurse will tell you, "Ayyo, sir, ball very unde." So no, you had to put the ball
Put the ball back.
again inside. Understand? So this is how it was done in the olden days. Now Star Edward valve had multiple orifices. So this was considered as,
Primary.
first of all, the whole annulus was considered as primary orifice. Or no, sorry, this.
This one, the
This
round one.
opening
Here.
which you see
I've
is
marked
the
it here, sir.
primary orifice. Now the distance to which this ball is lifted and through this gap, the blood comes out was the
Secondary
secondary
orifice.
orifice. And the space when this
Between the wall and the
space between the aorta
And
and this ball, when the blood goes into the aorta, was tertiary orifice.
We used to say another thing called quaternary orifice also because this would bulge into the LVOT And obstruct.
mitral valve.
Mitral valve.
So you may put a large valve, but always there was a murmur. You may think you have put a large valve. So which orifice you have taken care? Primary orifice. But there could be secondary and tertiary orifice. And today afternoon we saw Dr. Bashi's department, CMC Vellore, was a very, very strong. They never changed their valve. Valves, Medtronic, St. Jude, etc. came and went away. They never ever changed their Star Edward valve.
In fact, those days this was the cheapest available valve compared to all other imported valves, what we call it as. Yeah.
Yes, this is what I mean. No, never been done it, never put it. Okay. So this was lots of physics was involved. How much this ball will go up? How much this ball will come down? If you to avoid that, if you make the cage very long time the ball will go up and won't come down. Like a basketball, it will, or volleyball, it will remain ball over there. So all these studies are involved in deciding.
Every change they made became worse.
And finally they came back to the original, some 2160.
6120 and 1260.
1260, great.
1260 in Aortic and 6120
so
in.
That is the interesting part. They went all round and finally came back to this structure.
They put cloth over it.
Star gave credit to Ahmad. There was a Star Ahmad fellowship. Ahmad was from Bihar, Indian, settled in US, and he started a fellowship. And I was one of the recipients of the Star Ahmad fellowship, spending 3 months, everything paid at Star's place. And Star gave credit to Ahmad. He said, the world asked me to change, except this gentleman. He said, no sir, this is the best design. This ball in Star Edward was the only mechanical valve which underwent structural degeneration, called ball variance. Fat entered this ball and made this ball soft and fractured.
Covered with cloth.
Yeah. Studs were covered with cloth.
6190
Studs were left open. Studs were on
then they
outside.
had an open tip.
Outside they had multiple things. Whole idea was to cover everything with endothelium. Aim of the mechanical valve is to cover as much part with endothelium that reduces the thrombogenicity of the
But none of them worked. Everything became worse.
Finally they came back to this Star Edward valve.
Finally it was withdrawn from the market. It's an high profile
Any other
valve.
contribution of Edward? First commercially available Swan-Ganz catheter is by Edwards. Just remember. I think that fellow was Star's friend.
Edward was an engineer.
Okay.
You want to see once everybody, because this is well preserved.
Orifices.
This is mostly Mackie. This is Mackie.
No mechanical valve?
Yeah, this is Mackie.
No other mechanical valve?
No, as of now.
Anybody amongst you going to talk about St. Jude valve? You implant St. Jude valve?
Who implants St. Jude valve?
I thought you were saying yes.
Yeah.
St. Jude valve?
Come.
Huh?
Yes.
So what is the peculiarity of St. Jude valve? By the way, currently all valves are single cast. What is single cast?
They're not welded.
They're not welded, joined, nothing, bent, nothing. Single solid material, carve out and make it into a valve. Now St. Jude,
just see the ball. They are pressing the ball so much it should not get fractured. Just see it and
may
keep
be
passing.
called ball tampering.
Ball tampering.
Sachin,
It's a very precious one for teaching purpose which I kept. Keep passing it. You will not see that valve, so it's not available.
Now, this bileaflet valve also have got, by the way, this by the time the mechanical valve closes, there is always grade 1 regurgitation. Good or bad? Good. Why? It's supposed to wash the non-outflow surface of the disc. So disc opens, blood goes out. When disc closes, same blood comes back and washes the non-outflow surface of the disc.
It's called as washing jet.
So this is considered as normal. So grade 1 regurgitation is normal. And it should be what kind of regurgitation? All within the housing. Should not be outside the housing. Okay? Should be grade 1. And this grade 1 is on echo. This murmur should not be auscultable. I told you, any prosthetic diastolic murmur is abnormal. No discussion. Okay? Everybody has handled that ball?
Yeah, it's moving out. Yeah.
So that is physiological regurgitation. What is effective orifice area? Chitrawal kidhar gaya? What is effective orifice area?
We have a ring also.
So if you take out from this housing, place occupied by the disc, place occupied by the struts, that will be effective orifice area.
Geometric orifice area is geometrically what you get. Effective orifice area is actually the functional area
through which the blood
flows. It can be not measured directly. It has to be done by using you have to read a continuity equation.
What is the difference between mechanical valve opening and biological valve opening? Mechanical valve, cardiac output even 1 ml will open to its full level. 72 cap, 78 degree or 82 degree, no discussion. While biological valve will open according to requirements, cardiac output. So what the biological companies do, they keep the heart rate 60 or 50 and study that photography where valve fully opens and then closes and they impress you. See the valve leaflet opening to its full. Bastard, you kept the rate 60 or 50 and gave 4 liters, instead of 3 liters flow, you gave 5 liters flow. So increase the output. So that is the difference between biological valve and mechanical valve opening. Okay? Bileaflet valve, इसका नाम मैं भूल जाता हूँ. Suvi. How many openings? St. Jude valve, all bileaflet valve. By St. Jude I mean bileaflet. 3 openings, 2 sides and 1 center. And maximum flow through center and little reduced flow from the side. Now St. Jude valve has got inlet their pivots are on the within that. It's called pivot guards. Pivot guards. All bileaflet valve, the housing is like a tube. This was like a ring. Chitra was like a ring. In bileaflet valve, all the housing is like a tube. And 90% of the leaflet opening is within the tube. So all that fear, that surrounding structures will pout into the papillary muscle, the leaflet will pout into, danger is much less in a bileaflet valve as compared to Chitra monoleaflet valve. Incidentally, what is the market of Chitra? Just general knowledge. 33% of Indian market is Shri Chitra valve. Why it is Chitra? Finger. In Chitra nurses conference, I asked them why it is called Chitra. So they said finger. And this I told the Chitra valve maker, Shankar, in the evening. He put down his 60 ml and got angry. He said, take me just now to that nurse. I will throw her out into Arabian Sea. So I had to calm him down by another 60 ml. So remember, this Chitra is Shri Chitra. So why TTK's name has come? No, TTK is a company which has taken over a large scale manufacturing. Okay?
Who was the one who founded it? Who founded it? You should be knowing.
No, not that.
Just like yesterday,
Valiadan.
Dr. M.S. Valiathan.
Incidentally, Valiadan, apart from being a cardiac surgeon, was a chemistry PhD. And his first contribution is not the Chitra valve, it is the GOT shunt. But GOT shunt, which is used in liver transplant and this thing, that TD Mac shunt it was called. That is the GOT shunt.
Chalo. Now let us come to the bioprosthetic valve can be divided into free valve and stented valve. Okay, so these are stented valve. So what are the outer structures? What is this? Again, sewing ring. And what is this? Or stent post. Another name is stent post. And in the stent post is this material. To me, looks like a pericardium. Am I right?
Yeah, this is a pericardial valve.
Pericardium. Achha, incidentally, all mechanical valves have got their own personal signatures on X-ray. So very commonly you will be asked whether this is, which mechanical valve is this. So please go to your homework, go to internet and find out Medtronic Hall. Medtronic Hall.
Radiologically cannot be seen, others can be seen.
St. Jude, अपना ये क्या अपना TTK Chitra and Star Edward.
And just remember.
And how to know whether it is mitral position or aortic position. Coming back, this is pericardial valve. Okay, 3 leaflets taken, cut and sutured from inside. Another way is take a mundu, full piece and put it outside the struts.
All the valves with the ones without struts have failed and have been withdrawn from
So it is like 3 leaflets. Each time there is a pressure, there is a stretch on the pocket like this. So what will happen? 72 times a minute, 60 minutes in 1 hour, 24 hours in a day. It will tear at this spot. Okay? So this was the first Ionescu Shiley valve. Okay? So Ionescu Shiley was the first pericardial valve. I still don't know what modification these people have done.
Then trifecta also was one which was made outside.
No, but
that also tore.
So most of the now designs are like this.
Are like this.
Which is the another biological valve? Porcine valve. Now all porcine valves are tri-leaflet valves with a muscle shell in RCC. So if you see, draw a circle, 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 and draw 3 leaflets. Okay? Draw 3 leaflets. Very good. And the RCC leaflet, you decide which is RCC leaflet. In the RCC leaflet, draw a muscle bar along the margin.
I've just shown that there.
No, muscle bar.
Bar goes inside.
Along the sewing ring.
It goes like that. You can see there is a muscle bar like that. You will find a muscle bar shelf.
See that muscle shelf? This is present in all the animals, including human beings. More pronounced in cows, bovine. And this muscle bar extends on both sides, from RCC to NCC and LCC also. But RCC it is pronounced. And because of this muscle bar, that leaflet movement is less. Number 2, this muscle is extremely antigenic. So this produces all that calcification, etc.
So they wanted to?
So many companies have tried different tricks to remove this muscle bar. So it was first to be done by Edward Carpentier. He lifted the muscle bar into the stent post. So this muscle bar, suppose my elbow is muscle bar, was lifted into stent post.
So it's strictly triangular.
So what will happen to the leaflet? Shorten. So he pressed both the leaflets, the other 2 leaflets to compensate for regurgitation.
So it was a triangular.
Understand? So as a result of which, these three stent posts are not equally placed. That's why the company shows you marker, which should be the stent post, how they should be placed in mitral valve. On either side of the correct, loudly. First time in 48 hours, we'll hear your voice. Chepu, 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 chepu. See, chepu, she understood. Marathi chup chup means keep quiet. In Telugu, chepu chepu means speak, speak. So on the common annulus or aortic annulus, the stent posts are at 10 o'clock, 2 o'clock and 6
Basically
o'clock.
trigons, you remember.
Like this. Okay? What St. Jude has done? St. Jude has removed all the three leaflets. And only the non-coronary and left coronary leaflets are used to produce a tri-leaflet valve.
So you need two valves, two pigs to make
So you
one.
require 3 pigs aortae to produce one. Understand? You know or don't know? So if you are using porcine valve, you must know how the muscle shelf is taken care of. What is the generation of valves? Generation of valve is like cephalosporins. More the number of Z's in the name, it is latest generation. Huh? You know, every company will tell, sir, ours is the latest generation. These companies only have created this generation. No association, American association, European association, no association has declared this generation. So what are the first generation valves? One with muscle shell, which was removed and was changed. Second was closure. What are the closure of valves while preparing the valve? High pressure closure.
Fixation.
Low pressure closure for fixation. High pressure fixation, low pressure fixation, zero pressure fixation. Actually, high pressure, zero pressure, low pressure. So while fixing, pressure on either side of the valve is same, high, or difference is low.
We have added cath course and chest X-ray signature with the prosthetic valves in the 12th edition of our score notes.
Okay?
So you should say, Dave, can I ask you collagen crimp?
And last is decalcification treatment. So every company has its own decalcification treatment. It's not decalcification, anti-calcification treatment, and every company feels ours is the best. Okay? So remember this part. But it is not just the company is Indian, the all material comes from Russia. All
No, the pericardium is
but
not from
material comes from Russia.
Pericardium comes from Australia.
No, so everything comes from assembled.
Edwards valve assembled in USA, but pericardium comes from the same place, Australia.
Only 2 countries in the world pericardial membrane is accepted for human products.
Here the Indian girls do it. In USA, in Sacramento, I think. The Chinese girls do it.
Yeah.
In USA also it is.
They always require ladies, short ladies, soft hands. Everything is done manually. And one person just keeps on doing it manually. So this company has got one single marker. And if usually single marker is there, it is as 2 o'clock position. Okay? In aortic, what will you take care? This stent post will be right at the commissure. Should not be obstructing the coronary arteries. If at all, which coronary artery will get obstructed? 50% chance of coming correct. By God's grace, only 2 coronaries. Right. Why right? Why not left? If you see the statistical openings, right is more near the RCC, NCC commission. Okay? While left coronary is usually in the center and left coronary is posterior. Aortic annulus is oblique like this in me. So highest spot is right and the deepest spot is center of left coronary cusp. Got it? So more chance of that. Air goes where commonly? Right, and calcium goes into left. So remember this
They can
relation
ask
and
you how do
quickly
you
able to
avoid
answer.
calcium going into the coronary nerve?
Yes, how do you avoid calcium going into coronary?
If you get aortic valve, that's a common question to be asked.
Suction catheter or coronary
Mike, please.
hospital catheter.
Number one, number two, always. Don't remove, first pack the LV and then
With a roller gauze, we pack a
Pack the-
wet gauze piece into the LV.
gauze ways to capture there so that it doesn't embolize later.
What is cinching?
Cinching of a valve.
कोई किसी को भी नहीं मालूम?
You have not seen the valve, you have to cinch the valve.
They all repair your valves. They are your students. Tell me, artificial valve क्या है मालूम ही नहीं हमको. You only repair valves.
What are you telling? No.
It has nothing
Not
to do.
open the valve.
It
You
has
actually,
nothing to do with.
the struts are brought closer together.
In mitral position, the struts go into LV. So it is like eating food. So you don't eat food by keeping your fingers open like this. So how do you eat food? By closing your fingers.
And it prevents the...
So the mitral position, Edward, Medtronic, and maybe other valves.
Even Merrill also.
There are different names given. Edward called it some Edward has the name. It's on my laptop. Requires transfer. Tricentric loading. Whole idea is these three stent posts. One single suture is passed and is brought out from the sewing rim.
And then
So when you load the valve,
And
you
tighten.
rotate it 2.5 times. So this all stent posts will close. Now you implant the valve, finish suturing, and when you remove the intrinsic valve holder, automatically the stent post will open. Biggest complication in our days was the suture going around the stent post.
And it causes the
And
valve to...
biological valve, which stent post is seen by the surgeon? One at 6 o'clock.
6 o'clock, you cannot see the other two.
Other two at 11 o'clock and 2 o'clock cannot see. So by this, you ensure that no suture goes around the stent post. So you are supposed to take sutures, lower the valve, tie the sutures, and last step is remove the valve holder. Okay? If the valve holder rod comes in your way, you can remove the rod, but that seat over there, don't try to remove it. When you remove it, automatically the stent post will open. Biggest problem with pericardial valve, they have a fairly gross static regurgitation through the central orifice.
And they also
Pericardial
high
leaflets
struts.
never come together in the center. In the center, there is always a space of this shape, of varying size. So always, there is a regurg in the center. Pericardial valve. Okay?
And sutureless valve.
What is sutureless valve? Short note. Uses what technology? Nitinol.
Nitinol.
What is the advantage of nitinol? It has a memory. So this memory disappears when you cool it.
Cool it.
When you rewarm it,
It comes
just
back
like
to it, sorry.
Hindi movie,
And by the way,
Yardash
Percival
aa
is not
jati
the
hai.
only sutureless valve. Be aware. There's intuitive valve and other things.
So where
In
do you,
India only one is.
where this valve, if sutureless valve goes, at what level? Base of the nadirs. So the first 3 steps should be at the base of the nadir. You were awake that time when Bob was showing you the aortic walls, he was trying to show you. So you are awake. So at the base of the 3 annuli is the nadi. You take 3 stitches at that level and this valve descends to that level.
How many sutures do you tie after putting the sutureless valve? You don't put any sutures, you remove all the sutures.
But some valves required a suture. So what is the new name of this sutureless valve? Rapid deployment valves.
See, especially Percival, you should not put the suture because when it starts expanding, it will expand in an odd manner and it will cause paravalvular leak if you...
So I told you generation, I told you muscle shape, leaflet opening, I told you, stent post, and olden, modern also may be have a radiological signature. By the way, all valves are MRI compatible. What is this?
This is for the instruments next, after post-T instruments. Session will go up to 7, all of you be there, otherwise the notebook will not get, Satyasai notes will not get.
Everything over.
Then I want some discussion on the rings now, sir, because rings will be asked in the exams.
So officially, why this ring is this shape? Why, first of all, why at all this ring is this shape? It's open anteriorly. So in mitral annulus, anterior is fibrous annulus, common annulus, aortic annulus, fibrous. Rest is muscular, like Chinese mustache, thick here and becomes thin and totally absent at this spot. So you take this ring. This ring is covered with cloth. This ring is without any padding. Okay? Where this line should go? Line should go towards the endocardium. And without line should be towards the cavity. Supposed to have 2 markers. See these markers? See this marker? See this marker? बैड हुआ अभी तुम्हारा सर बोलता है रिंग के ऊपर बात बैड हम लोग दोनों ही अभी सिखाने वाले हैं अभी कोई कुछ बोलने वाला नहीं है वो सब भाषण हो गया उधर का ओके सो दिस 2 markers should correspond to your fibrous trigones. So fibrous trigones, what is the position of fibrous trigone? Just 1 or 2 stitches inside the commissure. So draw mitral valve. Draw mitral valve.
If you actually pull the mitral valve, AML, there will be 2 furrows which will go towards the trigone because they are fibrous.
Correct. Very good. And so beautiful. So just 1 stitch inside this commissure. Just 1 stitch inside this commissure is the fibrous trigone. So you take 2 stitches, parallel, non-plagiated ethibond, 25 mm, non-plagiated ethibond, parallel to the annulus at the trigone. Okay? Pull them. Now you take, we are not going to have tea break now?
Sir, yes, sir.
Kabhi?
We are breaking for tea break.
I want Caesar. Caesar! Suddenly everybody feels homely, you know. First time we feel back into OT. Prasanna is here for such a long period. And no shouting said not possible. So this ring measurer is this shape and it has got 2 notches. Like this. Okay, I'm very sorry for this gajera. And it has a central place where the rod is kept. Okay? So what you do? These 2 notches should correspond to these 2 trigonal surfaces. Then what carpenter does? He takes a hook and pulls the AML. So the clear surface of the AML should cover this totally. So this guarantees that the competence of the whole wall will, after the ring, will be maintained by AML. The clear part of AML. AML has got two parts. Clear part, rough part. Rough part is the one coapting, while clear part is the one which is moving. Correct? So these are the two things we must do. Now after this, we must take parallel sutures. Alternate green and white, and pass through that ring and lower the ring. Tie the sutures. And carpenter does one thing. I ask him, why don't you manufacture like that? He pushes these two parts up towards the LA. Because here is going to come the aorta, which is going to bulge during systole. So it should not be prevented from bulging. So these two, see this? So almost like a physio ring. Understand? So towards LA, because the aortic, torus aorticus is going to bulge in that area. Okay? How do you test the wall at your center? Tell a full process. On table testing of wall. Take accepto.
Fill the ventricle with the
With
Accepto saline, sir.
accepto saline.
With saline.
Warm or cold?
Cold.
Without air bubble, with air bubble?
Without air bubble.
So who is going to tell all this?
And then up to
And
what
without
point?
gauze piece.
And
All the nurses always put one gauze piece into the saline. Always. Perpetually ready. Understand? And we are testing the wall and seeing through your loop, one fiber of that gauze piece is dancing.
So,
It goes
how
into
do you know
LV,
that you have filled the
and
ventricle?
from LV it goes into brain, and then you have gray hair.
So how till where? How much do you fill?
See the saline coming out
From the cardioplegia cannula.
Okay. So you open the cardioplegia case.
Cannula.
Otherwise, what will happen?
LV distension. Distension of
Something else will happen.
Air will
Air
go
will
into
go into the
coronary.
which coronary?
Right.
So if you tell me air will go into right coronary artery, and he says that, and you don't say that, then I will give him more marks. You will say he's from Mumbai, that's why he was favoring him. Understand? This is how examiners are going to. What do you check after inserting saline? Coaptation. Then? Now, the coaptation
Line
margin
should be parallel.
should be C-shaped, like a smiling
Parallel to
face,
the
and parallel to posterior leaflet. ये सब लिखो. Coaptation.
ये लोग किया है.
I do simple thing because I am born brought up in CMC area. I pass a catheter from LV
LV
apex.
apex. I used to do
And
that.
I inject, nothing is going across the wall. So the wall should be absolutely nice. I can generate pressure, and what he said, I can see saline coming from cardioplegia with a jet. And then close LV apex as if you are closing, following post CMC. Two sutures, one interrupted suture and one figure of 8 suture. Without, no discussion. Thereafter first stage, no bleeding, don't do anything. Nothing. Second stage of checking.
Then after that, what do you?
Second stage of checking.
It's junction violet to check the level of coaptation. We do an ink test where we actually the line of closure is we
Mark.
junction and then you check the depth of coaptation.
Okay.
It should be
So that should be minimum.
10 millimeters. And then third.
So that is the rough zone. So if you try to do too much of thing, if rough zone height is not adequate, namaskar, this height is not adequate, this coaptation won't hold a pressure of 120. If it is like this, it won't hold a pressure
I
of
call it
120.
Hanumanta versus Pa and
Okay?
like this.
Okay.
And then the third thing is that you check again. Final test is on T.
Transesophageal echo.
We'll have a 10 minutes tea
Many
break.
surgeons, after repair, do their own transesophageal echo and declare, I have done a good job. How will you know without transesophageal echo, you have done a good job? First, simple, any cardiac surgery, Patient hemodynamically stable. Means what? Coming off bypass, good pressure with low CVP. Then you can feel from outside. After boss washes out, you feel from outside on LA, roof of LA, diaphragmatic surface of LA appendage, where you feel any.
In olden days, I used to use a stethoscope, a sterile stethoscope.
And no, I still put stethoscope on endotracheal tube, bell of the stethoscope on the endotracheal tube. Left bronchus in contact. I don't know what is the practice in DNB, but whenever I am examiner, I ask students to pick up one instrument. Okay? And if he or she picks up very simple instrument, I give one difficult instrument. So simple as that. Okay? So I give one difficult instrument. Straight away say, I have not used this instrument, no problem. Give you another instrument. Okay?
Never seen it in my life.
Yeah. Simple instrument, if you say, I have never seen in my life, you will be told to go back, see in your life, and come back. Okay? So don't try to be smart. Chalo.
This Cooley's retractor uses for LA retraction, sir.
Cooley's LA retractor. Why Cooley developed this retractor? Before this retractor was developed, how LA was retracted?
By using Langenbeck's retractor.
Sorry? Correct? Correct?
Langenbeck's retractor.
Langenbeck retractor or ters?
Retractors.
Retractors. Two retractors. So if you give two retractors, what the assistant will have to do? Both hands for retraction. So assistant's one hand was not available for any help. So Cooley developed this Cooley LA retractor. Okay? Now, how do you insert this retractor? How many sizes it comes? Official name, right question he asked, official name atrial retractor. It comes in two designs, this curved design and another is, this part is,
Like a claw hand.
so you retract like this. So official name atrial retractor. Okay? What are the, how do you insert this retractor? This is a small size. Suppose you have a large size Cooley retractor. How do you insert a Cooley retractor? One limb is inserted first and then second limb is inserted. So insert this and then the other and then retract. Okay? What are the injuries produced by this retractor? LA tear. Which part? Because of what? LA tear occurs in all teaching institutes because the assistant who is the student, he wants to see. So he retracts like this and looks inside and makes sure boss is taking proper stitches. So LA goes on tearing. So simple thing what I do, I always take a very small incision. So if I require 10 centimeter, I take 4 centimeter. And remaining 6 centimeters, I allow my resident to retract and tear. So I don't have to bother. Okay? So this part of the LA retractor bulges, hits against the interatrial septum and it results in hematoma of the interatrial septum. What problem is created while valve testing by this retractor? Pidipa? Sorry? When you retract Cooley retractor, the AML is retracted away. So, during testing of the valve, one requirement is to drop it, not use it, or just use two right angle retractors just for the surgeon to see the mitral valve. Otherwise, you pull it too much, the AML will just be taken away. Any other time when Cooley retractor has to be dropped loose. Very good. So what cardioplegia will be this? First or second? Second cardioplegia delivery. Very good. So second cardioplegia delivery, this retraction by the same rule produces aortic regurgitation. It hit against the aortic torus. So you must let it loose, give cardioplegia. Can you describe your technique of second cardioplegia? Besine bolo. What is the biggest danger of second cardioplegia? You also can answer. Anyone can answer. Very good. So why are you worried? Start talking. What is biggest danger of second cardioplegia? Air embolism to coronary arteries. And which coronary artery just now we discussed? Right coronary artery. So you have to let the air out. So how do you let the air out? What's your name? Ram Prasad. Give him a big hand. Huh? Very good. So how do you let the air out? First is open the cardioplegia vent. 2, if the air goes into right coronary artery, can you clamp coronary artery, right coronary artery? Take a forceps, take a mixture and clamp the whole fat in RCA. 3, you ask the perfusist to give cardioplegia very slowly. When it starts coming, air will start coming from the cardioplegia bifurcation, and when only blood starts coming, you close it. 3rd, 4th, can you make aortic valve incompetent? I take a mixture or SIMS, and for mitral valve, I pass it into aorta and open. So there is gross air. So all air comes out. Then take it out. So number 1, open the Y. Number 2, give slow cardioplegia. Number 3, make the aortic valve incompetent. Number 4, clamp the RCA or just hold it in your forceps for a few seconds till all air bubbles come out. Describe your LA incision. This is the standard pattern of examination. Instrument given, you will be asked about instrument. Number 2, use of that. So describe your LA incision.
Incision should be made parallel to the solder guard screw.
Very
by
good.
identifying the
How much centimeter away?
1 centimeter away.
As
Parallel.
near the groove as possible.
Yes, sir.
You must go as near the mitral valve as possible. If you go away, danger. Okay? Where do you start? Where do you start first incision?
So if I dissect the pad of fat, after that I will find the
Where do you start?
below.
Start puncturing LA at the highest spot. And what is the highest spot?
Right superior.
Between the 2 right pulmonary veins. Okay? You stab it. And then you extend the incision with what scissor? Mayo scissor. What Mayo scissor? Medicine bomb scissor. So start answering. See, more you talk like that, more marks you will get. Where is medicine bomb scissor? I thought there was one medicine bomb scissor. Suppose this is medicine bomb scissor. You are the surgeon. Show me how will you cut. Forceps. 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 This is the head end of the patient. I wanted you to show to the camera. Tambi, angir ke pare. Nice body, huh? If he hits me, there will be a memorial in the name of Anil Tendulkar died while teaching. You are open in office. Loudly. Ayo.
And then after that I will turn my scissors and then
Loud.
incision inferiorly.
You are not saying some mantra, the வாதியார் வந்துட்டு பூஜா சொல்றான் என்ன பேசுற ஆருக்கவே தெரியாது அப்படி இல்லைப்பா. Always keep it facing anteriorly at superior end, and inferior end rightly you go between the incision is not straight. Incision curves down and goes posteriorly, and posterior end goes where? Between IVC in the RA and right inferior pulmonary vein. So my teaching to all the students is look inside and cut. Don't cut from outside like that. Look inside and cut. At upper end, you take care of right pulmonary artery. Roof of LA, right pulmonary artery is absolutely closed. There is a recess. When you redo cases, this recess won't be seen. So upper end, people have cut right pulmonary artery. Understand? So just remember, right pulmonary artery and lower end, if you go straight, you will open RA. Okay? You first is the stab incision, isn't it? Moment you stab, the perfusionist tells you air, lock. What have you done? Tendulkar told you to go as anterior as possible, so you have gone as anterior as possible. You are entered RA. What are you going to do? Quickly. Quick.
I'm doing two SVIV condition. I will go around and make a total
If it is, what did you say? பைத்தியம் மாதிரி பேசக்கூடாது சொல்ல வைக்கிறேன் உனக்கு பின்ன if it is what cannulation you said? Whichever cannulation. You have to say by, if it is bicaval. It is always bicaval. You can say, if I have already taped SVC and IVC, I will tighten. Some centers they do it. Understand? My saving time. Our anesthetists are constantly checking what time you are finishing. So what will you do? How do you close that hole? Is there any instrument over here? You take this instrument. Where is that? Yeah, dual. Where is that dual? He's so happy to give dual for use. See that happiness on his face. So you quickly take a dual and that tear in the RA side, close it. Remove airlock, start the bypass. Now take your own sweet time in switching. Dual not available. You can take side biting clamp and clamp it. How do you close LA? As Dr. O.P. Yadav told, don't suspect rat in every question. Simple question. How do you close LA?
Phyoprolin switches.
Phyoprolin? Okay, this is what? Auction? Phyoprolin. Sorry, trioprolin. So, you require a long needle. Particularly the patient has got mitral stenosis. Understand? Phyoprolin is very short needle, 17 mm needle. While foroprolin, SH, has got 26 mm needle. Start from where?
From the lower end of the incision.
Loudly.
From the lower end of incision.
From the lower end of the incision. Why? Why not from the upper end of the incision?
Because technically it will be easy to close.
Not easy. Loud.
Always difficult part first. Number two, as you start closing the lower end, blood can come and stay in LA. And that reduces the air. Two sutures, one suture.
Two sutures.
From where to where?
From the lower end to
From lower end to center. And upper end to the center. Understood? And where do you stop? At the highest spot. Just now I told you, between the two pulmonary veins. Do you dissect Sondergaard's groove before inserting Cooley retractor? When it is done? With the LA is very small, you won't be able to put this. You dissect in Sondergaard's groove, where you can go into the septum anteriorly into RA or posteriorly into LA. Okay? Chalo. Sir wanted to know 1 layer or 2 layer?
2 layers.
Two, what is 2 layer? You again go back?
Yes, sir.
And 2 layers?
Yes, sir.
Okay. Many people do 2 layers. I always do 1 layer. Excellent. What's your name you said? Devakumar. Give him a big hand. Chalo. No chocolates?
No. High tea is there, sir.
High tea. Ange paare, camera irke paare.
This is Aortic.
You're Tamil Karan or?
Yes, sir.
I may be speaking Tamil. He said, Kannada bartade, Tamil bardilla.
This is aortic partial clamp.
Whose name? Why aortic? Can't be used on femoral artery? I can't use for IVC. Just now I used for RA.
Yes, sir.
So it's a side biting clamp.
Yes, sir. Side.
Okay? Goes with the name of? Satinsky. Satinsky. Okay? Now look at the tooth. He says it was originally made for IVC. Look at the tooth. Keep the tooth or teeth. Okay? All of you see these teeth. You got Cooley clamp? Classic Cooley clamp. These teeth are 3:2 or 2:1. That is called Debicki teeth design. No. Close it and see the tip. See the tip. Close it and see the tip. So all atlas, all journals, all books will say Debicki Satinsky clamp. Debicki this clamp. So Debicki did not invent. The tooth design is that. What is the Cooley tooth design? 2:2. So in the center you will always have a hole. Okay?
There's another one, castanate aspiration. That is 1:1.
So can I have it now back? So this is called clamp width, and this is called clamp depth. Okay? Have you seen Dera clamp? Dera clamp? Have you seen? No? So Dera clamp, same clamps, only it will have one additional angle. So when you put it for proximal anastomosis, this clamp comes up, while Dera clamp will fit on the patient's neck. Okay?
It's deeper also.
Sorry?
Dera clamp will be deeper.
Deeper also, yeah. This jaw width is more. Okay? Now, on the mic, you apply the ratchets. Apply the ratchets. I want to record the sound. Ayyo! He has taken the name of Karunanidhi, M. Karunanidhi, Stalin, Ella. Khalas. Down. Destroyed. It should be. Bleeding? Alata? People have studied the amount of pressure you generate with each ratchet. Understand? Why? What makes it avascular or non-traumatic? Why makes it vascular clamp or non-traumatic? What design I purposefully opened for you? Serrations are longitudinal. Number 2, this is called box. This is called box. So pressure applied is force multiplied by length. Force multiplied by length. So as this length increases, force will decrease. So all vascular clamps, anybody holding cross clamp? See this? The box will go away and away from the tip. We can take both these clamps together. Okay? Now this vascular clamp, you clamp it and see it against light. PD, against the light, and tell me about the space. At the tip,
At the tip, there is a small space.
no space or small space. And as you go towards the box, space will increase. Thambi, enne 3, 4 ella ratchet pottirkini. Ayyoppa. Ayyo, vandappa. I think his minimal count for force is esa. Even if he gives me a pat on my back, I will develop fracture, hemothorax. Shri Krishna will have to take me to his hospital. Okay? So number 2, to make it vascular, this clamp also I am sure, it will be touching only the tip. The rest of the clamp will be open. So rest of the clamp just brings 2 aortae together. Understood?
That is asked is if you go to if you are going to start a program in a tier C city, the guy comes to you with these instruments and then please buy this instrument. You want to check whether it
Is the mic on?
whether it is bad quality, good quality. I have come to sell you this instrument. You want to have a quick check whether it is going to be good or bad. How will you check?
The serrations.
All that, you have got to check.
He gives you 100 rupee note. You say no, 500 rupees I want.
One thing that you can always use, please, not just the paper, please remember, and this is being told, that you can put it in the, see, this is something beautiful that if I were to do this with the artery forceps, I would be
Screaming.
But see here, I can do this.
They were all, your students were
Well,
all hopeful.
hoping that
They were all hoping.
hoping that it
So
would.
I was looking at him. He was praying to God. He said, please.
So you
produce
see,
something."
it does not pain. If it is paining,
Tomorrow holiday.
if it is paining, you please do not buy the instrument.
So much so, this clamp is used on the acute margin of the RV. Okay? You hold it like this and retract
You will even lift it.
for showing the PD and terminal part of RV. So where have you seen this being used? That's a second standard question on every instrument. One is detail about the instrument. Number 2, where have you seen being used? Now you have to guide the examiner according to your wish. Understand? Huh? So you tell me, where have you seen this being used?
Aorta partial clamp.
For
Proximal anastomosis.
which aorta? Descending thoracic aorta?
Ascending aorta.
So why don't you say that? So proximal anastomosis in coronary arteries. Chalo, describe proximal clamp. Tell everybody. Ayo, mic madam. 500 rupees.
We have to ensure the BP.
On. Mic is not on.
You have put off. Very clever.
We have to ensure that the BP is adequate, basically systolic 100 by 80. We should not make sure that the BP doesn't exceed more than 130. And
You will make sure that BP is 100. 2. See, more you talk, more marks you will get. If you spend time in control of BP, how surgeon controls BP? By bleeding. So you would say, I make sure. So you said you will request anesthetist for low pressure. What else?
check
See,
for,
all your friends are telling you.
check for calcification.
See, what happens when they sit down, no? Blood supply start going to carotids. When you stand up, it goes into internal iliac. That is standard. One who stands doesn't speak. And one who are sitting constantly keep on prompting.
We have to check for calcification in the aorta.
Epi-aortic probe, etc. you will check. And yesterday we discussed which cases high chance of having calcification. What are those? Additional coronary artery
Hyperlipidemia
disease,
patient.
hyperparathyroidism, hypertension, diabetes, hyperlipidemic, redo cases, high chance of calcification. Okay? No, not there. You may do CT scan and make sure, not there. Third step, that is first step, second step is blood pressure, third step,
Third step is to ensure to compress the carotid.
third step,
Base,
you have to separate aorta from pulmonary artery. Fourth step, actual clamping.
you lift
Left
the,
hand
Left hand you lift the aorta.
or right hand lift the aorta.
So left hand you lift the aorta.
Left hand or right hand lift the aorta. Right hand lift the aorta and left hand clamp. Why left hand clamp? Not easy. This ratchet comes towards the head end and the surgeon's hands are free and assistant's right hand will stabilize that. Okay? Can you draw aorta and the parking lots for various grafts?
No parking board.
Reserved parking. Whole, you amma, I thought you will do that. Whole, this is aorta. ये क्या है? Sinks or not? Ayo amma. Show me the sites on the aorta.
So preferably we'll take.
Not, don't give explanation. Draw spots, name.
LED, OM and RCA, 3 grams.
He has given you the hints.
So we apply the partial clamp.
Heart எங்க இருக்கு? If this is the aorta, kundi இங்க இருக்கு. So where is the heart?
This down.
Heart is down. Apex is here.
So LA.
Where is the puncture spots?
Where will you put how does it guide?
What is this for?
This is for LAD.
LAD venous graft?
LAD venous graft.
Ayyo amma. Why is he answering like that?
Do you put the venous graft for LED normally?
Sir, we put elema.
So why are you saying LAD? And why you are drawing in the center? Draw it here. This is for OM. This will be for
LCS.
diagonal. And this side will be RCA. And what I am drawing, constantly showing you these lines,
Lie of the graft.
toe, heel direction. And this is OM1, OM2 will come here or OM2 will come here.
Sir, OM to go higher.
Very good. So OM2, all will go over the main pulmonary artery and then behind they will grow. Okay? You do off pump or on pump?
Off pump.
Off pump. You will do all the holes together or one at a time?
One at a time.
Why? Arey, why? If the nurse has given you knife, use it the knife, no? அங்க கேமரால சொல்லு அங்க பார்த்துட்டு சொல்லு why he says clamp comes out any day none of us have seen combined experience of 5,000 coronaries not a single time clamp has come out what are you producing when you produce partial clamping she will start screaming. You are increasing the afterload of the left ventricle. And the left ventricle is already damaged. Ejection fraction 25%. Left ventricle will strain. And what pressure will go up? She is under tension. I can see the sweating. Pulmonary artery diastolic pressure will go up. Rate will become slow. So what is the treatment in that case? Release the clamp. And suppose you have done multiple holes, then like a flute player, you have to keep fingers, 10 fingers on various holes. Start shouting, see the way she is laughing. So one hole, so in case you run into trouble, release the clamp and keep the hole closed. Okay? What are the complications produced by clamping?
Calcium is going to the carotid.
Very good. Carotids. Brain bolo na. Your Vitakari's name brain nirka. What are you shy? Why are you so shy of saying brain? See, all of you see this is how he's increasing the examination. Straight away say it will cerebral embolism, cerebral shower. You say carotid. Which carotid? Why are you see this is how you are increasing the work. Okay? Cholo, over. Thank you. Po. Over. 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 Just one question. Everything is what, 20 minutes or 5 minutes?
45 minutes time.
What you want to do now in the evening?
Disaster on CPT.
Disaster, same people. Same people, same talk. Only thing, one will be sitting like this. What is this? Show everybody. Tell me.
Right angle forceps.
Right angle forceps. Anybody's name? Mixter. Mixter. He was a war surgeon and developed this for looping the vessels. What first thing you will check? Look it there and tell me what is the first thing you will check. No. Look, they said tip, you said tip. Appadi panna kodadappa. See the serrations. This is traumatic or atraumatic? So mixture can be atraumatic or traumatic. Understand? So this mixture should not be used for clamping PDA, clamping pulmonary vein.
In lung resection, which side will you put this? If you have to clamp the vessel, which side will you put? You are doing a lung resection. Which side? I've looked the RPA or something like that. And which side will you put this? On the specimen side. Okay? Whatever you are going to discard.
Okay? By same rule, prepare for with a standard instrument, aortic cross clamp. What is the prerequisite for clamping aorta? Understand? So right from pressure on full bypass, pressure, everything you should be able to tell. And how do you know you have clamped it fully, clamped it properly? Remember. Okay? Side biting clamp, you open the aorta and you see atheromatous plaque. What will you do? Such questions don't have a definite, guaranteed answer. You open the aorta, side biting clamp, this case, and now there is a plaque inside. Localized plaque. For you, nice localized plaque. What will you do? Remove the plaque. And?
Give a wash.
Wash. And? People release some, give showers, remove everything, and again put it. So don't forget to hold the aorta in forceps during this time. If you only release, it will disappear. Okay? Last, Prasanna, with your permission, the dual clamp. Bolo. Where have you seen being used? What is so special about dual atraumatic forceps? Why the hole for? Prevent crushing. So where have you seen being used?
In the lung resection.
Lung resection on?
In the lung resection during lobectomy or segmentectomy.
Don't have to see, you are increasing the time unnecessarily. Lung resection I understood.
Any soft tissue handling.
So which side?
In the right.
Right part to be removed or the healthy part?
Healthy part.
You can put it even on the healthy part. Shri Krishna, correct? Even on the healthy part. It has got transverse serrations with peculiar serrations. See this, transverse serrations. And again same rule, beda. All of you remember, cross clamps, ratchets, just one adequate for that particular thing. You can always put extra, no problem. Okay? Can you use for removal of LA clot?
Yes, sir.
Not crushing, that hole helps you. But in LA clot, what you do, you don't use the ratchet at all. You just pick it. So use it as a forceps. Use the length for that. Okay? Thank you. Chalo. Prasanna, disaster. Arey Baba.
Debate, accidents are created, not spontaneous. Now, this is one thing which I always show people. This is a very famous water landing on the Hudson River. And you can see this thing, the plane has landed on water. You all have seen in the plane a water landing, no? What to do in a water landing, that card will become, that lady will announce, and all that nonsense will be told. So, but if you see in history, there have only been 3 water landings in the entire history, aviation history. And of this is the one which has been successful. And if you see how the plane, and you can see the plane has landed on water and people are being evacuated. There is so many things which have been done here, which have all been planned for in advance. Can you see how the plane, how people have been removed from the plane? They have been bilaterally, symmetrically been evacuated from the plane. Okay, if they had all gone onto one side of the wing, what would have happened? It would have tipped. In fear, people would have. So the rule is that in a water landing, the both sides should be open. But if there is, I will tell you, in New Delhi airport, one pilot was deroasted when there was a engine fire. And what happened is, when there is an engine fire, the pilot must never allow the door. You have heard, no? Door is armed. Has the door been armed and all that? What is that door being armed is that once it is armed, if the door is opened by the air hostess, the slide will deploy. That slide costs $100,000 to repack. And you cannot allow it to open on the side of the fire because people will go to their deaths. He was deroasted and fined and not allowed to fly for 3 months as punishment for doing that. So it is always important to do this. So if you see here, they had to take, this is the actual excerpt, minute by minute, of what was being done at that time. And as I said, see, there are only 3 water landings actually in history which were successful. And so it is very important that accidents will happen. But I will tell you, between all of us senior surgeons, how many dissections have we seen intraoperative? I have seen total 3 in 30 years. Sir, how many have you seen intraoperative? 2. Everybody will be able to count on your hand. But the time to learn how to deal with a dissection is not at the time of when the dissection occurs. So you must prepare for every dissection. And I give always aviation industry because it is safer to fly in a plane than to cross the road in Bangalore city. Really, fact, it is statistics I am talking. The actual brutal statistic, be it in Mumbai or Bangalore or anything, if you cross the road, you have a higher chance of dying than dying in a plane. And how do they achieve it? Repeated practice is required for low probability events. Your timing, and this is called as reaction time. Now in these things, one very important thing you must know, there is reaction time of the surgeon, there is reaction time of the anesthesiologist, the reaction time of the nurse, the reaction time of the perfusionist. All, in fact, in perfusion, in the final year exam of the perfusion, one of the things that we have asked them is to set up the pump, and we start the timer. In 3 minutes, if the pump is not ready, loaded, and it is every second that they take, points are cut for them. So everybody in the team should practice, and standard protocols allow coordinated response. So you can see flight training which is going on here in a simulator. We can do the same in wet labs in the thing. So simulation is a very important thing. And we can see it is very easy to do. I am not doing it here. All you need to do is have a bucket of water as the patient, and you can run the pump and you can do a whole lot of simulation. Now, I will give you many things, but these are some of the things which I am just going to show you. We have all seen, this is especially for the anesthesiologists, have isoflurane. Now, isoflurane and all these volatile anesthetics, if they fall on the oxygenator, and this has happened, you can see here what will happen when an isoflurane falls. We have just put it to demonstrate to you because you may not see these things. You can do it. Can you see here already the crack is starting to appear? Can you see there? The oxygenator cracks. What is the danger if an oxygenator cracks? Air embolism occurs. Now, if a crack occurs on the, so you can have air embolism, and it depends on which side it is pressurized. Obviously here, because the pump is pushing it in, it will actually have blood starting to leak here. Okay. So following protocols are very important, as I said, in a rare emergency. I said this is the actual photograph of the Air India where the bag was deployed on the side where the thing is there. And so how do accidents occur? A series of events occur, and this is called as the Swiss cheese theory, where an accident occurs because multiple errors creep up together and all of them align and to cause a mistake to occur. So you have to be able to interrupt it by having a series of checks and balances. For example, a standard this thing is when you give heparin, what is the important thing that is to be done? What is the protocol for heparin in your hospital? It should be drawn and then it should be injected back. I will give, and then what else is done? You put a timer and then what happens? And ACT. I'll give you a very beautiful example of what happened in Jaideva once. Neckline was put, everything was put, aspirated, shown that it is blood and put back in, but patient ACT never went up, not even one drop. Can you think of a reason? No, she drew and this thing, and then hypotension started occurring after some time. What had happened is they had actually punctured and it had gone, bleeding had occurred, a hemothorax was occurring, and then the thing was aspirating because the hemothorax was being aspirated and blood, and that is why the ACT was not going up. And we had a doubt actually, then when I asked, not even one, heparin resistance, and then when we just said, okay, let's see, and then opened the pleura, there was this much amount of blood there. And then we had to do the thing. But please remember, so checks and balances. The ACT, the final, today when we were students, we were not doing ACT so many. But today, I think it is a norm that ACT is done. So every stage, you have to have a check and a balance, check and a balance. But remember that sometimes things can go wrong and these things. So when do accidents occur? When do you think that in CPB, and how many of you have seen a CPB accident in your career? None. Okay. That just goes to show how low probability, how safe it is, but it is not necessarily so. And so most accidents in aviation occur during takeoff and landing. Similarly, most accidents occur in CPB when you are initiating CPB or coming off. And the general rule is, if you have a problem during initiation of CPB, what do? Come off CPB. Is one of the easiest things to do. Don't proceed. If you're just going on BPB, something has happened. I just got a call yesterday from one consultant who said that I'm doing a mixed procedure. As soon as we initiated bypass, my perfusionist did not say line resistance was high, but my anesthesiologist, they had a NIRS on, and he said that the NIRS has fallen, and so they immediately came out. Then he asked what could be the probable cause. I said, then they shifted over and did central cannulation, I think. Then I said, even though the line pressure has not gone, there must have been the initiation of a retrograde dissection. And so retrograde dissection must have occurred, and there will be no increase in line pressure. They came off. Then I asked them, before you this thing, please afterwards get a CT, and there was a retrograde this thing and a retroperitoneal collection. Luckily, when they did, it had sealed off and it was okay. Otherwise, we had to re-explore the patient. So this is how you have to be very careful. So this is a scenario. Now I am giving the thing, this is how to tell why break in protocol. This is a very famous movie called Suffer. None of you were born, I think, when this thing, but we all know this movie. And this was a classic, and oh, wait a minute, it is gone. Now, anyway, this is, hey, you've changed the file. It is some different file has come here. This is not my file which I had asked. I had actually got the movie, this thing. This is a very famous movie which was shot in KEM hospital. And the rule in KEM hospital is that you should always have a torch by the side of your, hung to your CPB machine, because in KEM, because AC is there and all, in those times, they had blackened out all the windows and the thing. The movie was being shot there. Somebody decided that it doesn't look good to have the torch there and removed it. And for the bad luck, current went off. Patient was on bypass. And actually, I had the scene of the movie. I don't know, everything is changed. Why I put the scene of the movie is the old CPB machine is seen there. And I wanted to show you Brown Harrison heat exchanger and other things there. But the patient died. Why? Because the torch is seen, the level was not seen. Some issues occurred and the patient ultimately died. And it has always been quoted. So finally, Dr. G.B. Parulkar chained this thing. I used to also do it in my hospital, where I used to chain an emergency lamp to always. But today, even they have the mobile phone and things addressing. So now, the first scenario we will talk of, pump is not ready and patient is arrested. There are two parts to the story. How do you prevent something happening? And once it happens, how will you do? Which are the patients where the pump is not ready and the patient could arrest? See, we have to get the holes lining up together. So prevent the hole from occurring, you be prepared for a patient who is this thing. Which is the patients? Severe aortic stenosis, any severe stenotic lesion, then left main, okay? A TAPVC, anything with significant obstruction can suddenly arrest. So in those patients, you see, now patient has, pump is not ready and patient has arrested. You give CPR. In severe aortic stenosis, you keep giving CPR till the end of time and no ejection. No ejection. Yes, now you have to, you are not giving effective CPR means the only option is to open and go on. Suppose, so you open and rapidly go in. What should the perfusionist be doing at that time? Getting the pump ready. How can, now I will ask you, you are going to Jumratalaya and you are from Jumratalaya and you have to go and there and you are, the perfusionist is a junior perfusionist and he wants, sir, what should I do to keep ready for the case? What are the things that you would like to tell him to do? What is done? You can flush and keep the thing with CO2. That is one of the fastest ways of priming. Okay? You can go on bypass with an unprimed pump with carbon dioxide in it. Okay? I don't know where the pictures are, but this is not the slide. So, this is where interplay between the skill level of the perfusionist and the surgeon. Remember, when you hire a perfusionist, you will not hire a perfusionist. You always are supposed to have two perfusionists. One, and remember, what is the other thing that you have to do is call for help. If you are a student and the patient arrests, what will you do? You will call for me. You will call for your boss. You will call. Nurse should call for senior nurse. Scrub nurse should ask for other hand. Perfusionist should ask for another perfusionist to come. So everybody should have help. Anesthesiologist, another hand, like that. Carbon dioxide, I said, and it can be put. Remember that you can have a carbon dioxide flushed system kept for 45 days, sterile. The moment you prime it, it can only be kept maximum for 7 days. They have done microbiological studies and a carbon dioxide flushed system can be kept for 45 days. In fact, in my hospital, for every op cap, they keep the carbon dioxide, flush this thing, and then after the case is over, they use it for a this thing, because there are a lot of student perfusionists and junior perfusionists, so we want to be safe. So we ask them to put the carbon dioxide flush pump, and then you use it for because multiple OTs are running and we can use it. Now, high line pressure. You are going to go on bypass, and the perfusionist says there is a high line pressure. Huh? He is telling high line pressure, so what are you going to check? Where obstruction? Please remember that a high line pressure can be anywhere from his end to your end. Your job is to check your end, his job is to check his end. What can you think of perfusion having a line pressure with nothing wrong on your side? There may be a clamp. Now the worst part is that I have seen is that there are many surgeons who put a clamp here and a clamp there. Perfusionist also has a clamp and you have a clamp. I actually prefer that the perfusionist has the clamp. Why? Because the less crosstalk that is there, the safer it is. And one person, when they say no, in one house there must be one yajmana. So if you have two, like for example, some people try to play tricks with the venous line partially clamping. I always say let the perfusionist clamp. Why? Because he is seeing the venous reservoir level. That's why I tell nurse must do nurse's job, surgeon must do surgeon's job, everybody must do their. I get sometimes I tell students don't do the nurse's job, suddenly try to do something, then that is how Gauss counts become wrong, things become wrong. Everyone must do their respective job. Then on your side, what are the possibilities? The clamp is there, but not there. Huh? Huh? It may be abutting. If it is abutting, how can you correct that? You can put a mural, you can pull it back, and then again you check. How do you have an idea that you have put it in an improper manner while putting it? See, I said no, checks and balances, checks and balances. What step did you miss in the checks and balances? No. Before when you put it in, what should you have done? Huh? Backflow ginta munche. You release and check whether there is a proper gush. If it is going tuk, 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 tuk like that, what does it mean? No. Tuk, tuk, tuk like that, if it is coming, it is actually abutting. And if it is pull back, it is this thing. Now if there is mural placement, that is if there is a dissection occurring, what are the signs that you will see? Let me tell you something. By the time you see bluish discoloration of the aorta, it is very advanced. It is a common misconception that you see the bluish discoloration of the aorta at the initiation of a dissection. Rather, the first sign that happens, and I have walked in and actually had people remove it, tie it, and put a new cannula in at that stage itself, is reservoir volume when you have already started the perfusion. I am telling you, put the cannula in and the dissection has started. The purse string starts, if the aortic purse string which was not bleeding before starts bleeding there, it is one of the earliest signs of a dissection. I have actually seen this, actually shown it, and actually had to take one deep bite and close the thing and prevented the dissection, took an alternate cannulation. Because I keep rubbing this in, that one of the earliest signs is purse strings which were not bleeding, starting to bleed after is a sign. Then later on, what are if on bypass, if it is happening, what would be the things? The RA will be empty and line pressure will be high. He will have, more than anything else, he will have reservoir level will keep falling. Remember that this story is not true in a if a retroperitoneal this thing in femoral cannulation occurs, because the retroperitoneum can contain liters and liters without the pressure. You all know, pelvic fracture, liters can accumulate. You've all done that, no? Pelvic fracture you've all managed in general surgery. Liters of blood can be there in the retroperitoneum without any problem. There will be no rise in pressure. So that is what happened. And I told you, just day before yesterday, I got a call, because actually around the world I do forensic audits of CPB accidents around the world. But I only do it for the surgeons. I don't do it for the opposing team. But then at that time they send me the files, I go through the thing and try to conduct a forensic audit of what went wrong during CPB. So they give me all the data. So you need to remember. So these are the things that I remember. And then another thing is that how many of you use straight cannulae? Straight aortic cannulae, yeah. So many of you are using EOPA nowadays, right? So now another thing is that you can have selective cannulation into one of the things. How do you prevent that? How do you prevent it? First is prevent it, then recognize it, then correct it. So how do you prevent it? I check the hub, check the guard. I measure. Do you know something? Medtronic has officially got a cannula which can be placed in the descending thoracic aorta. Day before yesterday, I actually had a patient with an arch calcification where we put a dual cannulation, one in the innominate artery and one in the aorta.
Sir, that mic missing.
One in the innominate artery and the other in the aorta. And why did we do this? We wanted, which is the most important structure in your body? The brain. You don't want embolization to the brain. So we wanted to pressurize the brain before the body perfusion starts. So we actually put a innominate artery cannula and then put a this, and then what? Under TE guidance we saw that the second cannula is distal to the thing, and we started innominate perfusion first, then we started whole body perfusion, and I think so that is not the thing. So how will you prevent such a thing happening? See, there you took a smaller cannula and a big cannula here, but how do you recognize if a EOPA cannula is abutting and you are going to end up in selective perfusion? Check and palpate both carotids. Both carotids should be there. Now, I go on bypass and then on a guide. You can pass a guide. You can see it. You can check it. The problem is, sir, now EOPA is also coming without a guide wire. Now there is a version without the guide wire also. Then the next thing that you can do, and as I said, the tip of the thing, unfortunately for us, what is the problem of monitoring the tip of the aortic cannula on TE? Actually, that is the blind spot. The aortic cannulation site is the blind spot of the thing, because the bronchus is crossing at that level, and so you cannot see properly. There are tricks available to be able to do it, and that which anesthesiologists can do. For example, instead of inflating air in the bulb, they can put lignocaine and they can image through that. But what I want to tell you is that unfortunately for us, the aortic cannulation site is not well seen. So you can do epi-aortic scanning and check, and if it goes distal to that point, you can check the thing. Okay. Then next, on table started perfusion. What is the way that you can now what is happening? What are the ways you can recognize selective perfusion occurring? One side will not one side will be having diaphoresis. If you have NIRS, you will have inequality of NIRS. If you have put NIRS, if you have not put NIRS, one side pupil will be dilated, other side pupil will be constricted. One side will be diaphoretic, one side will be flushed, the other side will be the same. So all those things can be said. So we have discussed now when in the case of a dissection, what is the most important thing that you have to do if you are suspecting an intraoperative dissection? Stop the pump. You don't want to continue having dissection. Now, what is the next step? You stop the pump. What is the next step? Now you have ruled out you are having a dissection. Now you have to get an alternate site of cannulation. Now I will give you a horrible situation. This is actually the first intraoperative dissection I saw in Jaideva. Patient is a CABG patient and is having aortoiliac disease and axillary artery disease. And I was lecturer, Dr. Prabhudev was there, and then what happened is we put the clamp and padang, the aorta dissected. Now, think I am giving you a really difficult situation and I managed it at that time. I'm telling no, axillary artery, this and all are this thing. There is a big poke there, there is a clamp sitting there, and he has made a hole, and suddenly everything has become blue, and actually bleeding started, everything started. We know that a dissection, my perfusionist is yelling that the thing. I'm just thinking out of the box because he alternate sites of cannulation. This is not a common cannulation, but I want to just stimulate your mind to know all the possible alternate sites of cannulation and how to deal. What was done at that stage? Can you think of a way? I can't do aortoiliac disease. I can't do, had carotid disease, had all peripheral vessels had issues. One was possibly a samurai technique could be done, but there was a graft sitting there already, so you can't do that. What we ended up doing is actually I took from the LV apex, I took a long cannula, pushed it through the aortic valve and initiated CPB, and then crash cooled the patient, and we did the surgery later. So what I'm... What is samurai cannulation? Samurai cannulation, there is a video actually on CTSNet of doing samurai cannulation in dissection, is that you actually put a venous cannula, and you tip into the oxygenator, you drain the patient. So literally the patient is being exsanguinated, and then you transect the aorta and you push the cannula under vision into the true lumen. I want to know which is the bigger lumen, true lumen or the false lumen? False lumen is always bigger and the true lumen is always collapsed. So in that, and the true lumen will have the white sheen, and whereas this will be blubbery and this thing. So you put the cannula in, and then you tape it, take a tape or whatever you want and snug it and initiate the thing. All those things, all head low, carbon dioxide, everything should be done. But it is, some people electively do it for every aortic, acute aortic dissection, samurai cannulation. Personally, I have done it a couple of times, but I will tell you, easier said than done, especially in a ruptured thing where everything is messy. You want to go there and exsanguinate, by that time that thing is flooding, and it is not as easy as it is said. It can be done, but it's a messy procedure. Now, okay. Now, your surgery is going on and the reservoir level has fallen. I have actually given you the presentation, so all these things should come pat now, because this is supposed to be a revision. RA level is falling. In fact, for our perfusionist, what I do is, I will just be sitting there for their perfusion training course. We put it, make it go down, 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 and if the patient, finally I clamp. You want to make it as miserable for the candidate, no? So finally I clamp, and what should what does the perfusionist do? You must know, because you have got to guide a thing. What will he do? He puts some fluid in. Yes, he puts in fluid, and then, but I am more nasty at this thing. Then he puts some more fluid in. Then and finally the level goes down to 1 centimeter. Correct. He will stop. He will warn you, and he will stop the pump. He cannot at any cost pump air into the. In fact, there was a perfusionist whom we have mandated in our hospital to always have a level indicator, because 2 times he has ended up thinking. Now, can you think of reasons why how do you now, what is your algorithm for managing a low, reservoir level? Perfusion is saying, I can't manage, sir. See, algorithms are a way to think this way, that way, this way, that way, this way, that way. You have to think. Is the RA full or RA empty? If the RA is full, it means it's your job. Venous drainage is not good. So what are the possibilities for that you can? You try to adjust the cannula, or you may have put 2 smaller cannula. And I will tell you today in 2026 we face this a lot because we have minimally invasive cannulae and you have got regular cannulae. The minimally invasive cannulas are extremely efficient and you can use much smaller this thing. Whereas if you are given that thick PVC pipes which we have no, with lighthouse tips and all those sort of things, you will see that you have to have, sir was asking no, what size cannula will you use? You must know the size of the cannula for the, how do they determine the size of the cannula? For arterial cannula? Let me tell you that the rocket engines, Annadurai was there. The whole of GSLV of Saturn V is a 1 rupee coin, and per minute tons of fluid are pushed through it. So a pump can push tons of fluid in it. So, but what determines the size of the aortic cannula? Flow is flow. I told you no, I can push tons. The gradient, why the gradient that is established for a given, which is the narrowest portion of the CPB circuit? The tip of the aortic cannula. What happens if the gradient goes up? You tell that cavitation occurs. Now, when cavitation occurs, what are the things that can happen? I always say, see, you must, even in the exam when you talk, you have to have a structured answer. Don't say hemolysis. Say, tell damage to formed and non-formed elements of blood. Formed elements of blood, RBC, hemolysis. WBC, inflammation. Platelets, coagulopathy and inflammation. And then in this side, albumin, protein denaturation, inflammation. Globulins are all your inflammatory cascade, coagulation cascade, everything. So you are going to have massive, same thing happens if the, what do you call it, your pump head is over occluded. Same answer, okay. When you talk of damage, you should think of all those things. So, checking, so there. Now if the RA is empty and this thing, what could be the possibility? Oversized cannula going and wedging, okay, then blood loss, where? I don't see blood loss normally in the field, no? Yeah, so it could be in the pericardium. Very often, especially in mixed cases, I am telling you now, that there can be blood going into the right pleura when you are doing transaxillary approach and all, and you have to warn the perfusionist, especially if they are junior. If you have loss of volume, please inform us. See, we are operating through small one, like if I am doing through an endoscopic approach, I am only looking through the endoscope and this thing. So if there is this thing, we will suck the pleura and whoosh, lot of volume, sometimes 1 liter of volume will come. Otherwise, he will keep on putting blood, volume, gymnium and other things. Okay. Now, please remember one dangerous thing. What is that if you are using vacuum assist, remember that the syringe pump, especially if you use I mean, we don't commonly do it here in India, but all the more if you use a biomedicus pump or venous assist, the entire this thing can be, syringe pumps can be sucked, and there have been cases where it has happened in Jaideva where a sodium nitroprusside has actually got sucked with a regular vacuum assist, okay. And sodium nitroprusside is sick. How do you recognize sodium nitroprusside? I saw my first sodium nitroprusside in a case when sir was operating a tetralogy of fallow, sweet little girl, and the perfusionist put a lethal dose of sodium nitroprusside. That is the first day I saw sodium nitroprusside poisoning in my life. How do you recognize sodium nitroprusside poisoning? It won't know, okay, vasodilatation occurs, but something happens in front of your eyes. In fact, sir diagnosed it on table, heat, not methhemoglobin. What happens? Suddenly, out of the blue, we suddenly noticed something, and we actually asked, at that time, we used to have these black syringes for this thing, and she could not see, And she has put, and then when we asked that lady, she said, I have put 12 ml of, 12 or 14 ml of sodium nitroprusside. It was a new drug for us at that time. We were not using it that much. We used to use myovin paste and nitroglycerin ointment at that time. So, but then nitroprusside, she had put a very high dose. What can you think can be seen? What can you on the table end see? What happens, what type of hypoxia is nitroprusside causing? What are the types? Is hypoxic hypoxia, like that, no? For first MBBS first term? Histotoxic hypoxia, histotoxic or cytotoxic. What happens with nitroprusside poisoning? Your cytochrome oxidase is stopped. So what will happen? What will be the color of the venous, what is the color of the venous blood? Became bright red. Normally, if in CPB, in which surgeries do you see the venous thing becoming nearly the color of the arterial side? And you are not concerned? Huh? No. No. In deep hypothermia prior to circulatory arrest. At that time, oxygenation extraction is so low that the arterial and the venous lines start matching. In fact, we do jugular oximetry and you measure, no? So, the blood became bright red. How do you deal with it at that time? What was done? I learnt it at that time. That was, I still remember to this day that. What do you think sir told immediately? I was a junior. I had no, was watching what he was doing. And it is stuck in my head. 30, I remember the patient's face. I remember the child was a tetralogy fellow. I remember him giving instructions at that time. What could be done at that time? You are having massive this thing. Today we can do 2 or 3 more steps. That time it was impossible. What he did is he told exsanguinate the patient and change the prime. We changed the prime so that now the cyanide levels immediately come down. Today in 2026, we have then correct acidosis, correct this thing, this thing, he did this thing, and we resumed bypass. What can also be done today in 2026 which we did not have at that time? Huh? Huh? What B12? Which injectable B12? Thank you. You did exactly told the wrong answer. It cannot be cyanocobalamin, you can give hydroxycobalamin because hydroxycobalamin today is commonly used for vasoplegia. We all keep hydroxycobalamin in the ring. Hydroxycobalamin will bind with the cyanide and become cyanocobalamin. Okay? You told exactly the wrong answer. You cannot use cyanocobalamin. So, another thing that you must remember is, okay sir, when we tell stop, we'll stop. One other thing, we'll stop, when you want us to stop, stop. Done. Only thing I'll tell you, overflowing oxygenator, last one. Jhalala, jhalala, jhaladhare. Which, so you say, how will I manage? How will I prevent it? How will I manage it? And what are the possible complications? So how will I prevent such a case? See, large heart, MR, AR, CVP 27, 25, 30, 35. How will you manage? How will you prevent it from happening in the first place? Yeah, you can take out autologous blood. In fact, in my hospital, I tell the perfusionist, anesthesiologist to take down blood 3, 4, 5 units. Yeah. So first is you can take out that blood and store it on the side, which you can give it back later. So sometimes we have, just to make it easier for the juniors to cannulate, I tell them, remove till the CVP becomes 15 because then next, vasodilate. 3, then what can you do? What is done? You can do retrograde autologous priming and you can go on bypass with a dry venous line and this thing. Then third, vasodilate, hemofiltrate, still the volume is still more. The perfusionist is saying, jing, 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 he's just gone on bypass, so time to filter, jing, 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 it is going out. What will he do? See, you do something, ragam, talam, pallavi. What will he do on his side?
First thing, don't forget to check the blood pressure, perfusion pressure.
Okay.
If the occlusion is not proper, the pump will just
Keep rotate.
and all the venous blood will be
Drained.
but nothing will be
Being. So here you are talking in terms of the
First thing, check perfusion.
pressure. Okay, then now what does he do? He can divert the thing to the, what's it? Okay, okay. Tell.
Now, at the outset, let me thank everyone, the faculty and the delegates. Lights on, please, lights on. Who have taken part in this 2 days intensive training program in this SCORE 2026. I would request Dr. Tendulkar, sir, can you come on stage once? 1 minute, I would like to acknowledge a few people immediately. One is, lights on, please. Yeah, I would like to acknowledge our Dr. Pooja, our cardiac anesthetist, who spent 48 hours almost with us non-stop. This is the first time in 12 years comparing is done by cardiac anesthetist. I am really blessed.
For tolerating us for last 48 hours. Anesthetist tolerating surgeon for such a long period.
I would like to call on Jaideep. Okay. I would like to call, sir, 1 minute. Jaideep is an AI master who helped us to do this study when the SCORE is going on. Now, for example, there's a 3-minute video which I want to show finally what they come down. Yeah. The team is from Gamma Group who have spent almost 72 hours with us. They had come down and made this. Can you put on the video, please? In this video, as I told yesterday, the avatar, what it has done, the outcome I want to show you, the VHD case, what you had taken, how human brain, if the diagnosis is known, and what it is. Just put it on, please. It is exactly 3 minutes, just have patience. After that, I will be completing the formality. Is in the ward with the patient herself talking.
ನಮಸ್ಕಾರ, ನಾನು ಡಾಕ್ಟರ್ ಹಿರೇಮಠ್,
Kannada language.
ನಿಮ್ಮ ಕಾರ್ಡಿಯಾಕ್ ಸರ್ಜನ್.
I want to
ಶುರು
show the
ಮಾಡುವ
report.
ಮೊದಲು ದಯವಿಟ್ಟು ನಿಮ್ಮ ಹೆಸರು ಹೇಳಬಹುದಾ?
ಮಗುದು ಸಹ ನಮಗಿಲ್ಲ ಇದೆ ನಂದೇಶ್
ಓಕೆ. ನಂದೀಶ್ ಅವರೇ, ನಿಮ್ಮ ವಯಸ್ಸು ಎಷ್ಟು?
ವಯಸ್ಸು 3 ವರ್ಷ
ಸರಿ, 3 ವರ್ಷನಾ? ಸರಿ. ನಿಮ್ಮ ಲಿಂಗ ಯಾವುದು? ಅಂದರೆ ನೀವು ಗಂಡ ಅಥವಾ ಹೆಣ್ಣ?
ಗಂಡು ಮಗು
ಸರಿ ನಂದೇಶ್ ಅವರೇ, ನೀವು ಗಂಡು ಮಗು ಅಂತ ಗೊತ್ತಾಯ್ತು. ಈಗ ನಿಮ್ಗೇನು ತೊಂದರೆ ಇದೆ ಅಂತ ಹೇಳಿ, ನಿಮ್ಮ ಮುಖ್ಯ ಸಮಸ್ಯೆ ಏನು ಅಂತ ನಿಮ್ಮ ಮಾತುಗಳಲ್ಲಿ ವಿವರಿಸಿ.
ಮಗುಗ ಇದು ಎಲ್ಲ ನೋವು ಸಹ ಅದಕ್ಕೆ ಬಂದಿದ್ದೀವಿ ಎಲ್ಲ ಎದೆ ಬಟ್ಟಣದ್ದು.
ಸರಿ, ಮಗುಗೆ ನವಸ ಇದೆ ಅಂತ ಹೇಳಿದ್ರಿ. ಈ ನವಸ ಯಾವಾಗ ಶುರುವಾಯಿತು?
ಅದು
ಎಷ್ಟು ದಿನಗಳಿಂದ ಇದೆ?
ಹೋದ ವರ್ಷದಿಂದ ಸರ್ ಹೋದ ವರ್ಷದಿಂದ ಸರ್
ಓಕೆ, ಹೋದ ವರ್ಷ.
ವರ್ಷ ಒಂದು
ಹೌದು,
ವರ್ಷ
ಹೋದ ವರ್ಷದಿಂದ.
ಒಂದು ವರ್ಷ ಆಗಿದೆ ಸರ್.
ಸರಿ, 1 ವರ್ಷ ಆಗಿದೆ ಅಂತ ಗೊತ್ತಾಯ್ತು.
ಒಂದು ವರ್ಷ
ನವಸ ಬಂದಾಗ ಮಗುಗೆ ಬೇರೆ.
ಸರ್.
ಸರಿ, 1 ವರ್ಷದಿಂದ ನವಸ ಇದೆ ಅಂತ ಗೊತ್ತಾಯ್ತು. ನವಸ ಬಂದಾಗ ಮಗುಗೆ ಉಸಿರಾಟದ ತೊಂದರೆ, ಜ್ವರ ಅಥವಾ ಸುಸ್ತು ಏನಾದರೂ ಆಗುತ್ತಾ? ದಯವಿಟ್ಟು
ಇಲ್ಲ
ಹೇಳಿ.
ಸರ್, ಏನು ಜ್ವರ ಪರ ಇಲ್ಲ ಸರ್. ನೀವು ಸುಮ್ಮನೆ ಇದು ಎದೆ ಬಡ್ಕೊಳ್ಳೋದಕ್ಕೆ ಆಸ್ಪತ್ರೆ ತೋರಿಸಿದ್ಕೆ ಇದೇನೋ ಹಾಗೆ ರೋಲ್ ಆಗೈತೆ ಅಂತ ಕಳಿಸಿದ್ರು. ಅದೇ ಆಸ್ಪತ್ರೆ, ಜಯಂತಿ ಆಸ್ಪತ್ರೆ.
ಓಕೆ, ಜ್ವರ ಇಲ್ಲ, ಮಗು ಸುಮ್ಮನೆ ಇದ್ದಾಗ ಎದೆ ಪಡ್ಕೊಳ್ಳುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರು.
ಹ್ಞೂ ಸರ್. ರಾತ್ರಿ
ಜಯಂತಿ
ರಾತ್ರಿ ಹೊತ್ತೆ ಸಹ ಜಾಸ್ತಿ.
ಸರಿ, ಈ ನವಸ ಓಕೆ, ರಾತ್ರಿ ಹೊತ್ತು ಜಾಸ್ತಿ ಬರುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರು.
ಹ್ಞೂ ಸರ್.
ಮಗು ಮಲಗಿದಾಗ ಅಥವಾ ಆಟವಾಡುವಾಗ ಈ ನವಸ ಹೆಚ್ಚಾಗುತ್ತಾ?
ಹ್ಞೂ ಸರ್.
ಅಥವಾ ಯಾವುದಾದ್ರೂ
ಹ್ಞೂ ಸರ್.
ಸರಿ, ಈ ನವಸ ಸರಿ, ಈ ನವಸ ಮಗು ಮಲಗಿದಾಗ ಅಥವಾ ಆಟವಾಡುವಾಗ ಹೆಚ್ಚಾಗುತ್ತಾ?
ಹ್ಞೂ ಹೆಚ್ಚಾಗಿ ಸರ್.
ಅಥವಾ ಯಾವುದಾದ್ರೂ ಓಕೆ ಹೆಚ್ಚಾಗ್ತಾ ಇದೆ ಅಂತ ಹೇಳಿದ್ರಿ. ಮಗುವಿಗೆ ಬೇರೆ ಯಾವುದೇ ಆರೋಗ್ಯ ಸಮಸ್ಯೆಗಳು
ಇಲ್ಲ
ಇವೆಯಾ?
ಸರ್, ಯಾನು
ಉದಾಹರಣೆಗೆ ಹುಟ್ಟಿದಾಗೆ
ಏನಿಲ್ಲ ಇಲ್ಲ ಸರ್, ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಹುಟ್ಟಿರೋದು ನಾರ್ಮಲ್, ಏನು ಆಗ್ತಿಲ್ಲ.
ಓಕೆ, ಮಗು ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ನಾರ್ಮಲ್ ಆಗಿ ಹುಟ್ಟಿದೆ, ಬೇರೆ ಯಾವುದೇ ಸಮಸ್ಯೆಗಳಿಲ್ಲ ಅಂತ
ಇಲ್ಲ
ಗೊತ್ತಾಯ್ತು.
ಸರ್, ಏನಿಲ್ಲ.
ನಿಮ್ಮ ಕುಟುಂಬ ಸರಿ, ಕುಟುಂಬದಲ್ಲಿ ಯಾರಿಗೂ ಹೃದಯ ಸಂಬಂಧಿ ಕಾಯಿಲೆಗಳು ಇಲ್ಲ ಅಂತ ಗೊತ್ತಾಯ್ತು.
ಇಲ್ಲ ಸರ್.
ನಂದೇಶ್ ಅವರೇ, ನಾನು ನಮ್ಮ ರೋಗ ನಿರ್ಣಯದ ವಿಮರ್ಶೆಯನ್ನು ಪೂರ್ಣಗೊಳಿಸಿದ್ದೇನೆ. ನೀವು ಹಂಚಿಕೊಂಡಿರುವ ಮಾಹಿತಿಯ ಆಧಾರದ ಮೇಲೆ ಮಗುವಿಗೆ ರಾತ್ರಿ ಹೊತ್ತು ಹೆಚ್ಚಾಗುವ ನವಸ ಇದೆ ಎಂದು ನಾನು ಗಮನಿಸಿದ್ದೇನೆ. ನಾನು ಈಗ ಹೃದ್ರೋಗ ತಜ್ಞರ ವಿವರವಾದ ಮೌಲ್ಯಮಾಪನಕ್ಕಾಗಿ ನಿಮ್ಮ ಕಾರ್ಡಿಯಾಕ್ ಶೀಟ್ ಅನ್ನು ಸಿದ್ಧಪಡಿಸುತ್ತಿದ್ದೇನೆ. ದಯವಿಟ್ಟು ಒಂದು ಕ್ಷಣ ಕಾಯಿರಿ. Now that was the history taking. Now I just wanted to show this. This is the end of, within 1 second you get this report. And if you observe this, I'll just come to the diagnosis, and the AI gives you 3 differential diagnoses, as I mentioned. And somewhere in these 3 differential diagnoses, the child had an VSD. When a proper history is taken with some more clinical data, definitely we will come somewhere near. This gives a vague idea. It's not that it's exactly this. This is just a beginning. So as days advances with adequate feedback, what we give to the AI, this is what innovation is happening. And because they did a lot of homework where I was not reaching to the correct diagnosis. When we came down with this after repeated clinical analysis, it has given a diagnosis which comes as an VSD. Certain red flags raised for alert of the surgeon, for example, resting palpitations, what has to be done, visit arrhythmia, and also a vague history of patients regarding requirement and emergency echo and all. So this is just I wanted to know where we have started in this core program shortly, and as days advances in the coming years, we will have a very clear digital twin with almost resembling the concerned person. So I thank the Gamma Group of companies coming up this idea, and I think they have really worked hard to do this job. And before end, I would like, as a part of completion, I would like to call on a student, one of the students, to just make a few minutes, 2-3 minutes. Rachita, who is Rachita? Come. So to talk few minutes, you should just introduce from which place you are and all. Hopefully not from Bangalore and around. So we just wanted your inputs on this 2 days core program with many new innovations in this program. I want your thoughts. Come, please come here. Take the mic.
Good evening, everybody. I'm Rachita from Jayadeva Hospital.
Wait, not Jay. Okay, Jayadeva. I want one more person, 2 persons. Please go ahead. Continue, please.
The 2-day program has been really academic, and we've learned a lot, more than what we normally learn during our daily practice. We went into the theory of things, and the case presentation really helped us understand in depth, and our faculties have been really helpful in guiding us throughout how to go. Prasanna sir has always been helping us.
Yeah, if people do not know, Dr. Tendulkar, the senior most batsman in the country, his student is Dr. Prasanna Simha's student is myself, and my students are already many, but here the budding student, I don't know where is that fellow, Adi is there, he is just in MBBS, wants to become a cardiac surgeon, he is there. Many of my students are already across country, so this is the lineage what we continue. In fact, before last year we had Dr. Bhattacharya also, who was the teacher of Dr. Tendulkar. I think last year somebody would attended. The continuous 5 generation students were here. So this legacy of teaching is a passion where we take along. So yeah, thank you. Come on. Other? I want Dr. Ashraf, please come.
Good evening, sir. Everyone, good evening to all the faculty, my colleagues. It has been...
you introduce from which institute, please?
I'm Major Dr. Muhammad Ashraf. I'm studying in SRMIST, Katankulathur, Chennai. I'm from Maldives, so if you want someone out of Bangalore, I think this is the furthest I can be.
Yeah, no problem.
So it has been a jam-packed session, a very academic session. I think a very concentrated dosing of the knowledge has been imparted to us. And all the faculty, they've taken us in a very nice way, like with somewhat of a jovial kind of way. They have imparted the knowledge. So I think it will be something that we will be remembering for going into the exams also. And I hope what sir has mentioned, that there's a 99% chance of everyone who attended this to be passing will remain true.
Also.
Yes, sir. Definitely, sir. Yes, sir. Yes, sir. Thank you, sir.
Thank you. I would request one of our cardiac surgeons faculty to make few comments. I would request Rakesh to come down because first time he's attending this program. Come. As a resident, I think he would have attended. I don't remember. Come, please come.
No, sir.
Yeah,
I passed out from CMC Vellore. I've never attended this program for the first time. But we've been following. It's very helpful for all the students. The knowledge in depth, especially 5 generations of teachers are here. Definitely it will help. I think this should have been more case oriented. We hurried a little bit in between.
Yeah.
Because we didn't end up till diagnosis. Operative thing has to be inculcated next time. More of theory which they can read. Practical is what.
This program has been modified by the feedback of the residents. The way we feedback, next year I modify accordingly. So what residents wanted, these are the weak points, we try to focus on that. That's how the program has come. That's why I call it dedicated operative session. I think that feedback again next time we'll add that. One full day. Then I have to extend the score program to 3 days then. Are you ready?
After 2 days, 1 full day operating.
But other 1 day it will not be sufficient then for that.
Let them present the case and then only surgery discuss. See, in the exam they have to describe the surgery.
Yes.
And surgery, it's complication. So that is very important because at the end of the day, we want surgeons who can operate.
Yes. Maybe we can extend, let me see if it's possible based on the feedback for the 3 days plan.
Less lectures.
Yes, sir.
I don't think we have to teach a student how to read a ECG or a echo or a cath at this stage. We can, and I told you, if you want, we provide them the document if they want to read, but is to refine themselves to go to the exam.
Thanks. Any other, we have Dr. Prasad, our radiology HOD, who last 48 hours has attended the program. Sir, please come down. I want to make a few comments. It's very unusual, a non-cardiac surgeon sitting for 48 hours in a cardiac forum, and he really...
I'm scared to talk. Sai Ram, with humble pranams to Bhagavan Sri Sath Sai Baba and our Sadguru Sri Madhusudan Sai. What made me to stay here is I could see all my teachers in all of you. As an undergraduate, when we heard my medicine professor, he mimics the sounds, S1, S2, S3, and he gives the murmur, the pre-systolic, that's mimicking that, how much he inspired that. My surgery professor, he never crossed beyond name, age, sex, and address, like what you have touched. Everything is an important part. And my gynec professor makes the board full with figures and everything. So this made me, they're teaching, the greatest teachers are here. And if I take in this the contest, all these students are for youth, and this is like a 20-20 match. In this 20-20 match, it is a perfect tie. But the extra mark goes here because the amount of enthusiasm with what they have shared their knowledge with all of you. So great marks for all our teachers. And I had the pleasure of staying in All India Institute of Medical Science in 1985. At that time, Dr. Sneha Bhargava was the director and Dr. Tandon was the neurosurgeon. So the amount of academic exchange of knowledge going in that, it is very, very thrilling experience. That made us to continue in radiology. Otherwise, till that time, I wanted to resign. Another thing what has happened part is, when Dr. Kakala Subbarao is our radiology professor. So when he has interviewed me to join in Nizam's Institute of Medical Science, Hyderabad, so at that time, Dr. Somarazu was there, cardiologist. So Dr. Subbarao asked me, Prasad, as a radiologist, how can we help a cardiologist? That is in 1984, 85, and we don't have much of that kind. But if the same question is asked now, sir, for this excellent program of your school, as a radiologist, I will give top priority either for bedside X-ray or bedside scanning or for CT or for MRI.
Thank you so much, sir.
It's an excellent, successful program. Yeah. Thank you very much.
Sir, just a minute. I request Dr. Tendulkar to hand over a memento.
Lots of quadriceps exercises.
There's a feedback form which will be released to all the registered delegates. You need to feed the feedback form about the score program, about this AI. So kindly feed that. Once it is done, then you will get the Karnataka Medical Council certificate number 1. Second is the Satyasai Notes 12th edition number 2. Number 3, all 2 days, whatever has been taught will be edited, and even that link will be given to you. That will be on the website. The website link will be given to you so that you can utilize these services. Next, I would like to thank our chief guest, Dr. Anadurai. I think he made a major impact on all of us. Even that will be on recording, and people who have missed, kindly go through that. And others, Sri Prasad from USA, who has supported us and helped us to bring AI into system. And Dr. Satish Bose from Durgapur, the chairman of the Mission Hospital. I would also like to thank the entire team of cardiothoracic vascular surgery who worked tirelessly for the last 1 month, the nursing team, housekeeping teams, and the event management team and the audiovisual team. I think the audiovisual team under Shiva's leadership, kindly stand up, sir. Really, you have really been working for the last 1 month. The entire audiovisual team, thank you so much. And flawless, a very good transmission. I would really thank. We have our from Jaydeva. We have our new cardiac anesthetist who has joined, Dr. Swarupa, who was kind enough, and she was here most of the times morning 6 o'clock to coordinate with the residents for helping them take cases. Where is it? Our Aditya is not. Can somebody call Aditya? And of course, all the deputy nursing superintendents and the group of nurses, Sister Usha, who was really dynamic to support us throughout. And we have our team of doctors, Dr. Madhuri, Nutan, Manasa, and all the CTVS team members. I did not mention. And we have our Sumant, Anji Naik, Mukunda, and our Avinash, Kavin. Many people are there. I am forgetting the names. Here we have our Madhvi perfusionist and Sneha perfusionist are there. So all of them together have supported to see that this program is really grand success. I thank each and every one of them. We have our manager Naveen and all. So I think after that we'll have a group photo with our team members. We can coordinate. I think with this I would conclude. I would ask pardon if I have forgotten anybody. But with this, I would thank my great asset, my teachers, Dr. Tendulkar, Dr. Prasansimha, Rajesh, and Dr. Sri Krishna, and others who would love Vinay Shukla. I would like to thank our Pranav, who is earlier a colleague of Satyasai, and he being a senior consultant, he is not a resident. He spent to revise the entire knowledge. I have few of the senior consultants who have come for this core program. One from Chennai. Sir, you are from Madurai. So they have come down. Yeah, Ashok from Apollo Chennai. He was there. He left. So they already with 15 years plus, but to want to revise the knowledge, to keep themselves updated, they are here. That is the drive to learn something, because learning has no ending. So that we should know, and how things have developed over a period of time. Okay. So I think with this, the tea is ready, sister. Hello, Susha. Hi, tea is ready. Okay. So we'll all stand up for the national anthem, sir.